So this morning, or actually today, we've got a little bit of a different angle. We have the surgical pieces where we're all going to talk about the different ways we treat these patients, but then we're going to start integrating. And we surgeons tend to live in a little bubble where we just do our stuff, and if the outcome isn't perfect, it must have been something we did, but obviously the rest of the pieces, the rehab, the mental health, just all the other pieces that go along with this to make success for these patients are what we're trying to incorporate. And how to understand these sort of globally. What are the things going on with these patients? One of our students, Chelsea, is going to present today at the Lunch and Learn. What she found was these patients that were hopeful and knew how to cope before we ever did surgery all had better outcomes than the ones who didn't. And so the mental health piece, all these other surrounding conditions and situations that we don't think about as surgeons are things that we want to incorporate because we want to deliver the best care for these people that we possibly can. Now, the gentleman on the wall here has been a mentor to me for many years, and we were hoping to have him here for his final hurrah, but he actually passed away just a few months ago. And this is Milan Dimitrievich. He was really a pioneer in restorative neurology, and he really drilled down on how does the spinal cord function in isolation of the brain or with limited connectivity to the brain. What is spasticity really? And if we understand this, how can we give incremental function non-surgically through stimulation, through other modalities and so forth? So we've got a little family of folks from him who sort of was a father to us all. And Boba Stokish was one member of that group that for years we would get together and learn from these patients and his experience and patients that he got who were so spastic they couldn't stand, and he would get them up and have them walking and really transform their lives. So the concepts that came forth from that were really transformative to us. They don't directly apply to surgical intervention, so we'll take it to surgical intervention after that. But I think it's important for this group to hear and understand what is this isolated spinal cord and how does it work. So I'm going to open this one again in prayer this morning. So thank you, Lord, for bringing this team together. We want to do a better job for these patients. We want to understand all the pieces they need to deliver the care and take the best care of them we possibly can. So thank you for your wisdom and insight and understanding. In Jesus' name, amen. Come on up, Boba. Thank you.
Okay, so I will move around a little bit because I will probably have to point out a couple of things on the slides as well. But for you to understand the context, of course, I don't know how many physiatrists are in the audience other than Jeff. Okay, I'm glad to see a few more. So I think this is not a big crowd, so I can be a little lower, so then trip over down. So the context, again, I'm a physiatrist by training. Back in the 90s, I came to the United States for a 6-month fellowship training, and I think here I am almost 35 years ago in the same country. And actually, I came to Dr. D's, how everybody called him, Dr. D's lab, as just out of residency physiatrist. And I have to say, in a way, I got brainwashed. And it's not only Dr. D that brainwashed, but it is the group of people working at that time in the lab, and many of those have gone to become very prolific clinicians and researchers after that lab. So the environment itself, I think, was very, very, I think, stimulating at that time. So after he told me I have to take these exams and go into clinic, and I did all of those exams, and at the end of the day, I had the opportunity to move to Jackson, Mississippi, to start a new lab over there, actually the whole program. And I think I really like that, and in a way decided to stay in research. For the most part, I realized there are so many good clinicians and physiatrists in this country. At that time, not as many good physiatrist researchers. So having this clinical scientific angle is what I think excited me more than anything else. So we got together with Dr. D in '94 for his 93rd birthday. And at that time, I asked him, so how about, Dr. D, if we put together the story of this complete spinal cord injury? And for somebody at the age of 93, you cannot believe how excited he was about that. So from that time, winter of '94, until actually last fall, we met every Monday over Zoom, of course, and I really tried to provoke him, and we exchanged tons of emails. I have so much documentation, really challenging him. What is this, this complete spinal cord injury, and how he understood it, and what he sees coming forward. So, despite this angle that it was really reflective on, in a way, how he thinks about it, the talk today is, I would say, my perspective on it. So, again, I'm not here to convince you about something, but I'm here to provoke your thoughts so that you maybe think slightly differently, perhaps, than how you were trained or how you envision clinical practice. So with that, these are the key points that I want to go over. As you know, spinal trauma results in heterogeneous spinal cord injury, but in viable and responsive sublesional circuits. Those circuits may be under supraspinal influence in complete spinal cord injury, which is the term he coined for this complete spinal cord injury. So the keywords is supraspinal influence. And then again, as Matthias said, Justin always puts the titles for us. So restorative neurology, I think as again, mindset, more so than anything else, it really involves recognizing those subclinical features and modifying both supra and sublesional circuits to improve motor function. So I think this talk, as you can see, follows very well what we heard or actually yesterday afternoon with Matthew talking about biomarkers, and I was particularly excited about Jack talking about those provocative cases, because in a way, this whole talk is about being provocative. So, needless to say, it's very hard to jump into the idea of this complete spinal cord injury without taking a little bit more, I would say, historical detour. And if I would recommend anyone who has to do anything with spinal cord injury, no matter profession, to really go back to some of these old papers, like the one published by Redoc. Of course, as you can imagine, this was the time of many spinal cord injuries as a result of the First World War. This paper is about 135 pages long, on which he describes a clinical course of 8 patients. The longest time observation period is actually 360 days. So it's very unique how neurologists could describe features very early on, but really projecting on the movement. So the key point of his work was that flexor spasms indicate complete cord transaction. And this was heavily influenced by Sherrington, as you can imagine. So that idea, in a way, it's almost like his observations were to validate Sherrington rather than being I would say, critical about what he is seeing. At the same time, we have to keep in mind that people were dying rather very quickly at that time as a result of spinal cord injury. So if we move fast forward to after the Second World War, this is again work by neurologists from B.A. Hines in Chicago, where he actually described that extensor spasms do not imply incomplete cord transection, but that it can be also seen in complete transection. So they also described that reflex pattern evolves over time, that initially it could be flexor dominant with simple movements, and then it becomes very complex. Also, that spasticity is more prominent in cervical injuries, and that it is independent of completeness. So that means both clinical and anatomical completeness. And of course, many of these observations were made with the help of surgeons who would actually verify and sometimes operate on these people and help verify whether the lesion was transected or not. So what we learned from that is that circuits below complete spinal cord injury are active, they are responsive, they are actually state dependent. And in one of those observations, not only that spasticity can go up, as you very well know, with the, for example, urinary tract infection or pressure sore, but actually as the patient gets sicker and sicker, as you can imagine, with sepsis, that those reflexes actually go down to the point that almost prior to death, there is no really any reflex function of the spinal cord. So this idea of transitional state of reflexes was not recognized very early on. And probably the most important, that output is determined by physiology, not necessarily or not strictly by anatomy. So this is actually I would say, what Dimitrievich knew at that time when he was a neurologist, young neurologist in Ljubljana, Slovenia. And when he actually had the opportunity to go and study in Sweden, working with Kugelberg and Granit at the time, being exposed to EMG. Ljubljana, Slovenia was very, I would say, prolific place. They built their own EMG machine. So he actually got into subclinical features very early on as a young neurologist. So immediately, as a result of that exposure in Sweden, he realized that there is more than what previous people observed, which means strictly movement. But the point is to look at the motor units and how the motor units behave in case of spasticity. So this is what I would actually summarize the most, I would say, influential work that he did with Peter Nathan from London in the series of papers entitled Studies of Spasticity in Men. There were 6 papers in that series. The first one is called Features of Spasticity, and this is what I'm trying to summarize. So what you will actually see, and what this whole story is about, that motor unit behavior is widespread, it's excessive, and it's not reciprocal. I think that's one of the things that Sherrington put out very early on and prompted people to think about reciprocity, but it was true, except that Sherrington did very reduced preparation. He did only antagonistic nerves and muscles, and that held true, but not necessarily if you have the full preparation, as it was actually proven even in animals later. The other point is that motor output is what they called idiosyncratic, that there is individualized pattern, and that it's reproducible. Now, by reproducibility doesn't mean that the output is the same all the time, but it can be scaled up and down depending on the input that the cord receives. And I think another point is that this, what we would call nowadays stimulus-response relationship, that it is very much altered, that there is a loss of local signs, which means if you stimulate certain area of the leg, for example, you will not get a local response as you know it. But also that flexor-reflex stimulation, such as, for example, stimulating the sole of the foot, is going to activate flexors as well as extensors. So it goes beyond what I think what Sherrington was actually teaching very early on about the spinal cord injury in dogs. The other, probably the most influential part of that work was that motor unit output is modifiable. And I think this is really what this talk is all about, that it can be intentionally generated such that if people try to move, they can actually produce output that is very similar to what you would recognize as spasm. That they can be internally facilitated, which means if people are asked to do gyndrasic maneuver, that output can be amplified. And that it can be volitionally suppressed, such as the instruction to relax can actually reduce motor output. So what they did a study in both complete and partial, or what we would call nowadays incomplete lesion. But I think the most impressive, I would say, from that series of papers is this illustration, where we can see that attempting the extension of the leg produces very similar motor output as subsequent spasm. Now, this spasm doesn't mean that it is clinical spasm. It can be actually very subclinical, only visible activity in the motor unit, so that there is no visible movement as clinician would perceive being a spasm. So I think what I take out of this work is the quote that in most respects, the features of spasticity are the same, whether the lesion is partial or total. This is really how they put it. So I think this idea that spasticity is not associated with the specific type of lesion is probably what influenced his work for the next 30 years. So after he published this series of papers, he moved to to Texas Institute for Rehabilitation Research in Houston, and then after spending a couple of years actually in a trailer, that's the story goes, that his first lab was literally in the trailer outside of the main building until they finally got the space. And as skilled as he was, he attracted attention of some people who believed into this concept and supported him through the Vivian L. Smith Foundation for Restorative Neurology, which established restorative neurology and human neurobiology at Baylor College of Medicine. So this is the department, actually division of the Department of Medicine that I came in. And by title itself, the most, I think, again, impressive, maybe especially from today's perspective, is the idea that neuroscience has to be combined with clinical practice. And it was very impressive because it was not only talking about it. There were people doing actually animal work. So side by side with people doing clinical research. So at that time, focus was very heavy on stroke, but nonetheless, it was the time when genes were being discovered as an overexpression after stroke. This department, I think, again, was the attraction point for many, many, I would say, contemporary clinicians and researchers, and certainly people who are no longer with us, so to say. So what I want to talk about now as the, probably give you the idea what they call this complete syndrome, which appeared for the first time in 1987 publication in Annals of Neurology. So in a way, the idea is that people, that those patients are clinically complete. At that time, there was no ASIA scale, all right? So that was still the time of Frankel scale when people were talking about, can somebody move the legs? So that was the main idea besides clinical completeness. What they observed that actually people can be neurophysiologically incomplete. And that's pretty much the idea behind the dyscomplete syndrome, such that people can produce, or we can record repeatable EMG in the leg muscles on different reinforcement maneuvers, such as you know, Gendrasic maneuver. It could be neck flexion. It could be shoulder shrug, depending on the paralysis of the patient. Also, the tonic surface EMG can be produced as a result of tendon vibration, whether it's Achilles or patellar vibration. And the last one is that there should be evidence of decrease in surface EMG activity during the attempt to suppress response to plantar withdrawal stimulation, as you would typically do for Babinski movement. So I'm going to share with you a couple of those slides. Some are kind of old as they appear in publications, but thanks to Matthias, I got some more contemporary records that are maybe more visible. So this is what would be in the original publication in 1987, the response to reinforcement maneuver, with the idea that those single motor units can be seen during the attempt to, in this case, it was a neck flexion maneuver. And you can see that it's reasonably, actually very, very repeatable, even though maybe a couple of motor units firing, but still they're consistently time locked to the onset of command. And that can be followed actually by much stronger output. How reproducible this is a slide which, this is a slide which shows that. So you can see the reinforcement maneuver when person will ask to do neck flexion from the supine position. And you can see that, again, the motor output is actually very time locked to the command to execute that. It's extremely reproducible in people. Actually, it turns out that it's more reproducible sometimes in people who are complete than it is in people who are incomplete. As a verification that there is no voluntary motor unit firing at the same time is the record on the right side, which shows pretty much no time-locked activity in any of the muscles recorded at that time. So this would be the first, what we know now as a marker of this completeness. The second marker is this command to suppress plantar stimulation upon provoking the reflex with a blunt probe over the sole of the foot. As you can tell, obviously in this case, it's a very reproducible firing of motor units time locked to the blunt probe moving along the sole. And after the attempt to suppress, there is actually much less activity. Whoever is in neurophysiology will always argue that this is nothing but habituation. And this has been really, I would say, a difficult point for them to overcome. Now, obviously, there are a couple of arguments that may not be so, because this is actually a recording that goes actually in series. So this is a real timeline. So what you can see is that it's very prominent response each time the probe is moved along the sole of the foot. But on attempt to suppress, it goes down immediately. There is no slowly decreasing motor output, which is typical of habituation. So that it is also not necessarily habituation, but at the same time could be indication of some kind of supraspinal preservation of input on those circles is the example in Asia D patient, who pretty much shows the same pattern and same responses, only that they are far more augmented. So that whatever we see in Asia A people doesn't necessarily differ too much from what we can see in Asia D, in a way trying to convey the message that this is probably it's very likely the voluntary supraspinal suppression of the EMG. And Justin, remind me again, lady who you sent to Macy. So we had the chance to talk to Macy last night, Matthias and I, and she just came to us and told us pretty much this story. Without being asked, we didn't ask anything. She told us this: I can control my spasms. I know how to do it. So in a way, it was a perfect, in a way, timely, I would say, validation of this idea. And she told us also that she is presenting as a Asia A spinal cord injury. So this is, I would say, reasonable verification of the idea that supraspinal influence can be exerted over the sublesional reflex circuitry. So the last component of this complete is vibratory reflex. And vibratory reflex can be induced by Achilles vibration, or in this case, this is patellar vibration. And what you can see is that it is actually tonic response. It starts and it lasts for the entire duration of the stimulus, and then upon repeated short vibration periods, it comes back. So of course, this one is not necessarily under voluntary influence from the above lesion, but the essence of that response actually lies in the work of excellent, I would say, neurophysiologists, both animal and human, from Australia, who actually documented in cat that it is the brainstem that controls vibratory reflex, so that it can be augmented with electrical stimulation of certain areas in the brainstem, more rostral areas, and it can be actually suppressed by stimulation of the more caudal areas of the brainstem. So that in itself is giving indirect, again, validation of the concept that being able to sustain vibratory tonic reflex depends on supraspinal influence. And again, Matthews, a couple of years before that, documented in spinal cat that spinalization abolishes vibratory reflex. So again, this is a, I would say, segmental response, but at the same time under the influence of supraspinal structures. So when you put all those three responses together, this is what at that time was and still believed as being markers of this complete in the absence of voluntary motor unit activation. So for all of us, we were curious what is the prevalence and what are the clinical correlates in a way. So the original study that put all this together was done by Sherwood in '92, where they reported 84% of the patient being this complete. Now keep in mind, at that time, to be almost part of the clinical research at that time in Houston, patients had to withhold medication for at least 3 days to really for that spasticity to come out. Once I was part of the group when we repeated study in 2004, the number of identified discomplete cases was slightly lower, somewhere in the range of 60-65%, somewhat less than this time. At that time, it was done at Houston VA, and the patients could not be asked to go down on medication. So this could be a reasonable explanation for the decrease in prevalence seen later on. There is only one, unfortunately, abstract when 2 physiatrists, as a part of the group, were curious about clinical features, because that's really what matters. Electrophysiology is nice for electrophysiologists, but at the same time for clinicians, can they identify some features of this completeness? And they looked at 3 things. They looked at spasticity, they looked at autonomic dysplexia, and I can't remember the third one, but the only one that came out as statistically significant was that so-called problem with spasticity were 3 times more prevalent in discomplete than in complete cases. So that gives us some kind of angle that probably if the patient is spastic, there is a chance that that patient is more likely discomplete at the same time. So that the 2 phenomena do go together. They may coexist. Whether they are causally related, that completely remains an open question. But I would say from my angle right now, I would say if the patient is clinically complete and shows a lot of spasticity, there's a great chance that you can actually activate the network below the lesion and have some evidence of motor unit activity. So at the same time, meaning 80s, I was told that Byron Kakulas on the left was the one who independently did a series of investigation as a pathologist, studying people after spinal cord injury from hyperacute within 24 hours of car accident and death all the way 3 months and 6 months. So he provided some evidence of neuroanatomy of complete spinal cord injury. So at the same time, Richard Bunge here in Miami project, he did independent study himself. So contrary to Byron Kakulas, he saw slightly lower prevalence of continuity across the lesion side, except that at that time, Byron Kakulas described it as only tissue continuity without necessarily pointing out to the parenchymal, meaning neural tissue continuity. But when they did a study later on between the 2 in patients who presented as clinically complete, anatomically complete, and they could separate anatomical completeness, meaning cord transection, as opposed to anatomically incomplete patients. So they came to about the same prevalence in pathological or in pathology material of this anatomical incomplete. So later on, Byron did additional studies looking at the size of the spinal cord tissue, having different, looking at different features, whether it's white matter, gray matter, connective tissue, and so forth. The most important part of this slide is to look at here anatomically complete cases that actually people who are anatomically complete can actually have a greater size of the white and gray matter compared to the lowest clinically incomplete. So again, it's not necessarily the size of the preservation, but it's probably very strategic preservation that makes somebody being complete or discomplete. And these are some of course, slides that were published, very impressive, I would say, of what the spinal cord can look like in chronic stages. So this is my rendering of additional Byron's results, where he was looking at the preserved fibers in the lateral pyramidal tract at T4 with respect to the rostral injury. So obviously, as you would expect, there is a huge difference in the number of fibers between intact and the patients. But what really matters the most is, again, this distribution, that the lowest number of preserved fibers in the incomplete patients can be lower than the highest number of preserved fibers in those anatomically discomplete patients, so that there is really no such correspondence, even when it comes to pyramidal tract, between the anatomically complete and anatomically discomplete. So now transitioning toward I would say, bringing this together, as probably neurophysiologists and a few more in the room as well, the question is, what are the physiological bases of this completeness? And again, the best model that you can think about is the model of Lundberg, who proposed that segmentally there is a premotor center, and that it is the premotor center where all these inputs are coming to before being delivered to the motor neuron. And that would very much conform to the idea that you can have very stereotyped output no matter what kind of maneuver you're asking patient to execute, because it is all going through the preserved tracts and landing onto the premotor center before being delivered. And here, conceptually, what we would think about this complete injury, that there is a decreased drive, there is a decreased gain, there is a decreased inhibition. As of recently, we also learned that there are changes at the motor neuron level, such as persistent inward currents that are very important after the lesion, at the same time that there is a change in so-called KCC2 receptor, which is again one associated with the appearance of spasticity, and as you know, that receptor supersensitivity is very common. Now, this fits actually very well also in with the idea of propriospinal tract, because to establish those connections between the cervical segments, as for example, Jędrusik maneuver, and lumbar segments being response in the units, it's unlikely that this is taking place through, I would say, very specific pyramidal tract or anything else. And as Peter Nathan also described in his work on humans, that majority of brainstem pathways actually end in the cervical cord and are being distributed through the propriospinal system. And the propriospinal system is the one that allows those inputs to travel between the two segments. And as you know, in cat work, this is actually the idea how the quadrupedal locomotion takes place, that between cervical and lumbar enlargements, the connections exist through the propriospinal system, allowing quadrupedal locomotion. So, so one piece of evidence that I want to say we added to the story, or at least I was curious how it would turn out, was borrowing the idea that if people were asked to do arm cycling, it was demonstrated that actually that can reduce the size of the H reflex between the static and the cycling condition. So this was done in healthy subjects by exercise physiologists looking at the actually connectivity between arms and legs in the context of walking. What I tried to, how I actually thought about this paradigm is what would actually happen if patients are complete. So what kind of findings would we have if we use this paradigm in patients who are clinically complete? And we did the study, and as you can probably predict, what we've seen, no difference between controls and clinically verified Asia A patients when it comes to responsiveness to arm cycling, such that arm cycling can suppress soleus H reflex equally in complete thoracic spinal cord injury as it does in the healthy subjects. So these patients were, I would say, acute, so available to us in rehab settings. I did not verify other markers of this completeness, but my point here is not, again, to propose yet another marker, but it is, again, thinking that we should be looking into subclinical evidence beyond what we know how the patients present on the clinical exam. So, slowly wrapping up, I would like to say, or at least propose, that this complete resolves maybe clinical paradox, that Asia A or Asia B patients can actually present clinically without voluntary movements and a lot of spasticity, but at the same time, neurophysiologically, they can present with all features of this completeness as originally proposed by Dr. D's group. Also, in a way, if you would think about reinterpretation of clinical completeness, as you know, on the left side, these are all classic features of spasticity as you would see in a clinic. But that doesn't mean that sublesional circuits are totally disconnected, but most likely they're dysregulated, they're underpowered. Also, that those sparse traversing fibers cannot produce maybe overt movement, but they can still excite or at least reach and influence sublesional circuits. So when you think about that it goes actually beyond our classic, I would say, spastic syndrome as we were taught and trained how to examine. So it's really looking at the level below. Now, of course, there are many open questions. That doesn't mean that this story has been resolved. So the question is, when does this complete emerge? Is it something that is masked by spinal shock, or it develops over time? If it is dependent on spasticity, maybe it takes time to develop it. How modifiable is it? Is it fixed state or something that can be changed? I think the most important is, should those people presented with this completeness, no matter which marker you take, should they be treated differently? Is it predictor recovery, or could it be useful predictor response to therapy? And I think, again, the most interesting for all of us is, can this complete become clinically incomplete? So is that spontaneous transition, or is it something that needs to be done with specific treatments given to those patients? So this idea of transition is probably the most, again, exciting one. If you look at the AGSC patient, what you can see that on deep breath request, neck flexion, that motor output is essentially no different but scaled maybe with voluntary bilateral hip flexion that AGSC patients can produce, at least rudimentary. If they cannot entirely flex knees and hips toward the chest in supine position, they can generate output, but that output is really no different than what you get with those other provocative reinforcement maneuvers. So to me, that tells us that maybe this gap between clinically, or actually electrophysiologically discomplete and clinically incomplete is maybe not that big. It's something that is missing addition of input that would be actually driven toward the voluntary movement. So the pictures do not look so much differently. So it is plausible that there could be an opportunity for transitioning people from this complete to very rudimentary complete. And if I were to do a study and maybe a clinical trial, I would probably pick people who are complete but electrophysiologically discomplete. At least that's a prediction. I'm not sure that this is necessarily true, but I think this makes sense to think about. So again, I said restorative neurology is about recognizing subclinical features and modifying supra and sublesional circuits to improve motor function. So if we have only a trace of supraspinal input that crosses the lesion side, the question is, what can be done to engage and enable those sublesional circuits to generate essentially movement? And probably the most likely answer is neuromodulation. And for me, nobody owns neuromodulation. It's a broad open field, and it does include biological, pharmacological, electrical. In the rehab world, we believe in activity-based neuromodulation, but of course, surgical as well. So I think this is I would say, a concept that holds across many disciplines, and it's very much applicable to restorative neurology. So here I want to show a couple of slides that electrical neuromodulation with epidural stimulation can actually modify sublesional influence. This is a work done by Dr. D at the time when he was very active in Vienna, the program from which Matthias came as well. And what you can see here is that the output is amplitude dependent, but also frequency dependent. What is the most important is observation that with certain combination of intensity, and frequency, you can see a reciprocal output as a result of tonic epidural stimulation. So that it is the settings of the stimulation that are producing output to be one way or the other. And I do not have the video, but also there is a video recorded where a patient with epidural stimulator can actually produce reciprocal movements. This work was taken a step further, I would say, by Susie Harkema's group and Gerasimenko, Reggie Anderton as well. So where they used epidural stimulation to augment spinal output, actually enable voluntary movements. So the existence of voluntary movements with stimulation can be seen on the last trace here, which is force. And what you can see that under the influence of epidural stimulation, those patients were able to produce dorsiflexion and plantar flexion. So there is opportunity with electrical neuromodulation actually to induce movements in the patient who cannot do it on their own. This is again I would say, a review paper, very, very elementary review of so few trials. But the point here is how should we think about epidural stimulation? Is it simply prosthetic effect? If you give enough epidural stimulation to multiple muscle, I guarantee you can make anybody stable enough to sustain upright position and standing. So the question is, at which point can we go from using epidural stimulation to be prosthetic effect as opposed to therapeutic effect, meaning that that the activity during stimulation can be sustained in the absence of stimulation. And what you see here is a situation that there is a lot of prosthetic effect that can be done across different severities of injuries. But once the stimulator is turned off, it really stays in the space of C and D, and very few trials have seen something in Asia B patients. So we are not there yet, so to say, but there is an opportunity to consider those neuromodulatory techniques to be moved actually from this space of Asia C and D into the complete injury. So to close it, I have 2 slides to talk about neurosurgical implications. As you know very well, and that's what you probably practice every single day, when it comes to acute injury, it is preservation and protection, the most important part that can be done right now. Preservation and protection is, of course, considered something important at the lesion side, but think about that being actually how that applies to translesional pathways and circuits. And as you do that, I would say assume that residual connectivity exists even in the complete spinal cord injury. When it comes to chronic injury, I think I would suggest to leverage and modify residual pathways. That this is probably, in a moment, this is probably the strongest approach to do it. And whether you do it surgically through central neuromodulation, meaning really going into the brain to activate, augment supraspinal input, or you're doing peripheral, even neurotomy. So all of those things are actually very valuable tools to change the circuitry. But the most important message, perhaps, is to point out that the effect may extend beyond local targeting. And this is something, again, that in a way Jack was talking about. So the spinal cord is not really only reacting to what you do to certain segment, certain nerve, but the input that you are withdrawing or adding through the procedure has widespread influence. So think about your local targets or procedures being done locally, but what are the broader implications of that? And my takeaway is to think about when you see a patient with clinically complete injury, keep in mind that you are likely not operating on disconnected cord. That nowadays, I'm talking about nowadays when we have so many contusion injuries primarily, that it is really unlikely transected cord. And that this complete spinal cord injury, actually, you can think about it as a model of residual connectivity recovery potential, at the same time a therapeutic opportunity. Now, of course, the last points are maybe more practical, and the first one is, to me, spasticity is a sign of life. So treat it with respect. And I think I have to say in this country there is a tendency to overtreat spasticity. That's at least my observation. So think about not going for the most expressive feature of spasticity, because to kill that extensor spasm, you have to do so much, you have to have such an effect on all other circuits before you can actually kill that extensor spasm. So you're going to make the cord totally quiet. That's probably not a good idea. And I think instead of that, I would propose to focus on augmenting and enabling residual circuits, because this is probably more likely successful direction, which we'll have to do nonetheless. No matter whether you come with serial bullet for spinal cord injury, there is no way that protection and preservation can fix the problem. People will start, and they are already successful in adding cells, replacing cells. They're also successful in regrowing axons. But at the end of the day, you will have to deal with sublesional circuits. And that means that you will have to rewire those circuits. You will have to use rehab as an activity-based therapy to reestablish the different behaviors at the end of the day to regain function. So this is actually continuity. And I personally, Matthias and I both belong to the Department of Neurosurgery, which is, I think, very exciting to us, because I think we can talk much easier to neurosurgeons than perhaps neurologists about all of these problems. So I think this idea how the recovery takes place from preservation and protection all the way to rewiring and actually relearning behavior to rehab probably is the most appealing way how we can get closer to improving function and lives of people with spinal cord injury. So I thank you very much for your attention. Appreciate Justin the opportunity, and very proud to be able to give this talk about Dr. D. Thank you.
Thank you, Dr. Stokic. That was a marvelous introduction to our first session today. Now the second speaker will be Dr. Brown, the organizer of the meeting, and he will give us an overview on the pathology of spinal cord injury and implications for limb reanimation.
So what Bobo just shared is really kind of, we've known it for a while, but it's really a new concept to a lot of practitioners, because that spasticity works in an inverted U-shaped curve. That is, a healthy cord has little, a completely disconnected cord has none. But if you have severe spasticity, there is connection through the cord, and sometimes there's something modifiable and usable in there. And so when we go and we put backup pumps into folks and we completely shut them down, sometimes we're shutting down potential. And what these guys used to do is find that potential, use stimulation, other modalities to be able to activate it, get them to stand, to get them to take steps, and so forth. So what I'm going to do now is talk about how this applies to reanimation of the hands. And so the system I'm going to talk about is a little bit simpler than the cord below the lesion. The cord below the lesion, you're talking about an entire computer that knows how to walk. I'm talking about the nerves that operate the arms and hands. And the nerves that operate in the arms and hands, they really require a lot of cortical control. So to imagine stimulating to get them back, it's tough. You can get a little bit back, but we really want a nerve to be connected there so they can automatically turn that on and off and do activities of daily living. So when I think I'm going to have to do what you did and walk around here. Yep. So when we think about an injured spinal cord, there we go. An injured spinal cord, the area of impact right here loses its gray matter. And if it loses its gray matter, it loses its motor axon. If it loses its motor axon, the muscle connected to that degenerates. And so we have the same situation we have with brachial plexus injury. So at that site of injury, we've got a ticking, a time window that we need to address. If we ever want to get those particular muscles back, we want to fix that within a year. I think you can do up to 9 months, and I haven't lost anything from 3. But there's also that idea that there's some descent of function in the first few months after an injury, really even up to 9 months. And so I like to wait on these folks and see what's going to happen, because they're going to gain, they're going to breathe better, they're going to get off the ventilator, they may start recovering some wrist extension. So we want to see where they plateau out, and then it's time to jump in and not waste much more time if this is the problem. Now, how do you discern if that's the problem? And how do I advance on this thing? I got to plug it up. How you discern if that's the problem is how it responds to stimulation. So, you know, our upper and lower motor neurons here. The lower motor neuron, if you cut that, that goes away, the muscle's denervated, and after well-layered degeneration completes in 2 weeks, it will not respond to any stimulators we have in the US. It has to be a really high power, long pulse width, it, like Armando was talking about and Matthias was talking about yesterday. But standard stimulators, you put it over the muscle, you crank the thing up, if it doesn't move, it's denervated, and your time window is short. If it moves, and the injury is up here, it's an upper motor neuron injury. And it will definitely respond to that, because you'll have the axon. So it looks like an avulsion injury. We've got sensory axons throughout that thing. You can run a sensory nerve potential down there. If you cut the nerve, you look at it in histology, there's all kinds of wires in there, but the muscle doesn't respond, and it's because that gray matter got destroyed. In the area of that, a lot of folks have gone in there and said, well, all C5s look like this and all C6s look like this, but they're all based on the type of trauma they had. So if it's a small disc herniation that resulted in a complete Asia A, this patient can probably get surgery 20 years later with nerve transfers, and it's fine because the gray matter is for the most part intact there. If it's the gentleman on the right with the burst injury, there's a lot of hemorrhage within the cord there. You've destroyed gray matter over several segments there. Those arms are going to atrophy, and that window is going to close for nerve transfers shortly thereafter. So we need to get in there and figure out which patient it is. And this is the simple way. The neurologists probably don't love this one because it's a dumbed-down surgeon's version of neurophysiology. But we take the stimulator that we use in the operating room to see if the chemical paralytics are working, and we just stick it over the muscles of interest and crank it up. It's uncomfortable, but it answers our questions quickly. So we come in here and put this on the back of the arm and turn it all the way up, and up come the fingers, and you can grade the MRC strength. This is the potential that patient has. I don't care if it's been 1 year or 25 years. If they do this, the nerves are intact, and we can connect another nerve to them and get it back. And then our dramatic effect, this guy has the opposite. So we hook his stimulator up, and we turn it up all the way, and nothing's twitching. If we want that to ever move again, we need to move a tendon, or we need to transplant a muscle from the leg, but the window has closed if we're beyond 1.5 years to do nerve transfers. And so if they come in and the arm looks like this, it's tendon transfers. A nerve transfer is not going to work in this patient. He has a cord that's damaged over many segments. The only muscles available are the ones you can clearly see through the skin here. He's got a pronator, he's got a flexor carpi radialis, he's got his wrist extensors, and the hand is denervated. You can see the wasting in the muscles. It's too late on a patient like this to do nerve transfers. Tendon transfers are the answer, and they're good. We're going to hear about how good tendon transfers are. I'm a little biased towards the nerves. So in the chronic patients, we want to make sure we have a good nerve above and a good nerve below. And this was the trickiest part for us. Rasa's talk yesterday was about, hey, even though you have a strong muscle, it doesn't mean it has a lot of wires in it. They may have sprouted and created massive motor units to compensate. So it looks strong, but when you actually transfer it, there's not that many axons in it to be transferred, and you get a compromised result. Similarly, the area below, you stimulate it, it moves, but you want to do that stimulation, feel how strong does it move, because that's all you have access to. If it barely twitches, all you're going to get after that nerve transfer, no matter how many axons you send down there, is a minimal twitch. So you got to see how robust the target muscle is. And there are a little bit more sophisticated ways of doing that. So in that case, we're doing an axon exchange. We're taking the spastic axons below. They're connected to dysfunctional spinal cord that the brain doesn't talk to, but they're there preserving the muscle all along. They can be activated with standard stimulators. The muscle moves. And so you're taking the ones connected to the brain, you're cutting it, you're then sending it down the pathway of the ones that were not connected to the brain and growing those to target. And so our friend Macy, I don't know if she's here yet, but this is her beforehand. And these patients, a C5 injury, no triceps, her arm is swinging and hit her in the face. She has no finger movement. And she was, unfortunately, a long segment injury, and none of these muscles stimulated, so we needed to get to her within the 9 to 12 months window. And we did, and that worked well. And then the concept is we need to take something with redundancy above. So we need, with the external rotators of the shoulder, we have 2 of them. If the infraspinatus is good, the teres minor is available, we can send that to the triceps. So we take our C5 muscles, we send it to our C7 target, and we do that within the window. So those are the concepts, and of course, if we can give these people an increment of function, their independence moves dramatically. So you have a patient who has some elbow flexion, they need assist all day long. As soon as we get them the ability to open and close the hand, they have all kinds of independence and things they can do all by themselves. So it's a major change in their quality of life. And the next step is going to be that our diagnosticians telling us how to figure out who's a candidate and who's not. So thank you. Yes, sir. Yes, Bassam, you made it. Looking good as usual.
Hello? Can you hear me?
Morning. So, Justin, in brachial plexus, we understand, like they have certain time and they end up in your clinic. Traumatic brain injury, they're different because
Yes.
it takes so long to get them. And I was, with my naivety, I was under the impression they're traumatic upper motor, they're not gonna need what you're talking about. Now I understand what you're talking about, the combination. We saw a lot of them, me and you. What can you do to get this patient to see you before that timeline, before you cannot do anything for them? Because usually they come late. You get the brachial plexus, but traumatic, they don't come early. What do you do to get them if they have a combination that you can help them with?
It's tough, honestly. I never got a whole lot of cooperation from the physiatrist. The therapists were wonderful, the physiatrists were not. So I would actually go over to Spalding and around with them on the inpatients and start telling the patients we can do something. It's a huge time investment. I quit that later on, but everybody spends their time telling the patients there's no hope. And so they finally internalize, all right, I'm going to live like this. And then you go try to sell them hope 6 months later, and they're like, get out of here. I just dealt with this. I don't want to revisit the idea that there's hope because I've just come to terms with the fact that there's not. And so it would be great to have that collegial.
My other question, among your patient, what's the percentage of patient that they have this combination, like the patient that they will have either pure traumatic versus traumatic or an element of nerve injury that you can reconstruct? What's the percentage you think in your practice that you have this patient that you can do nerve reconstruction on among traumatic brain injury?
In the chronic phase, I would say more than 50% have some availability. I mean, 60, 65, it's, but there is a huge subpopulation that just are not available, and we've got to do bigger work, but yeah. Thank you. So, can you guys?
So we have time for discussions. Any more questions? Yeah.
Hi, Dr. Brown. That little SDMI device, I think it was called, is really cool. I've never really seen it used in the hospitals as a physiatrist who was frequently in the ICU. And I was wondering, what percentage of spinal cord injury patients are coming down with brachial plexus avulsions that are going undiagnosed?
So concomitant plexus injuries?
Exactly.
Yeah, I think there's a good subset. I have no idea what the number is because honestly, people don't look for it.
Right. So
Yeah.
the fact that we pick up on the major ones, but
Yeah.
We basically just do it by doing a very quick exam, and normally that's about 3 weeks later after they've woken up. It would be nice if that was kind of a standard protocol where we could use that and find out, okay, they have a spinal cord injury. Most of the imaging in these places aren't going to pick up on micro avulsions and micro problems with the brachial plexus that probably need more aggressive, ways to address it from a neurosurgical standpoint.
Yeah, and it's a tough because there's not an easy screening because most hospitals do a crummy job at doing a brachial plexus MRI.
So the question is then,
Yeah.
what protocol would you recommend in developing and getting an easier?
Well, we need Dr. Peckett at every
Right.
institution to make sure they get a proper MRI of the brachial plexus. But yeah, unfortunately,
So, yeah.
they get these really thick cuts, and you look at it, and they read probably fine kind of thing. And so, what's the physiatrist supposed to do? I mean, you can do it by you look on examination, you see the legs aren't moving, and the hand on the left isn't moving, and the entire right arm is not moving.
Right.
And they say that's a weird asymmetrical spinal cord injury, and they treat them like a spinal cord injury, and maybe much later on you finally get triaged.
Yeah, I mean,
Yeah.
the way I look at it is it doesn't have to be, highly specific, but it could be really sensitive.
Yeah.
Maybe I'm always flip those two around, but you know what I mean, in terms of we cast a bigger net, so we're
Yeah.
gonna have some false positives.
I mean, ideally, they just send all of them to us, at 3 months. I'll sort it out for you. You don't even have to do the work. Just anybody who doesn't have arms and hands working well, send them over. We'll work them up and tell you which one could benefit from surgery or which
You're
one
gonna
should
be
wait.
outside that time frame from acute rehab. By the time they get in acute rehab, they're gonna be at least 3
Yeah.
weeks out, if you're lucky, and then acute rehab's gonna hold on to them, depending on their insurance, for at least 2-3 months minimum.
Yeah.
Or even worse, they end up in a skilled nursing facility, and then they're gone forever. So. that's
Yeah,
the-
and there's that dichotomy. So the pure upper motor neuron injury that Boston was talking about, I don't think anybody should touch them until a year has passed at least. But when you see there's a significant lower motor neuron injury, it's time to move along quicker. But as long as they know that we're going to make that distinction, and I'm not just going to cut when they send the patient over, hopefully they have a little more comfort to just send them and have us work that up.
Sounds good.
Yeah.
And I will talk a little bit about this this afternoon. So I'm from Sweden, and we travel as the specialized units. We travel to all the SCI units in Sweden and see all patients at 3 months, 2 months, 4 months after injury, and give them that hope. And
I need a partner like that.
you have to do the work and get to know your SCI units. That's the key. Any other questions?
I have a question for the Discomplete. Do you have a practical way to look for that in the clinic, for example, or is this a surface EMG technique to try to distinguish those things? Or are you looking at extensor spasms, or how do you approach somebody?
I think your best bet is taking time with the patient. That's
Yeah.
what I think Dr. D would teach us, that you cannot do it in a fast-paced clinic. So I think vibration, actually we do have, looks like a car shop tool that we can use in the outpatient clinic. You don't necessarily have to put the EMG electrodes, because you can see tensing of the muscle
Sure.
upon the stimulation. I think the opportunity lies in the other two markers when you ask patient to voluntarily suppress. Now, voluntary suppression has nothing to do with the plantar withdrawal reflex, because if you prep your patient enough, and that, just like we heard yesterday, patients know how, or patients should be taught how to control their spasms. So I think setting up quiet room in the first place, having patient relax, and then trying to provoke spasms, and then telling patient clinically, you can control it. Now, this is beyond just, I would say, psychological factor, because there is a physiology behind. So I think your opportunity lies on this voluntary part with the patient, whether you want the patient to provoke some sort of activity with Gendrasic, or you want to ask patient actually to relax in the presence of very exaggerated tone. So you can do it clinically, actually. And I think Dimitrievich was very successful in that by taking time. And the most important thing I think that we are overlooking is we have to go away from examining patients only in the wheelchair, because that's how they roll into the clinic. And we have to also not examine patients only supine. So this idea that you can actually change the postural reflexes by having patients supine, prone, sitting in a wheelchair, and being asked to do different things, you can do a lot, actually. So, because keep in mind, his initial observations were not done on motor units. They were clinical observations that he then documented using motor units. So I think it comes down to the skill of the examiner and taking time. That would be my perspective.
Okay. Thank you.
I also have one reflection on that.
Yes.
I would just try my thoughts on here. So I was intrigued about the breathing, that it's a deep breath would trigger it. And when I see my patients, the really skilled patients, that before they do a transfer, they take a deep breath.
Yes.
And I always thought that is to get core balance, to fill the lungs up. But maybe they also get some tone in their lower body.
Exactly. So I think yes, I will.
You're right. They can move and they can take deep breaths and a little bit
So we have yeah, go ahead.
Learn anything that can change their tone will affect their spasticity and how it reacts. So they can do like mewing and different type of breathing techniques and can totally control
Yeah.
the amount of spasticity that's going on.
But I think I have only told them to do that to get core balance. But of course, it makes sense that it
But
also get
their
more
balance
tone.
is getting better because they're modulating their tone when they take the deep breath.
Yeah.
So this is I believe correct observation, because any change in postural demand is actually being done through, if I have to pick a pathway, it would be lateral vestibular spinal pathway that is directly connected to the extensor motor neuron pool. So I think you are modifying in some way brainstem influence. I think the one uncomfortable thing about it is what we have never had a chance to study. But the question is it so that in some patients you actually do something through the sympathetic system, through changing the pressure, deep breath? So there is additional piece, I would say, of this completeness that exists maybe on the autonomic side that we are not able to recognize, but maybe we actually see it through motor unit recording. So I'm not trying to say that this completeness exists strictly in the somatic system, but it may exist also in the autonomic system and have some contributions to what we are observing. So I think that's true. Shoulder shrug is another one that patients can actually do if they're very high completes that they cannot do anything with the arms, that you can sometimes ask them to do shoulder shrug. So all of that is actually changing postural reactions, and that can have effect on the extensor tone. And that's why maybe they are more able to sustain transfer. So,
Thank you.
yes.
Any other? Perfect. A cliffhanger. Perfect. Okay, any more questions, or we close this session? Thank you.
So I think we're going to move on to our diagnostic session. So is Jeff Sheehan? Where's Jeff? Ah, you are here. Are you ready? Or do you want us to jump into imaging first? Jeff had a lecture thrown at him last night from Ross Mandeville, who left early. So, but Jeff is actually the originator of the quantitative neurophysiology. He's the guy who trained Ross, so it's actually appropriate for him to give it. You want to do it now? So Jeff Sheen is a neurologist, neurophysiologist who was my partner in San Diego. He was probably the main reason I even took the job. It was like, this guy thinks like I do. We're going to work together. So, I'll walk it over to you, Jeff.
Yeah, I'm going to have to stand up here, I'm afraid.
Hit presentation.
Oh, yeah, it's not like, this is not, because I've got all the wrong software.
You're on.
I'm on. Okay. Well, good morning, everybody. Yes, as Justin said, and I told Jeff yesterday, poor old Ross was called urgently away to attend a, oh, is that better? Oh, yes, he was called away to attend a luxury spa resort in Palm Springs. And so he asked, or rather imposed this upon me. So, so this is mostly about assessing donor muscles, but in the program, I think, oh God, I've got to remember, in the program, I think it said also the potential recipients, and that's not quite as interesting as the donor muscle, so I'm going to talk about those particularly. And although you can test the strength, as Dr. Brown was saying, the strength is good, but it doesn't really tell you about what the pathophysiology or physiology mechanisms are of that strength that you're examining clinically. So electrodiagnostics was sort of brought in to check on that. And there are really two main reasons for testing the potential donor muscles. The first is really to try to identify the number of motor units that are in there, on the understanding that the more motor unit or motor fibers that you transfer, the better the outcome will likely be. And there is some evidence to suggest that that's true. So the success of innovation, and it also allows a partial transfer, so that if you find that your donor muscle is has plentiful amounts of motor axons, then you can decide not to take all of them. You only need to say half or so. The second reason is to check on the status of that donor muscle, which frequently by virtue of the nature of the brachial plexus injury, it could be a little suspect as well. So it could have actually undergone some partial degree of denervation, which is hiding below the surface. The traditional methods of doing this are going to be talked about shortly, but the actual purposes of the electrodiagnostic as outset there, you do want the motor unit number or some idea of it at least. The total electrical capacity is effectively what you're feeling when you do the strength test, but you, as Dr. Brown pointed out, you don't really know what the status of those motor units are that are producing it. And the third thing to recall is that you have to have some sort of reference. And this is where it gets a little tricky, because some of the techniques really do not have any normative values there. And so often it's necessary to, if you need it, to rely on the contralateral side, if it's available, hasn't been damaged itself or something else has gone wrong with it. So traditional methods, the compound muscle action potential is very good, but unfortunately not all muscles are available for that. Some of the potential donors are actually quite deep, and so you have to resort in those cases to needle EMG, which of course you can do on the superficial muscles as well. And the traditional way is to look at the interference pattern as it's gradually increasing from low force up to full force. And that's the way that we describe that in clinical terms is very vague. And it's very imprecise, as you've probably experienced in your own EMG reports. And if there's going to be any sort of counting of motor unit numbers, then it's done visually, and that has some great limitations. But going back to the general approach, I mentioned the three things that we're looking for: motor unit number and total electrical output, and some evidence of denervation. So we can look at the approach to the donor muscles as a global approach, which is compound muscle action potential, and the surface EMG. The needle, on the other hand, is a very local thing. It has a very small area of field, and so in order to get a very good idea of the muscle, you would have to sample a number of sites, and that's necessary to show the extent of the denervation, and we would normally expect that there will be some variation within it there. So it's a sampling problem in general. So, as I mentioned, the total electrical output from the muscle, the easiest way is the compound muscle action potential, as you see, and probably area of the action potential has greater value, has a little bit over the actual amplitude. The other way is mean rectified voltage. As the CMAP is passive, that's done with electrical stimulation, the voltage is actually sort of more a functional total electrical capacity, and that has its own limitations if there are pain and other things that can interfere with it. And it's rectified by taking all the negative values and flipping them up and making them positive, which is the change between the left side of the MRV figure and the right side, and then you sum all of those values, and that gives you the mean rectified value. And that's a sort of surrogate or a proxy, if you like, for total electrical output, but in a different way to CMAP. As Dr. Brown was showing with tetanic stimulation, that shows you what the system is capable of, but unfortunately patients aren't capable of tetanic stimulation, so it's not entirely a reference for that, but it's not too bad. So you've probably all come across motor unit number estimation, which has a long and tortured history, unfortunately. And it's very, very complicated. Most of the ones that are reported in the literature are very laborious and difficult to do and fraught with other sort of technical problems. But a sort of surface EMG version of that came up called Munix, and there's something called Musix. Now the N in Munich stands for the number, so it's designed essentially to try and estimate the number of motor units that are there, and the Musix, the S stands for size, and that's simply the relationship between the total compound muscle action potential and the Munix. That's probably pretty complicated, but anyway, what you do is you first start with a compound muscle action potential and stimulate, say, the median nerve at the wrist, and obtain a CMAP from the abductor pollicis brevis, and then a number, perhaps between 10 or 20 short voluntary contractions are performed at a range, and it's ideally a fair number of lower range, low force muscle contractions are obtained, and up to full force, and then that's plotted in that sort of decaying curve there, and from that a formula for that curve is obtained, and that is referred to the standard area of 20 millivolts per millisecond, and that gives you the Munix number. Is that all clear? Any questions on that? No. All right. But just bear in mind that it's a nice, simple, fairly easy thing to do, and much better than any Muni sort of technique you could get. And so therefore, it's eligible, I think, in the basic assessment or the standard assessment of the muscles for being a donor. Now, I wish I actually had a figure to show you the clustering index. This is another surface EMG technique, which essentially tries to, for the most part, identify neurogenic abnormalities through the skin or from the underlying muscle, and its formula picks up the fact that with neurogenic cases there's more sort of pulsing type of density, the clustering of electrical activity. So it shows up that particular pattern which we see in neurogenic conditions quite well, and it's fortunately very, very sensitive for detecting neurogenic abnormalities at the low range of force. So when you're doing your sampling by short, usually half a second long or a second long contractions from low to high, it's important to get a number of low ones in there because everything gets all mixed together later when it's full force contraction. So that's another way to look at the interference pattern. So looking at what I've talked about as the global measures are here: compound muscle action potential, mean rectified volume, those are the total electrical capacity. The Muni and the Munix are good for motor unit number, and the clustering index is also good along with the Munix and Muni. Oh wait, I'm getting all confused here. Munix and Musix, silly names, but they are good for detecting neurogenic abnormalities. So you've got a range of surface applications which can detect all three of those, both of those requirements. Okay, moving on to needle EMG. By virtue of what I talked about earlier, it's necessary to sample a number of sites, and This is obviously going to try your patience as well as the patients, but ideally 8 to 10, you might get that if you're lucky. So when you're looking at the needle EMG, you can do the number of motor unit count if there are only a few present, and that is somewhere in the range of 7 or 8. But once the number of motor units increases, it gets harder and harder to actually identify individual ones. So the visual inspection is not very good. We can use interference pattern metrics to sort of get a better idea of that, and I'll tell you about that shortly. And with disease detection, just the standard sort of EMG characteristics there are useful for both looking at the individual motor unit potentials morphology and the recruitment and fullness of the interference pattern. Right. Okay, so this is just this is a bicep showing you that when there's low force, it's pretty easy to see there's one there, but as the force increases, it gets harder and harder to actually pick out individual ones, and by the time it's full force, it's pretty much impossible. So as I mentioned, visual counting 7 or 8, decomposition software which can extract all these things automatically for you, but still requires an awful amount of manual input, can get up to 15 or 20. But after that, it's sort of like an open field of, yes, it's too much for me to count, but I can't really tell you how many or give you any idea of that. And that's just it in a different way. So the interference pattern, when we're looking at it clinically, we can say that it's full, but for the most part, being full is something that can occur as low as 50% of actual full force. So that 50 to 100% is open and undefinable visually. That's where quantification comes in, and it measures essentially the density of the interference pattern. And the typical traditional version is by turns amplitude analysis, and you can see on the figure there that there are quite a large number of little dots present in I don't have a pointer, I don't think, but you can see there's a kind of a...
There is one.
Is this it?
Yeah.
Oh, really?
The green button on the bottom, it looks like fire.
On the bottom. Oh, right, great. Wow. So all of these represent a single dot is a perhaps 500 millisecond long EMG, and it's plotted with the number of turns, that's the definition I won't go into, per second, and the amplitude of each turn. And this thing here represents a cloud which contains all the sort of normal data. So if your results fall up here somewhere, where you've got a low number of turns, but they're very high, that sort of indicates that it's neurogenic. And if you get some down here, where you've got a high number of turns, but low amplitude, that's myopathic. So anyway, this is cloud analysis. And the problem with that is if you're using normative data, you have to use normative data that comes from a specific muscle, and that might not be possible. So this is great, but if you don't have any reference, then there's not much for you to do about it. But it is potentially capable of disease analysis. But for our purposes, it's the activity measure, which is essentially how much electrical activity is present in that 500 milliseconds that was recorded, and the gaps are where the activity starts to fall. So in a neurogenic case, then there's going to be less activity because there are fewer motor units overall. So that's how we can get an idea of, and the quantification of the interference pattern from this here. Now, there's another way to look at the individual pieces of information that were in that cloud, and that is to plot the mean rectified voltage, which if you think of as a proxy for total electrical output, against the number of turns, you get an interesting pattern whereby this blue line here is the healthy, and it starts sort of off slow, and the slope goes up here, and then it sort of starts to become a plateau. So this is a sigmoid-shaped curve, and the slope, the rise of the slope, essentially is, it tells you, or it represents the size of the motor units which are occurring as the force increases in that zone. So if those are healthy, you get this sort of thing. But if they're neurogenic, meaning if the motor units are actually larger than they should be because of collateral reinnervation and the like, this becomes steeper, but it plateaus at a much lower level because there's a smaller number of motor units there. So this sort of, applying this kind of metric from the data you get for your turns amplitude analysis, you can also get curves like this which could indicate to you that it's neurogenic. Now there's another method called filling factor, and its formula is there, but effectively it tries to categorize the EMG as a probability density function, and when starting out first, you've got a few motor units. If you plot a histogram, it looks like a very sharp little thing, and that's called a semi-degenerate or a Laplacian distribution, and that's normal. But as it increases in recruitment, and eventually you have full recruitment, and then rapid firing, rate coding starts to appear, it becomes more Gaussian. So by modeling the EMG as a probability density function, you can watch as the amplitude of the filling factor increases. This is in the healthy here. It reaches a plateau, and that plateau should indicate that it's close, that it's a Gaussian distribution, which is the normal sort of stochastic distribution of the EMG. However, if it's neurogenic, on the other hand, its slope is slower and its amplitude at the plateau is lower because it's behaving more like less Gaussian and leptokurtic, if you want. You'll know leptokurtic, right? That's another silly word to describe the shape of the probability distribution. So neuromuscular disease shows up in the slope and in the plateau. All right. So needle EMG, I've mentioned the various things there that can be obtained from that, the interference pattern and the neurogenic. And so to wrap up, this total electrical capacity from the CMAP, which is stimulated, or mean rectified voltage, and you can get a sort of functional version of that from the interference pattern. Motor unit number, you can either count it, which I don't advise overall, but Munichs and Musics are your best bet there. And to find denervation, these are the kinds of things that can be easily applied. Now, it may sound very complicated, but these are actually very quick and easy to do. So my recommendations are, if you have a surface accessible muscle, CMAP is good. You can collect individual segments, ideally 10 to 20 of about a half a second long, and they can be all analyzed offline using these three things. So the time investment during the EMG is relatively small. And for the deeper muscles, of course, you can use needle EMG over here if you like, but these are the things that I think would be quite useful. And overall, I don't think now that counting the number of motor units by visual sight is such a great idea, but you can if you want to, and especially if you have to, because there's no other way to do it. So there we are. That's all I have to say. Thank you very much.
So for the surgeons in the room, I then say, is that going to be a good nerve transfer? And Jeff says, yes.
That's the short version.
That's the short version. Is this transfer going to work? And he says all that, and then he says, it's going to be a good transfer. And then I have confidence.
That's
A
right,
lot of
yeah.
thought went into that. Your neurophysiologist will probably say absolutely not if you ask him to do this, because it's a lot of work. Is it not? I mean, how much time does it take you to arrive at your confidence level that that particular muscle has a useful complement of axons and will deliver a good result with transfer?
Yeah, well, that's pretty quick. I mean, that's very, very, very short. Seconds.
Okay. For Jeff, it's seconds.
To make the decision, yes, thank you.
Very good.
I better get off.
So next up, we have Dr. Renee Balzo, who's a radiologist at Massachusetts General Hospital with me. And he's going to talk to us about using MRI as an indicator of innervation status.
Need some help here, thank you. Looks like it's coming. There it is. Thank you. Morning, everybody. Thanks for the introduction, Justin. So the name of this talk is Reading MRI in the setting of the innervation injury. Try to get a sense as to what kind of useful information we can get. I decided to waste a couple of minutes with Google Gemini, asking it to generate an image based only on the title of the lecture, and it kind of did a good job. It came up with a schematic of what we've been talking about. It even got some of the muscle signal changes that we'll be describing shortly mostly right. It took some liberties with the anatomy and introduced a couple of femoral shafts at the level where there seems to be a vertebra and a spinal canal in there, so I guess that's the state of AI, right? Still helpful, but a little wonky. So I got nothing to disclose. And so peripheral nerve injury, it's not uncommon in the setting of trauma, also in atraumatic situations, can be a pretty uncomfortable issue, produce a lot of morbidity, can lead to sensory motor disturbances, and that in turn may lead to a muscle denervation injury of varying severity. The localization of the nerve involvement and the severity is a big challenge. Skilled examiners will be able to narrow things considerably, and that is something that as a radiologist I always find very impressive, that they tell me, look here and here, and the answer is most likely in a couple of two places where they suggested. Electrodiagnostic testing plays a big role, as we just saw, of course, and then imaging, adds a complement, which more and more, it's catching up with the clinical necessities in trying to answer these questions. So the big things we will try to help to answer is, prognosis from these injuries. People will want to know, what's going to happen. And when intervention needs to occur, then they need to decide, is this something that I should wait on? Is it totally out of the table, or do we move on it? So when it comes to MRI of the muscles, what are we looking at? So we'll be describing what we can see in the muscles in this acute setting, in the chronic setting, and once reinnervation occurs, how these things tend to move. I will not be talking so much about the nerves themselves, kind of more focusing on the muscles, but some nice images, hopefully, for you folks. And then finally, just kind of wrapping it all up together, how I would think about it, at least from my more basic perspective on these things. So, brief comments on EMG. I mean, I hope I won't completely mangle some of the terms in this case, but basically it's considered the gold standard in much of this assessment. It provides physiologic and real-time evaluation in the setting of active denervation. Words that I'll hear that I'll read in these reports include fibrillation potentials and positive sharp waves. You also can see decreased motor unit recruitment. Challenges, as we've been mentioning, is that this is invasive, often described by patients as uncomfortable. Reliably probing deep muscles, it can be a big challenge. It introduces operator dependence, I suppose, just as imaging does, where Justin was describing shoddy imaging in some places. And then in the acute setting, some of the changes might not be evident. This is also, of course, true on the imaging side of things. So MRI is great, we love it, but it can produce a couple of issues, right? So the main frustration is, I guess, that you got this clinical picture that looks pretty complicated in MRI, doesn't seem to show much. Or you have, a slightly bright-looking nerve or muscle, and so is it really correlating well with a clinical picture, or am I going somewhere else with some dubious findings? And then on the technical side of MRI, you have these patients who want to lie still enough. We were talking about bad trauma cases, ventilators. Patients need to be in a good enough condition so that they can go through an MRI. Are there any nearby metal or devices? This is a big headache for all of us. Despite improvements in technology, a big hunk of metal nearby a nerve that you want to assess is still going to pose a challenge. It is getting better, but sometimes there's just not much that MRI can do. When there's pacemaker, this introduces delays. You'll have to see if the device is compatible, and then you might want to have an electrophysiology service nearby. So we talk about MRI neurography, and so this means a variety of things, but mainly we've tried to design these MRI protocols so that you get very high resolution in plane, and you'll get fluid-sensitive sequences. You've heard about things like STIR and T2 with FATSA, T2 Dixon. And then you have your so-called anatomic sequences, which are great for assessing the contours of a fat around the nerves, fatty infiltration of the muscles, volume loss of these muscles. So protocols continue to get better. We're still not quite standardized, which is a big problem when it comes to trying to achieve multi-institution studies, but hopefully we're getting there. And then, as we were saying before, you do these MRIs, and sometimes you'll only find some muscle signal changes that may or may not correspond with the distribution that people have in mind, and sometimes you just don't see much of the nerve. So historically, this has been the case, that we've been describing all these patterns of muscle edema, but identifying the nerves, we're getting better at it. We're still catching up. And in this example here, you're able to see some edema of the deltoid muscle, teres minor, what seems like a pattern of the axillary nerve. As best as I can tell, I think it's pretty hard in this case to find a demonstrable abnormality of the axillary nerve. So on your T2 images, what are you looking for when you're suspecting denervation injury to this muscle? You're looking for edematous appearance, right? So we like to use the word T2 hyperintensity, and that can, of course, in the muscle be regional or diffuse. And it can be regional in the setting when it's very early, or if a muscle has dual innervation, that's something that you will see. And on your T1 weighted images or your protein density, that tends to be very good, as we were saying, to identify volume loss or fatty infiltration. And you'll use muscles that are nearby as your reference standard. So, regarding onset of some of the stuff that we see in regards to the edema, people have described, dilatation of capillaries, and it seems to be the main driving factor as to why the muscle looks congested. And this can happen as soon as 24 hours, though in a lot of cases you won't be able to detect it at that time. But more importantly, in the acute setting, the muscle will look edematous, but it should not be atrophied. It should not have fatty infiltration. And so the thinking would be that maybe this means that the muscle is viable. That's what it seems like from the imaging perspective. So still on the timing, in the first couple of weeks, muscle edema will be on the subtle side. And again, as we were saying, sometimes looking a little regional. And then by weeks 3 or 4, it'll probably peak in intensity, and so no one should be missing it at that point in time. So whenever possible, I try not to bore non-radiologists with radiology jargon. Just thought I'd comment quickly on some of these sequences that you hear in this setting. So you hear T2 FATSAT. We've been doing it for years. We really like it. One of the challenges is near the edges. As you get closer to the board, the fat suppression starts to fail a little bit, and this can obscure findings or give you, false positives. And then you have your other techniques, like historically the STIR, and more recently the T2 Dixon has increased in popularity. And so the pitch behind those things is that the fat suppression tends to be more robust and kind of increases your confidence that things are mostly normal or if a finding is real. STIR is still king whenever metal is nearby. So, instead of worrying about these names, I just thought I'd talk about T2 Dixon. You'll be hearing it more and more. It does produce good results. Let's see what else. So in the setting of reinnervation, what we tend to see is that these capillaries eventually regress. If I look at an EMG report, I'll probably see language such as loss of spontaneous activity, and they'll report changes in motor unit action potentials, mainly increased amplitude is the one that I tend to remember. And then on the MRI side, the resolution of this edema is going to be variable. But as a rule of thumb, a lot of patients you'll be seeing it 10 weeks out. How quickly will this progress? It really is quite variable. But there are papers that say that, by the time you see edema that seems pretty evident after, suspected, after efforts to try to improve the condition of these nerves, you see it 6, 12 months out, then this has an association with bad outcomes. And so this here is an example from the literature, 57-year-old patient who underwent surgical release for pronator teres syndrome. And so on the baseline image, you're able to see edema and some of the flexor muscles in this region, a bright median nerve. And then after the surgical release, the patient felt better. This is 6 months after. That regional edema that we were seeing has gone away. And then again, kind of like the funny fatty infiltration at the edges, but in this case, doesn't really kind of messes up our diagnostic dilemma. So far, so good. The other thing is we've been talking about muscle edema. So if I see muscle edema, I'll have to, of course, go into the chart and figure out what the clinical question is, what the scenario is. Because bright muscles can, present on imaging for a variety of reasons. In this example here, you have a patient with myositis. You have a bright tensor fascia lata muscle, maybe the gluteus maximus, both quadriceps, some of the hamstrings on the left. So not anything to do in this case necessarily with the nerves themselves, just a myositis type situation. People who read a lot of forearm and wrist MRIs, and you guys probably will get some of these referrals every now and then, a bright pronator quadratus muscle, which can be seen in asymptomatic patients, but sometimes will raise a situation like, hey, in case there's some weakness, think about, your anterior interosseous nerve, that kind of thing. So pronator quadratus on its own, just, we radiologists should remember that it can be seen in asymptomatic people. The other common one is exertional changes, right? So this patient got in an MRI to evaluate for bone stress changes. That was negative. And then, this patient is an avid runner and had some muscle edema that can be seen just after a workout. And then, of course, stuff like strains, infection, that can also present an edematous muscle. So just kind of thinking about the different situations that might result in an edematous appearance of muscle. So now moving on to the chronic side of things, you can see loss of volume of the muscle, increased fatty streaking within the muscle. And this is appreciable even in a small nerve such as the supinator in this patient who had posterior interosseous nerve involvement. And so the worry with this is you see a muscle that is substantially atrophied, that the fatty streaking is evident, and so the worry is that this might be a poor candidate for reinnervation. And so you'll sometimes also hear comments on the degree of fatty infiltration. And so a lot of this stuff stems from shoulder imaging. And so shoulder surgeons like Dr. Hassan will look at this kind of thing and say, hey, my tendon is messed up. Do I bother repairing this thing? Does it have enough muscle that I'm going to have a good outcome? Or if it's badly atrophied, then maybe I consider other things. Do I move on to alternatives such as reverse shoulder arthroplasty? And so when we talk about mild, moderate, and severe, basically what we're looking at is the proportion of normal muscle to fat streaking. So fat streaking is there, but just kind of on the faint side, so that would be mild. By the time the fat streaking becomes evident, but there's still way more muscle than fat, that would be your moderate. By the time you have substantial volume loss and about the same amount of muscle and fat or even more fat, then that's really bad news. So a couple of example cases. There's a 38-year-old female patient who developed symptoms shortly after delivery. So delivery took place 4 months before the MRI that you're seeing here. And it all started with bad pain in the back of the shoulder, and this later on transitioned to weakness, not so much decreased sensation. So this is on the left side. So we go through this image here, and it'll come back to the brachial plexus. And most of the brachial plexus looks okay. You do get to see some muscle edema, supraspinatus, infraspinatus. At this point in time, 4 months out, there's even a little fatty atrophy of those muscles. And then the other thing, which unfortunately might be tricky for you to appreciate, given the zoom here, but the suprascapular nerve, which in normal circumstances is really hard to see, in this case it was thickened and found to be abnormal. Just kind of zooming into the suprascapular nerve, this is a curve reconstruction. And so basically what I'm trying to show here is that you have, when all these arrows are, these focal narrowings of the nerve. And so, this is considered to be the hallmark imaging finding of Parsonage-Turner syndrome. And interestingly, in this case, there's also a little crossing vessel, and it's just kind of an artifact of, in relation to the type of sequence that we use and the timing. So in this case, EMG reported acute and chronic left suprascapular neuropathy consistent with PTS. They mentioned acute denervation and reduced recruitment. They say we didn't find any evidence of median and ulnar neuropathy and no other thing going on. So rather nice correlation, especially with the acute and chronic comment, given the fact that we are seeing some fatty streaking. So that was very nice. This other individual is a 58-year-old male patient who had been complaining about shoulder pain for several months. However, after lifting heavy luggage, he now reports worsening shoulder pain and, more interestingly, new upper extremity tingling and weakness. So 6 days after the injury, an EMG was performed. 8 days after that, we did an MRI shoulder, and a few days after, we did a brachial plexus. So starting off with the EMG, it reports an abnormal study. It says that seems to be acute right brachial plexopathy involving the posterior cord, medial antebrachial cutaneous nerve. There might be some radial axillary nerve involvement, but it seems like there's nerve continuity throughout. It seems like it would be pretty dramatic for you to not have continuity after lifting heavy luggage. I thought it was an interesting mechanism of injury. So going back to the imaging, at this point you're able to see, hopefully it'll come back soon enough. Let me start from here. So big rotator cuff tear. Central anterior supraspinatus tendon, some edema of that muscle, some fatty infiltration. So that's probably been there for a while. You have these signal changes in teres minor. So, is the axillary nerve also involved? I kind of feel like I struggle with that. You tend to see in patients with no good explanation. So those might be red herrings. Going back to the brachial plexus. So here you're able to see we're kind of far out of the level of the mid-distal clavicle. And you have the subclavian artery, lateral, posterior medial cords. The posterior cord is thicker. And as you follow that medially, you're able to see some of the divisions. Superior middle trunks also seem a little thickened. And so I think this a kind of curious mechanism. I wonder if you guys kind of hear cases about this, but it's the first time I've seen from heavy lifting, I guess, kind of similar to those, the baby version of those motor vehicle crashes, right? And then this is the same patient, and again, just showing, kind of going back to the axillary nerve and how tricky it can be, right? So here you're seeing some capsular disruption from the trauma, and then you get to see the axillary nerve just kind of coursing through a hematoma here, or maybe some kind of extravasated articular fluid. It might be a little thick, but kind of really tricky to assess in this instance. All right, so different patient now, 68-year-old male patient presenting with might be like, both kind of like median and AIN symptoms, both motor and sensitory, and these were of slow onset. And so you were able to see kind of the muscle edema in the typical pattern, right? You have flexor digitorum profundus, flexor pollicis longus, pronator quadratus, the usual ones. Pretty good correlation in this case with EMG. So they mentioned, there seems to be some right C8 involvement, but really what looks bad is, some of these muscles in the AIN distribution. And so the other thing that this case, I wonder if some people will buy this, is you see a median nerve here looking kind of bright, but then more importantly, as it's kind of crossing its way here into the proximal forearm, there's an area of subtle narrowing. So that's a bit on the tricky side. But anyway, this patient underwent surgical resection. There was a debridement of the lacertus fibrosis and the fascia of pronator teres, and the results were pretty good. The surgeon was happy with this. I think this is the last one of these scrolly cases. So 59-year-old male patient, in this case with ulnar nerve symptoms. So even way back down, we're able to see some of these nerve and muscle findings, right? So you have kind of the dorsal interosseous muscles mainly showing what appears to me kind of like more recent denervation. And I don't know why this stopped. And then going back to the ulnar nerve here, kind of okay. Then it gets a little bright, a little thick, just proximal to the PC form. And so this was also surgically released. And so in the op note, it reported that the ulnar nerve seemed to be particularly narrow at the side of the antebrachial fascia, which is kind of just proximal to Guillon's canal, right? Just proximal to where the PC form kind of comes into place. And again, pretty good correlation with EMG in this case. Not so much fatty streaking, so patient did well. So quickly touching up on quantitative. So all of these things that we've been talking about, the edema, the atrophy, and the fatty infiltration, people are trying to come up with these clever ways to try to quantify these things with the hope of detecting these changes a little earlier, but probably even more so than that to try to get more valuable data for longitudinal follow-up so we can all understand these phenomena a little better. So this here, just an example of the T2 mapping, again, try to quantify the edema. This is a median nerve with a focal constriction there in the setting of PTS. Here just kind of showing how the ROIs were placed, and so here just showing that your pronator quadratus is the one that's involved mostly. Apparent fiber diameter is kind of the clever way where we're trying to kind of quantify atrophy almost at the micro level. And so here in the top row is a normal patient, and you get the nice color maps that this is supposed to be calibrated to show that it's normal. And on the row inferior to this, a very young patient, 11-year-old female with a Parsons-Turner bilaterally, but the symptoms were worse on the right, and so of course the edema is worse here, and that kind of correlates well with this, where it's just kind of showing you like early atrophy now that the edema has installed itself well. And then, and this one just kind of tying it all up, you have, this is just to illustrate the fat fraction, which is a quantitative evaluation of the fatty streaking. And so a patient who suffered at this location, also surgical repair of the anterior inferior labrum. You see the adjacent and a curve reconstruction, the adjacent axillary nerve looks pretty sad. And you have the characteristic muscle signal changes, just kind of like visually evident. And then you have the T2 mapping, again, kind of confirming that, all that edema is there, seems to be worse for whatever reason in the posterior deltoid. You have the apparent fiber diameter, kind of hinting at early atrophy of some of these muscles. And at this point, fat fraction shows nothing. So just, in the future, if we can make these things work reliably, we will have a whole lot of data to, have more refined information, and hopefully that aids in helping management. So tying it all up from my, especially EMG ignorant perspective, how I would think about things. You see an MRI that doesn't show much. EMG doesn't show much either, so maybe leave it alone or follow up or look at other alternatives. By the time we see edema, EMG seems to be confirmatory of denervation changes. then you think of the muscle as being threatened, and then you want to try to decide how soon you want to move for different interventions. And by the time you have fat infiltration, especially if the atrophy in the fat infiltration is convincing enough, then at that point, do you pursue other alternatives than a nerve transfer? So last slide, EMG and MRI, are not fighting. MRI is just trying to help things. It's a backup role. EMG is showing if the wire is live. MRI is trying to show you how the muscle is lying. Remember that some of these signal changes, they might not be present. If they are present, they need to fit the picture, so that is key. And then in the acute setting, we'll have edema, not much fat, not much atrophy. And so hopefully technology keeps catching up. Hopefully we continue to understand these phenomena better. Feedback from dealing with people like Justin is excellent in helping us kind of get better at this kind of thing. So thank you for that, and thank you everybody for your attention.
Thanks very much for the excellent talk. Now I would like to invite Jeffrey Strakowski.
It seems like Dr. Hassan has a
Petros,
question.
A couple questions we're going to
Couple of questions, okay?
Yes, of course.
Thank you.
There
That's
you go.
great. Great talk. It's very, very challenging though, because we have a lot of cases that they come early on. First of all, MRI shoulder does not show medial scapula, which means the whole muscle you cannot see, number one. So we always challenge, do you get scapula MRI or shoulder MRI? Number two, I've seen many patients. You said 3-4, it will show. I'm sorry, it does not. I have patient, nerve injury, EMG, 4 weeks, there barely any edema. And then I bring them, they're really, really weak. And then you get EMG, they have the nervation. You get them at 3 months, they start to show up. And this will become challenging. Where does radiology now fit in to this category of patient as they're evolving into this atrophy? And the most challenging if someone has baseline rotator cuff tear with atrophy.
Yeah.
Now, what do you talk about nerve injury? Because they already have fatty infiltration. So where do you differentiate between cuff tear? Because this is the one I discussed with Justin. If someone has tear and nerve injury, for me, they have to be repaired quickly. Why? Because as they're recovering, if you don't repair them, the cuff is gone. You want to do whatever nerve surgery on is not going to work. So that's very important. If baseline have cuff tear, some atrophy with nerve injury, how can you use MRI to help you differentiate where is nerve injury, where is muscle injury?
I'm afraid I don't have a good answer for that, and I think it's an excellent question. I think this is where talking to referrers like yourself and trying to really understand where you're coming from after looking at the history, looking at the imaging, examining these patients, and trying to understand the context of the question really comes in key. I think in a vacuum, which is unfortunately how we end up reading a lot of these studies, and I'm sure it shows on your end where it seems like we're only saying part of the answers and only addressing, a small fraction of the questions. But the short answer is when we have these confounders, I don't know a way that I could reliably be able to distinguish to what extent the atrophy or the edema, to what proportion is resulting from the tendon issue or from the nerve issue, if I'm understanding your question.
And when do you think we'll be able to use the volumetric MRI? So the tricky part for us, like this yesterday before I came, I saw a patient from the VA, chronic nerve injury, like not traumatic brain injury, chronic brain injury. He has function but weak. Edema but not complete. So this is where you have a chronic deltoid, for example, but you need volumetric. Yeah, look, atrophy. What atrophy? Is it grade 1, 2? What do you mean? When you look at the MRI, it's smaller. What do you mean smaller? It's like 40%, 30%? So how, do you think soon we'll be able to get volumetric evaluation of the muscle, especially with chronic denervation that has some life in it, but it will help us also determine the treatment for the patient?
I think having this feedback is really valuable. I mean, how soon could we have volumetric assessment? Tomorrow, pretty much. It's a question of us knowing that this is something that you need.
Yeah.
And so we probably wouldn't be doing this routinely in everybody. Of course, there's big pressures for throughput, but if this is requested, then we can certainly accommodate that kind of thing. Technically, it's not a big challenge.
Yeah, Bassem, I think in my hands, to have these sequential, that you get the MRI first. Now we see what's perfectly normal and what's not quite normal. Follow that with the EMG, and now we start getting our answer. But I love the imaging because we now have our three-dimensional of the entire shoulder or limb, and we can look at every single muscle within that limb and every part of that muscle within that limb and see, because partial denervations you can miss if you just start with a needle. I'm sure Jeff will tell us that ultrasound is going to answer all of our questions here, and maybe it will. But for us to go back and get on the PAC system and be able to walk through every different dimension of that limb and see what's normal or not, I think is a great place to start.
Because Justin, in OBPI, obstetric brachial plexus, late presentation, you look at the MRI, it looks almost normal. It's smaller, some fatty streak. But in reality, they feel contraction, but in reality, they're not. They're abnormal.
Yeah.
And I feel this is where, like, some of what he presents is awesome, but I'm hoping we're gonna get to a point where we say, yes, like, it's an answer, not, yes, there is something, instead of, like, this is the problem, and this is the percentage, that's it.
I want all the data, all of it. So Jeff, we'll have you.
Good job.
Thank you. Thank you.
All right, in 8 minutes remaining here, we talk about ultrasound a little bit.
Jeff, you can, we got
Okay.
time. Okay.
So I wanted to thank Dr. Brown for having me here. This has been a great venue. I'm going to talk a little bit about ultrasound for some of the same principles that we were just discussing, including volume assessment for muscle. That's one of the things that we do. So here's, I can barely read my screen here, but I want to talk about using ultrasound with electrodiagnosis. Things that we want to use for surgical decisions would be precise localization of the neuropathy, evaluation of the appearance of the nerve in question, okay, and assessment for different types of anomalies. We can use this to help assess the extent of denervation. And then also look for musculoskeletal changes. So if you're going to select these tissues, is there secondary muscle damage, tendon damage, problems with the cartilage, even the joint that you might be involved. So that's using ultrasound as a way to do that. So I'm going to talk about combining these a little bit. So let's start with the progression of technology in electrodiagnosis. This is kind of the time frame from 1990 to 2026. Okay. By contrast, this is the progression technology for ultrasound in that same time frame. Okay, it's been pretty dramatic. So we're starting to see things that you just really couldn't see before. I was part of this paper that we put together from people from around the world of value of using ultrasound with electrophysiology in neurogenic conditions. And the conclusion was this shouldn't really even be considered a separate entity in assessment. We should consider not just EMG and nerve conduction, but it should be EMG, nerve conduction, and ultrasound, and it should be a combination of those. I'm going to skip this slide, but the idea is one's predominantly physiologic, one's anatomic, and they fit very well together. So looking at, most of you have a sense of looking at, the distal C map. We've talked about that, the distal snap, that in a static condition, that kind of tells us the most about how many axons are still preserved versus a neuropraxic lesion. So clinically, this is difficult. So in a typical nerve condition, what is the value of electrophysiology when you can just examine them? And I can tell you that you can't distinguish a complete neuropraxia from axonal loss until you get something into the order of muscle atrophy. So this adds an acumen that you just don't have on a clinical basis. Okay, so I thought, well, what do we do on ultrasound? Well, this looks a little bit like a neuropraxic lesion. This is my dessert the other night, and you can see some of the probably crumbs on the menu. So that's probably predominantly a neuropraxic injury. This is a little bit more of like an axonotmesis, and this is a neurotmesis. And Cartwright and Walker came up with a nice study to show we have really good precision with ultrasound to distinguish in these two. Okay, but the reality is this isn't what we see in ultrasound. This is what you might see surgically. What we see in ultrasound is actually through the tissue. So we can see, for example, enlargements within the fascicles of the nerves themselves, not just the enlargement of the nerve. And we can see internally. We see above and below it. We see below the surgical field. So the idea that maybe this is like in a den of wolves to make a comment like this, but I don't think the idea of surgical exploration, it ought to be a thing of the past with some of the acumen that we have. Okay, and so that's just a neuropraxic lesion.
And there's another example of the vacuolated fascicles that we see within a demyelinating condition. Now, axonal, we can see the different aspects of Sunderland classification. So we see loss of some of those some of the fascicles where they start to coalesce together. It looks a little bit like a bag of grain. This is one that looks fairly similar to the last one you saw, but there's internal disruption within the fascicles themselves. Okay, and that's something that we're really pushing to get people that do ultrasound to look at, is not just look at the size and just measure nerves and try to make it all ordinal, but you know, there is a qualitative estimate of, you know, looks pretty severe. We can analyze it over great lengths. Now, neuromesis, okay. This one actually, I took this from Tennell's original book. We redrew this. It was 1917, and I took it from the University of Washington, and it hadn't been opened since 1987, and I was scared to hurt it, but it was just absolutely amazing. By the way, he was not saying you tap here and that means you have carpal tunnel. That was not a Tennell sign. By the way, that's been really destroyed. He just meant you could tap on something and it regenerated to that point. But this is a neuromesis here, but we can tell because the nerve is no longer under tension with this neuroma, where this one actually is an axonotmesis that has continuity. It's more clear when there's a distal neuromesis. So this is the superficial radial nerve, and we have complete neuromesis. We can see it in short axis where we see the terminal neuroma. And the advantage of this is, you know, electrophysiologically, this would look like a complete axonotmesis, and it has no localizing ability electrophysiologically, but we can localize this down to portions of a millimeter with ultrasound. There's an example of a terminal sural neuroma. Okay, and we can localize it and qualify it and see if there's connective tissue scar, other things that might be influencing it as well. So being able to see the injury site in detail is helpful. Now, other things with electrophysiology is it helps our needle accuracy. We talked about superficial and deep muscles and things like that. We can actually get to the muscles with greater precision, and Dr. Boone at Mayo Clinic has done some nice studies to show that it's really effective for doing that. This is back to the things that I mentioned. These are some advantages of using ultrasound with the EDX, and you can read those. Okay. But you can really identify dynamic abnormalities, anatomic variations, more precise localization, give you information of the anatomic source, what EDX doesn't usually do. And one really critical thing is EDX can't really distinguish a complete axonotmesis from a neurotmesis, right? And you need imaging to do that, because those will be exactly the same on electrophysiology. So let's get into a little bit more with localization. Okay, you always want to look in short and long axis if you're a scanner. There's an example of the fascicular pattern of a nerve that we see in cross-sectional area. We can see the palmar cutaneous branch of the median nerve. We're actually learning with some of this ultra-high frequency that some of our anatomic dogma that have been done with cadaveric specimens are actually changing, because we can see things without altering the superficial tissue and do it in much larger numbers. But this is the fibular part of a tendon. That's the FCR tendon. Here's the medial and lateral plantar nerves in the tarsal tunnel. And we can see when we move back and forth, we can see it with a greater conspicuity. This allows us, this next one, this is the ulnar nerve. We can see the fascicles of the dorsal branch of the ulnar nerve. This is the flexor carpi ulnaris tendon remnant and muscle. And so this allows us to see things in great detail. There's the dorsal branch. Those are the 9 to 13 fascicles that the dorsal branch of the ulnar nerve has. Okay. Now, anybody want to take a guess out of this group what this nerve is? You're not really expected to get it. Just take a guess. This is for shock effect. I'll stop it here. I'm going to just throw out a guess. What nerve is that? The answer is that's the medial branch of the deep fibular nerve in the first web space of the toe. Okay, why is that important? Might not be, but I actually see a lot of these things from foot surgeons. They went to neuromas. Okay, and this is from the superficial branch. But the point of this is with ultrasound, there's no nerve we can't see that's not covered by bone. We can see any of it, all of it in detail, and I can count the fascicles in that little tiny branch. Okay, this is 7 millimeters, the entire screen. Okay, so it's really effective for that. Okay, so other things relative to EMG, many things we don't have electrophysiologic conduction studies for, so it can help localize things like that. Okay, here's For example, a little neuroma down in the foot, when you see the focal enlargement, and sometimes that has morbidity for patients. So and even in our spinal cord patients, we may have something not necessarily that small, but something that influences what we're going to make a decision about. We can see post-amputation neuromas with detail. We don't have electrophysiology for that very well, and we can identify a source of pain. It actually adds specificity to more conventional entrapments too. How many, this isn't an EMG crowd, but the people that like to spend lots of time doing inching or short segments around, to me it's most of the time a waste of time unless there's a really nice conduction block. It's fun to show the patient, like that's right here when you stimulate it. But this is, down to portions of a millimeter, this is the ulnar nerve at the elbow. We can see where the enlargement is, we can see where the compression is, and we can see the mechanical things around it. Again, down to portions of a millimeter. Seeing it in both views here, we can see the vascular supply and even neovascularization. Okay, so there's other situations like selective fascicular injury, for example, where we have an injury that may take us to the wrong place, the wrong location, right? We run into that kind of thing where all the fascicles aren't affected. Here's an example of the fascicular sparing in the ulnar nerve. This is the ulnar nerve at the elbow. And we can see that there's gradient enlargement here, and I'll move this. Okay, that's the medial epicondyle. Now you'll notice there's normal fascicles, and these are the fascicles, if you follow them, they go to innervate the flexor carpi ulnaris in both the humeral and ulnar portions. Okay, so we follow that back and forth, and that fits the clinical picture of relative sparing of the flexor carpi ulnaris. And the dogma in the electrophysiology groups I hang out with was always that there was so much variable innervation in the flexor carpi ulnaris, and I don't think that's really the case as we study it. I think it's more of a matter of different degrees of involvement, but that allows us to actually predict what's going to be affected most by that injury or that neuropathy. Now here's another example, so I'm going to do a quick case here. This is a person that had just a routine rotator cuff repair, but afterwards he noticed that he kind of lost his substance under his biceps, and it turns out they did an MRI and they found, denervated brachialis in isolation. Okay, and so we can confirm that on ultrasound. So here's a look at the normal pronator and brachioradialis next to this, or next to the brachialis muscle, right? Anybody want to think, where's the lesion in this case? It's isolated to that muscle. We don't want to throw that out there. There the muscles are labeled. We have to be a little careful with ultrasound because if a nerve has, or a muscle has a different angle, you could get anisotropic artifacts selectively making it look like that. And this muscle is actually, that's a possibility, but I can do it again in long axis and it still is denervated. The answer is, well, it's probably the branch to the brachialis is what you would guess with the sparing of all the other parts, right? So you think that's down somewhere at the branch of the brachialis muscle, somehow that got injured or affected, okay? Well, here's the muscocutaneous nerve. We can see those fascicles. Now, if you look in detail, and I'll convince you of that later, the fascicles to the brachialis are the only things affected and enlarged were the fascicles to the biceps brachii, the sensory fascicles to the lateral cutaneous nerve of the forearm are in the same location unaffected, okay? So we can see that pulsate here. And we can see this kind of large thing back and forth, and we can follow those directly to the brachialis muscle. And I'll go through these quickly because okay, and you can see that clearly abnormal. And I'm going to go a little ultra high. So here's the fascicles to the lateral cutaneous nerve of the forearm. Those sensory fascicles are normal. The fascicles to the biceps brachii are normal. And then we have these abnormal vacuolated motor fascicles to the brachialis. Okay? So anything you did electrophysiologically or clinically is going to suggest this lesion is in a different location. But this kind of imaging allows us to distinguish that. Okay, here's this labeled, okay. So this is neuralgic amyotrophy. It's probably an autoimmune insult. And in fact, there's this big movement about talking about the constrictions, and we've had lots of debates over this. And most of the time, the sine qua non of this does not appear to be a constriction model in any sense. They're enlarged over great periods. Most constrictions are usually 1 to 2 centimeters. These are large, much greater. But it's really hard to ascertain how a model of that kind of selective fascicular injury could occur in a constriction model as the primary source of it. So here's another example of a radial neuropathy here, and here we see all the motor fibers are affected. This is somebody that had almost a posterior osseous appearance. Digit extension is weak, radial deviation is weak, or excuse me, there's radial deviation with wrist extension and no sensory complaints whatsoever. So you expect that is going to be down in the forearm somewhere, correct? And the reality is the abnormality was in the motor fibers up at the spiral groove, where these are the fibers of the posterior cutaneous nerve of the forearm. These are the fibers to the superficial radial nerve, completely unaffected. It's very hard to ascribe a constriction model to this as the primary source of that. Okay, I'm going to skip this case for time. It's pretty cool, though. But just know that we can get other mechanical things that might be missed if we don't, and we're able to pick up. In that case, it was a ganglion cyst in the wrong area where people thought it was a Wartenberg syndrome, okay? Okay, and evaluating the nerve in question, I am going to do this case. And this is just the simplest model we can think of. We'll just talk about carpal tunnel syndrome, and this is how ultrasound helps us. Okay, this is somebody that he's a 54-year-old. He had a carpal tunnel release 6 months ago, had no improvement. Did an EMG here, and he's got a distal latency of 5.2 milliseconds, 5.6 millivolt response, and nerve conduction velocity in the forearm of 46 meters per second. The sensory is done on both sides of the wrist. Okay, he's got a 5.4 millisecond, 6 microvolt response, 7 centimeters at digit 3 is 2.1 and 14. So he has shirt slowing across there, and he has conduction block with a sensory of more than 50%. Everybody comfortable that's carpal tunnel? So what happened? Well, we got the EMG, okay, it didn't get any better. We may or may not have a prior EMG. Say it was as better than it was, or we don't know. This is still thing in time here. What happened to this person? What went wrong? And if you think you're goth, you're not goth unless you have a crow on your lap on the bus. Goth, by the way. So it's really hard to tell from the electrophysiology what went wrong in this case, right? How many people run into this all the time? So what do we say? Well, the EMG's a little better, or I don't know. Okay, well, we scan it, okay, and I'm going to take you quickly through this just for speed. Well, he's enlarged at the wrist and small and normal at the forearm, okay, with some compression. Let's just look at this. Okay, so here's the median nerve. This is the lunate. This is the distal radius. This is the FDS tendons, ulnar bursa. Right here is clear compression, and there's no real scar there or anything. We got enlargement above the level. So he does have carpal tunnel syndrome. What went wrong? The answer is in 10 seconds, you can say this is an incomplete release. We know in 10 seconds. Where, without that kind of imaging, you're just guessing. Now, the clue on electrophysiology was there was a little bit of neuropraxic block. Okay, that usually goes away if there's not an ongoing compression or insult. But that just takes that away. Now here's another case, post-op, that they got better for a while and then got worse. And then we can see post-operative scarring, compression. So we know very quickly also what's the source of the recurrence. Here's one that is so scarred that it has no mobility. So the dynamic source of that also helps us. Okay, and we can tell that this absolutely has no chance to do well, and it's going to have a traction neuritis that continues to worsen over time, because with every movement there's a little bit of traction neuritis from that encasement and scar. So we can see that very quickly. Here's another example of one that went bad, and that is just an encroaching muscle. So he's got a large flexor digitorum superficialis to the index finger. So those kind of imaging can help us with this. Justin, you want another case? You want to wrap it here? This one's pretty cool. You guys might like this one. We'll do it quickly. All right, this is a kid, a 9-year-old, who for whatever reason stabbed himself in the back of the knee, and he had a foot drop, and they were concerned. They had me see him 10 days out, and they didn't want to do an EMG at that point. They had already operated on a vessel. This is a big gastric tear and hematoma from the knife wound. This is this common fibular nerve near the popliteal fossa, okay, right here. And the question to me was, do we go operate and try to reanastomose this now or watch it 10 days out? How many people want to watch it? Based on this, how many people want to move in? How many don't want to commit? Well, that's what we got to decide. So the right answer is what you're saying is, let's see more. Okay, so now he had a brace on because of the gastroc tear, so I couldn't really put a lot of stress on it, but a little. So this is it. So when you're looking at long axis of something, to the left is cranial, to the right is caudal. Okay, and this is the laceration wound. And this is a real case. I'm forced to make this decision for him. How about now? Now that I saw a little dynamic. Looks bad, doesn't it? And he's got no motor function at all. Anybody want to commit? So let's go and zoom in on this in short axis. So there's, well, that's still actually long axis. I'm sorry. There's scar, wound. You can see all that. Anybody now? Operate. So he could decompress. He could. They wanted to know, do they need to move in on this? And
I'm waiting for your report to come out that says transected or not.
Wait, I mean, that's fair. Okay, so it looks like there's a mess here, but now we come in and let's look at the fascicles in more detail. Where this laceration actually occurred is right at the bifurcation from the lateral serocutaneous and the trunk of the common fibular nerve. So here are the fascicles to the deep branch. Here are the fascicles to the superficial part of that nerve. And this actually is just a normal bifurcation. So the answer was none of these were injured to any serious extent, other complete neuropraxic within 6 weeks. I just said I would follow him carefully. We just followed him every 2 weeks, and the parents were comfortable with that. He was back to normal in 6 weeks. It was shocking. Okay, and just to show off, this is a saphenous burn that happened. They got bovied, and this is 0.2 of a millimeter, and I can see that on ultrasound.
Let me have you address Carlson's question from earlier.
Which question? Oh yeah, I have a whole thing in muscle. Here's another, partial fascicular injury that was directly injured by a knife. Okay, so we can see lots of those. The muscle part of it, this is just post-operative stuff. All right, these are cool a little bit. We don't want to take all the time here. So in question to the muscle, okay, we can do volumetric measurements very well with ultrasound, and the key is having consistent anatomic landmarks and lack of movement in position. So if we have consistent positions, and we can do this very well down to with great precision. Okay. This is a whole talk in and of itself.
Looking at relative function of muscles. So we're looking at shoulder dysfunction here. We had an MRI that's iffy, it doesn't look entirely normal, we don't really know where the problem is. Are you going to be able to look at the movement of those muscles and say, this was...
I am, and I'm able to look at it, but this is something where I think having all the modalities help when we're trying to make a really serious decision. I wouldn't leave it to one set of images, but I showed this yesterday as an example of a denervated anterior compartment compared to the same person's normal side. Okay, so we can do the measurements of how much loss there is in those positions, and we can see the change. Okay, and it's interesting because I think we talked about the change of the MRI and the fatty infiltration. Okay, there's a couple processes that happen. Okay, and I think some of this gets skewed a little bit because people are trying to use MRI technology approach to ultrasound. Ultrasound, what makes a muscle sick is the loss of the normal hypoechoic fibers, and so what's bright in the muscle is the connective tissue, the epimysium, paramysium, those things. And when you have a loss of the healthy dark hypoechoic muscle, just the atrophy and axonal death causing muscle loss is going to make it brighter, more than probably you do an MRI. It's not just fatty infiltration. Okay, so we're gonna, I can show some other examples. I showed you the focal denervation. This is an example of a myopathy, by the way, in FSH compared to You know, I don't look like the Arnold Schwarzenegger picture, but that's my biceps compared to someone with FSH. Here's an example of complete destruction of the muscle. This is somebody with a complete or a spinal accessory neuropathy. So this is completely denervated, but we still see the architecture of the muscle, where we don't in myopathy so much. In smaller degrees of that it gets a little harder, but we're working on some AI systems that help us. You know, here's a denervated hand compared to the normal side. This is somebody from a zone 2 ulnar injury here. And look at the localization we can do in that zone 2 injury with muscle. There's the ADM, that's the fourth dorsal interosseous. Okay, we talked about the rotator cuff. Now sometimes just from disuse you get fatty infiltration and it looks bright, you know, from a complete rotator cuff tear,
Yeah.
right? And so what do we do in that case? And the answer is that's where you add the EMG component with it. And so that gives us an idea of both the appearance of it, and it gives us also the electrophysiology of how much is denervation. We'll see this all the time with people overestimate even a carpal tunnel if somebody's got CMC arthropathy. It changes the motor point that you record from, and it also just atrophies from disuse because they don't use that hand very much. And so we don't want to subscribe that to being neurogenic atrophy if it's not, and using the needle EMG assessment helps with that delineation. So does ultrasound actually, because it's going to look in a disuse one, you're going to still maintain some of the hypoechoic appearance, and it's become more hyperechoic in a denervation state.
So can I ask you a question?
Of course.
So, not very common, but a common scenario that we see, let's say someone has a fracture dislocation. Okay?
Has a
Fracture dislocation of the shoulder.
Sure.
Okay? Axillary nerve is out, but this is time 0. And now reverse shoulder arthroplasty is recommended for this comminuted fracture in older patient. The problem is time 0, we don't know what's the status of the axillary nerve. And someone will calling it, they're not comfortable, and many times it is in the what we call it the blind spot area, like the injury is around inside the deltoid. Are you able with the ultrasound at time 0 before getting the patient into surgery to see the axillary nerve to see where, if there's an injury, to tell the surgeon?
Up under the deltoid, as it's passing.
Like, can you see the whole axillary nerve?
In fact, I'd like to make a comment here. We have some great equipment back here in the exhibit hall, and we can show you some of these things. And I'd encourage everybody to go kind of look at that. You can't do these courses without seeing the exhibitors and go see that. But I can show you the axillary nerve. You can see all of it. So you can follow the course of it. And so you're right, you're not going to see muscle denervation in that scenario. But what you can see, bone fragments and scar and things that are affecting the nerve directly. So you can, you know, that's why I pointed out that little tiny nerve in the first web space. You can see those.
So thank you, because Rene, I'm very interested, because in my general, when I ask for ultrasound, they say no, get an MRI. Well, Justin likes an MRI more also because it shows the nerve better. And sometimes, okay, sudden for MRI, yeah, I don't think we see some hematoma here and there, and now we're telling you can see it by ultrasound.
I am telling you that, and
so Rene,
it's not easy. It's a deep curving nerve, and it takes some acumen and some work to do it. Well, okay, you know, so I come from the fattest. In 2000, we were the fattest city in the United States. Yeah, thank you. But we're not anymore. We're like 18th, and you know, the mayor came up with a commit to be fit thing, and we, you know, but then actually, if you look at the data, we didn't really get any better. Just other cities caught up. But you're right. BMI makes a difference. Yeah. So
what about the suprascapular nerve? Can you see it very well all the way as well?
All the way.
So this
if you don't believe me, I'll show you in the exhibit hall.
I believe you. I just want to make sure, because this is a.
It's hard, so it's very easy to see when it comes off the superior trunk, right? It's easy to see, and it goes under the omohyoid, and you can follow it backwards as it gets deep under the trapezius. It's hard, but what I tell people to do those things is you have to change the settings on the equipment. So you have to go to deeper, and then you can follow it and do back and forth scanning. And then by the time you get to the suprascapular notch, you can see it very easily. So
because there's certain fracture of the scapula that the nerve is transected, in fact, and they cannot see it because of the CT scan. But now you're saying in ultrasound we can follow the nerve into that area, and you'll be able to see if the nerve is injured.
And nothing's infallible. Okay, it doesn't mean there's not a situation where I'm not going to be able to see it, right? And be confident. But there's a lot of clues. And so it's a really good modality for that. Yeah. If I can just make one last comment of, And don't forget here's the shoulder. Don't forget, you know, when you see the dynamic part, you know, looking at the joints with ultrasound is part of this transfer process. You know, you certainly don't want to transfer something where you have, you know, gout or you have torn tendons, or, you know, it's really good at looking at muscle strains, muscle hematomas, all kinds of other things. Chronic strains will look a little bit like denervation, like a hamstring strain. We'll see those. I see all these professional athletes with these, and it'll look hyperechoic, but it's going to be localized to just a particular area in the muscle. And don't forget about muscle herniations and things that can factor in. Okay, vascular anomalies, infections, thrombosis, tendons. There's a nice tendon there, and bursitis. So those are, you know, that's a bursitis that could potentially affect the median nerve. That's the biceps tendon here. So this is the bicipital radial bursa. You know, how has this tendon been repaired, and then what's the status of the tendon repair? All those things might come into play. There's hardware where you get attrition of some of the flexor tendons or extensor tendons. So that's pretty much it. Thanks.
Thank you very much. Any more questions?
Sorry, I have one more question.
Great question. No, you're doing great questions. I'm going to come down here.
No,
Get out of that evil spotlight.
Because you mentioned something about dystrophy. You mentioned something about FSHD, FSH. Like you said the myopathy.
Yeah.
So if someone, like, sometimes we diagnose them on the spot, like they don't have diagnosis, and we have to send them through genetic testing and etc. So do you think if someone visually, like trapezius atrophy, myopathic, look like FSHD, through ultrasound you can say, yeah, this is an FSHD?
So just like everything though, all these tests we see this over and over to our med students. It's an extension of your history and physical, what they're presenting with, what they're complaining of. So nothing's just there in isolation. Not the EDX, not the MRI. To do good practice, you have to, what's the presentation, right? So that's part of it. But even, we'll use this, for example, like the most common acquired myopathy after 50 is inclusion body myositis, right? And we'll see a classic pattern of what looks like almost denervation of the medial flexor digitorum profundus with sparing of the FCU, those kind of scenarios. So we'll see that pattern of change. We'll see a pattern in FSH that it allows you to say that really looks like that, or even motion of things in ALS. You know, we can see fasciculations and see denervation patterns without having to stick needles in all the cranial innervation. You know, we can do it in much more diffuse pattern. So it's got a lot of value for neuromuscular conditions like that.
And what's your take on the quadratic space syndrome when there's only pain, no atrophy?
Only pain?
Yes, like you have pain and you have tenderness.
I love that question. So I'm going to expand it beyond quadrilateral space. Okay, and we were talking about like Sunderland 0, I guess we called it. Okay, so nerves can hurt without neurologic deficit, right? We all know that. We know that has. So think of, you know, if you talk to EMGers, radial tunnel doesn't exist. You talk to the pain management people, it's in everybody. But what we'll see, and we'll see that with ulnar nerves, we'll see it in the quadrilateral space, you'll see nerve enlargement in the absence of neurologic deficit. They may have tingling, but the difference between tingling and true sensory loss, right, is critical. You know, but you'll see focal enlargement besides beyond certain criteria. You're over 2 millimeters squared of the deep branch of the radial nerve in the supinator. You know, that's abnormal. That means it's under pressure and it fits your clinical exam. Same thing if you feel like they're clinically getting pain from there and you could see an enlargement of the nerve, or if you see a posterior labral cyst or some other thing or some fascial scar, you know, those are all things that help you. Yeah, great questions.
Well, good morning, everybody. So, you know, the reason I got into this field is a lot of neurosurgeons really aren't exposed to nerve surgery, even though it exists. And I happened to be there at the same time Justin came to Mass General, and he was giving a talk on this, and I was amazed and been attached ever since to him for the last 5 years. So, no disclosures. I guess the only disclosure I should make is I haven't done any of this in practice yet, so you may not want to listen too closely. But I, you know, Justin, we set a goal, you know, for him to get these nerve transfers published. So we did a series of operative neurosurgery for technique, and then another one with the outcomes in neurosurgery. So we're almost done, I think, maybe a couple more to go on that. So in terms of spinal cord injury, I mean, I myself included, and probably most neurosurgeons, at least in America, you know, when they think spinal cord injury interventions, you know, you think direct repair, everybody thinks stem cells, you know, everybody wants to just take a pint of stem cell juice and, you know, their spine's going to get better. And they pretty much blast about everything they could to try to get direct repair, and we're just not there yet. I mean, I'm sure it's a worthwhile endeavor, but it's going to be some time. But really, what we have right now is the capability to take advantage of what's already there, and you know, with the leverage this preserved circuitry and redundant circuitry to get more function. So 2 ways to do that. One is neural interfacing, and where I'm at Case Western, they've done a lot of that with the freehand system, and then the neural network prosthesis, the next evolution, which, you know, it sounds like I'm not as familiar with it, but people have been happy with it. The part I'm directly involved in is the extension of BrainGate with the brain-computer interface into the FES, and we still got quite a bit to go on that, I would say. But really, the nerve and tendon transfers, we need to increase awareness of this. And you know, everybody wants a cure for everything, but you know, as we can see here, just going up, you know, an injury level, you know, can drastically increase your function, which is what we can offer with nerve and tendon transfers. So this is not just to advocate for nerve transfers. I believe it's a combinatorial approach to, you know, to gain function. Nerve transfers are nice because you can restore the natural biomechanics and the anatomy of the muscle and the direction of the force. So it's independent of the muscle mechanics, and I think one of the bigger things, though, is that expands your donor options. You have more to work with. There is minimal to no postoperative immobilization, which I know is an issue with some of the tendon people, but you're waiting a long time to get your nerve to grow back. But at least you're not losing function in the meantime and the independence. So you can also innervate multiple targets, which is also a problem too, because now you get dispersion of axons and you can not get as much to your desired target. A key here that I'll talk about too is you got to assess the degree of denervation, because as Ross talked about earlier, you can't get a lot of collateral innervation, and now when you lose axons jumping the repair gap, you may not get that a good recovery if you're at kind of the tail, if you're at a little bit like you see in polio. But the biggest problem with nerve transfers is the time constraint, and that's the big reason we have to keep people aware of all this, because the earlier we get there, the more options we have. And typically this is a diagram you see looking at spinal cord injury. You got the, you know, levels 1, 2, and 3 here. Normal is the, you know, zone 1, where you have volitional innervation to the muscles. 2 is the injury zone. So there you have a lower motor neuron injury because your spinal motor neurons have been beat up. And then below there you have non-volitional but innervated muscle groups. So, you know, if you get there early enough, you can recover zone 2. And zone 3, we find in general that you can recover at any time point to make volitional. And now with neural interfacing, it's potentially valuable to go from 3 to 2 if you can, and then subsequently stimulate that, which I've noticed is a big problem in our in the rehab project, in the FES project I'm doing. So you got to make a plan. You give natural 6 to 12 months of recovery time. Everybody seems a little different on that, but I wouldn't go any earlier than 6 months. Justin, I think we're going 9 to 12 still for you?
9,
yeah. And then you got to assess the damage and see what you're working with. This is through physical exam. We're very heavy on electrodiagnostics, on doing EMG, quantitative EMG to see what the donor has to offer. And then you got to make sure you do that for the backup function too, to make sure you're not actually losing anything. And then in terms of timing, to see if the muscle is denervated, we'll do high frequency stimulation to see what the status of that muscle is. So then we try to get the closest available donors to the targets and movement that is synergistic for better rehabilitation later. So then we have the re-education with that on relearning the new movements. And then Dr. Growitz, and we'll talk about later, with more of the tendon transfers and hand intrinsics that is necessary as well at the end here. And there's also addressing spasticity, which somebody else will also talk about too, and also the rehab component of it. So I'm just focusing more on our nerve part here. So as I said, what's really great about these nerve transfers is the expansion of donors, especially in that C5 level now, where you have spinal accessory to offer, and now you have variations of axillary, brachialis, and supinator, which you wouldn't have otherwise, that are not favorable tendon transfers. So, and here's the, our Tetraplegia hand score here, just going through the, okay. Yeah, just, obviously have more options, the more spared spinal cord tissue you have. So this was created for tendon transfers, but now this opens up now to include the nerve transfers. And we also use the ECRB and PT for nerve transfers as well. So the Frieden group put out kind of a algorithm for what they have, or their reconstructive plan based on what level you're at. And typically, we've been doing the same kind of approach where you have elbow flexion, right, and you have variation of supinator, and you always have shoulder function typically in these C5, C6 patients, which is most of the ones we're seeing. So our goal is to reanimate elbow extension, and typically we do that with teres minor to the long head of the triceps, and then for finger opening with supinator PIN. And then it depends on what we have to work with in terms of looking at finger flexion. So a lot of times it's just brachialis at that C5 level for us to work with, so that's what we've been using, which has traditionally been poor. And you get much better results out of the distal transfers, such as ECRB and pronator teres. And then you can always have brachioradialis to strengthen your hand function at the end of the day there. Or in a hand score 0 or 1, you can use it for wrist extension. And then you have your subsequent your intrinsic procedures later, which we typically wait until we see recovery from the nerve transfers and see what we're doing with these. So our first example is just running through the axillary to the tricep. So we typically take teres minor, and then you have infraspinatus as a backup. So we've had some difficulty assessing this in the past, and so we've talked about this quite a bit here. Is how do we determine how good teres minor is? It's tough because a lot of the EMG people will get the trap instead of the teres minor, or the infraspinatus can overwhelm the teres minor. So we believe it's nice to do this under ultrasound. MRI can be helpful, which we talked about earlier. And then you have 3 heads of the tricep, and we go for the long head of the tricep. So key, we get redundancy with the infraspinatus. And then the triceps are often, 90% of the time in these C5-6 injuries, the triceps are denervated. So it's very important to try to get to this early. It's our video plan. So again, teres minor, we take an anterior approach for this, which works nicely. If we go for intra-op stimulation and the teres minor doesn't seem like it's adequate, then we can also take the posterior delt. If we still have issues with that, then we've taken branches of the anterior division as well. And a key here is to, better diagram here. Here we have it separated out, teres minor, the posterior division, anterior division. And just if you're taking that posterior division, we try to make sure we avoid that cutaneous branch there. So here's our anterior approach. So our results for this were roughly similar to the field from what the Van Zyl group reported to. She was around 60% of getting the anti-gravity elbow extension. Out of those, 10 of those 13 were M4 strength as well. So this is very important for increasing your workspace. So in terms of prognostic value, we did find that teres minor, when that was used alone, really had our best results. And my thought with that is probably just if the teres minor took a hit, probably the other ones have some sort of a hit too, and maybe you're not getting as good of a axon donor load into the recipient. And then when we found that the hand scores of 3 and 4, they all did very well. We're all M4 strength, suggesting that we had good donor supply. So in our publication here, we try to be very clear about what we did. So we showed an example of all the patients in there, if you look at that online. And we showed every patient, all the data for each one in there as well. So now supinator to PIN, that's the one everybody likes to talk about because the results have been pretty great across the board. It's you have the donor right next to the recipient. We just snip the supinator branches here and just put them right into the PIN. We find a variation of 2 to 4 branches, a lot of times 2, and we take all the branches there and put that in and make sure we do it by stimming proximally and making sure we have everything. And the idea here is we have the biceps as a backup, so we don't lose supination, which is one of the reasons against the tendon transfer going biceps to try. And also we have the posterior deltoid as a backup as well if we just take the teres minor. So here we published on our outcomes too, which, like I said, has been favorable across the board. Here at our MRC, we achieved 3 and about 80-90% for the finger extension and the EPL. And we had a lot of chronic injuries, and here we just demonstrated that these did as well as the acute injuries as well if you hit these later. So it's still an option many years out. And one of the main findings that I thought was interesting from this is that your tetraplegia, your hand score of 0 or 1, 6 out of the 7 failures we had were at that level, suggesting that the supinator most likely took a hit. So, but we also had ones that did well. So I think one of the things in the future we need to look at is how do we delineate what's going to do better out of those or not, and at least we can counsel the patient better of those chances. So here we also, recorded some of the angles that are in the publication, and then we saw extensive variation based on, did they have intrinsics or not? Did they have flexor spasticity? And here's our averages down there in our medians. And again, we try to get everybody within a year if it's an acute denervation. So really the problem that everybody knows has been finger flexion, and that's been most common into the anterior interosseous nerve. So there was a recent review done, I think it was headed by the Northwestern group, just showing that the distal donors do very well, as you can see with ECRB, pronator teres, but in most of our transfers, that's not available to us. And here's an example of them. There, you have 2 branches of the pronator, and we typically take the distal branch and plug it into the AIN. And then, but like I said, mostly we're doing this brachialis, and here in the study, most of those transfers are brachialis, and even including brachial plexus, where they tend to get to them earlier than spinal cord injury, they're still at 59%, which is quite a bit lower than our other ones. And if there's 2 main approaches to this, and one is just starting distally and following that AIN all the way proximal, which is a very tedious and painful dissection, and the other one is the topographical method where we just plug out the AIN proximally. And as you can see, and I think this is where Justin noticed early on, something needed to change with this, because he wasn't getting good results, neither was anybody else. And here you can see 30% from that topographical one. So what's the issue? Is it just that it's closer to the target? So it really seems to be those interweaving connections between the median nerve and the AIN. And this was a recent, and this is what we've talked about for a while, and he's been trying to address, and just recently Osmond's group put out this paper on the anatomy just showing how extensive these connections are. So what what really seems to be the main problem is bypassing these connections. If you're too proximal, you're going to get too much axon dispersion. And then if you're trying to weave back, you're probably losing a lot of the inputs to the AIN. They're getting transected. And it's also not a fun procedure. So the approach was, how do we bypass these connections? So this was our technique report that we just put out. Here's showing these connections here. So we take 2 approaches to this. One approach was, do we just bypass it with a graft? And really a benefit here because you're getting all of brachialis and it's going into all of AIN. So you're getting everything to where you want it to go, but then again, now you have an extra coaptation, so you need to make sure you got enough axons getting sent down. Originally, we were doing these with the sural nerve, but now you can just take the MABC, which we've switched to take a local and get rid of the extra morbidity of the donor site. So in stage 1, we're going proximal, we're getting brachialis, and then what we're doing, like we do when we put shunts in, we'll tunnel it distally. I'll speed this up a bit. With our tunneler here. And then we'll just make a little hole here to come back and get later. So we'll wait anywhere after 6 months. We've waited quite a bit because sometimes they don't have good follow-up. I think we've done some a year and a half later up to on this second stage. So what's nice about this is by waiting and not doing the graft right away, we postpone the denervation process in the recipient muscle. So that's our idea there, to keep that more robust by the time the axon gets there. And then we go and we hook it up. But again, here you can see, right, we're getting all the donor into all the recipient we want. So the other method, especially if we find that the AIN is denervated and we need to get in there quicker, is to do the direct repair with a limb positioning. And that's what we're showing here. Here's the gap before we bend the elbow, and then we can achieve that repair. And then we just gradually, we'll let it sit for a month and then gradually extend it over the several weeks later. So again, the outcomes were pretty poor earlier, and excluding the brachial plexus stuff, we looked at 5 of the largest spinal cord injury series, and we saw only 42% got an M3 recovery in the second digit, and then 40% in the thumb. So pretty poor. And then with our modified technique here, we've had significant improvement on this. So we think this has made a big change for us. And here we're looking at 71% for FPL, and then 12 of that is M4 strength. And here are other values here. So this includes both indirect and direct, and they actually have pretty similar outcomes. We had a little bit of difference in thumb and FDP2, but in general they were the same. And you'll even start doing the indirect, even if it is denervated, if it's earlier enough now, if I recall. You like it that much. And
Yeah.
so again, we got the brachialis, we got the biceps to back it up. And this is just a SUPIN and brachialis AIN. So we're in the process of getting this published now. So we're looking to try to find no more than just MRC, because we all know that that's pretty subjective. So we're putting together different angles that we're summating that'll all be in the paper that's coming out, and we're looking at like a kind of a grading scale of how much the hand's closing. So that's coming. So moving forward, I think we want, maybe it's the quantitative EMG, and when you are doing quantitative EMG, you got to make sure you're doing enough sampling points. I think that's key. And how do you assess reinnervation is, you got to check, equal distribution throughout the muscle. So if we can get good indicators for that, and we can tell people how they're going to do in these, higher level injuries. I never knew about any of this. Most of my neurosurgical, friends don't know about these procedures. So we need to increase awareness, because we can actually help people with this and get them there earlier. And then I think we really need better, standardization and objective outcomes. I'm working on some of the, 3D capture stuff. How do we get forces better? And we need more of them. So I think the next step here is I'm just presenting the nerve stuff. But then, once we get the intrinsics and all the other tendon transfers, then we'll hopefully follow up with all the functional work. And then just one thing I thought I'd throw out here. It's been great working with Justin, because he's very innovative, always looking for why things are doing what they're doing. So we've extended this into, he's been working on bladder project for many years now. And we just published this last year for conus injuries. Here showing the sacral roots were resected with a chordoma. And then we successfully was able to give him volitional bladder function through an obturator to the vesical branches from the pelvic ganglia. So, all right. So thank you, everybody. And he's got his posse over here. That's all been helping. So thank you.
All right, Andreas, you can tell us tendons are better? So we'll probably hold discussion to the end after we have a little of We got two different approaches, as most of the audience probably knows now. The nerve transfers are more recent introduction, but tendon transfers have been done for decades now and really have a lot of foundation behind them. This is truly one of the experts.
Okay. So thank you very much for inviting me. It's a great honor for me. The title that I was given irritated me a bit. So I had to put the remain into parentheses. I'm originally from Munich. I work in Basel, which is in the middle of Europe, as you see here. And I have no disclosures, but I would like to say that I have had and have collaborations with other colleagues, and I have learned a lot from them, most from Jan Fridén. We worked together in the Swiss Paraplegia Center. I worked 1 year with Oskar Assmann, and I'm collaborating and visiting hospitals in Germany and Austria, and I have been to Cuba and to Vietnam together with Cesco Soldado and Jaime Bertelli, and I also learned a lot from them. So just a little excursion into the history. I come from Germany, as I said, and the godfather of reconstructive neurosurgery was probably Adolf Stoffel, who around 1909-10 did nerve studies and discovered that nerves are unlike tendons, so they consist of Nervenbahnen, nerve railways, and they have a specific motor and sensory fiber distribution, what he called topography or topography. And he devised two clinical applications. First, selective neurectomy in spasticity, and second, selective nerve transfers in peripheral nerve injury of the face, of the hip, interestingly, so the gluteal muscles, and the upper and lower extremity. You see him here, and you see an old nerve transfer, spinal accessory to facial nerve in this patient who closes his eye by elevating his shoulder. And there's an interesting quotation about his early work, because in 1913, his mentor said about nerve transfer and tendon transfer, if we compare today the status and safety of the successes of tendon transfers versus nerve plasty, the first appears at Goliath. But it can be guessed that in nerve transfer, a victorious David is rising. And I had the pleasure to go to the Museum of Prado with Jorge Clifton just a few weeks ago, and we saw the picture of David and Goliath. And David was not very kind, to say the least, to poor Goliath, because he cut off his head. So if we associate David with nerve transfers are really young, smart, and elegant, and they provide a lot of interesting advantages. And they have put also limb reconstruction, spinal cord injury on the agenda. So it's a hot topic. It's interesting for a lot of people. Also, nerve transfers have solved the problem of how to open the hand by the spin transfer. They offer a different style of hand, and they are safe, and you can do them bilaterally. However, there are also some limitations, and even if you're a nerve enthusiast, as I am, sometimes you think we have gone from tendon to nerve transfers, and now should we go back? Because with the rise of the nerve transfers, we have seen variable results and limitations, and there's the dilemma that sometimes we expect and promise a lot, but in real life we cannot always deliver. And also, we see that tendon transfers are not always like Goliath, clumsy and knocked out. So the objective of this talk is to give you a clinical decision-making framework by using a narrative review. And I would like to analyze 10 different clinical situations where, in my opinion, tendon transfer is still better than nerve transfer. And as we are in a Christian atmosphere here in the university, I've permitted myself to call those the Tendon commandments of tetra hand surgery. So you should strongly consider tendon transfer in these 10 different situations. The first is chronic muscle denervation, which is rather frequent. So you have a delayed referral, or you have an evidence of a lower motor neuron injury. For example, regarding the triceps, and you're not sure if it's a good idea to do a nerve transfer because the recipient muscle is probably not a reliable end organ anymore. And the tendon transfer bypasses this problem because it's independent of surviving motor end plates, and it can outperform nerve transfers in these situations. You can also combine nerve and tendon transfer, so do a turbo procedure and have both. For example, as was described by Biondi for the elbow extension. And this situation, unfortunately, is quite frequent because if you look at the literature, there's a study of more than 100,000 spinal cord injury cases from the US, and only about 1% got upper extremity reconstruction anyway. So you have to anticipate that if the patients come, they will not be seen early, they will become probably beyond this time window for nerve surgery. And we have published a review article in the Deutsche Ärzteblatt, which is sent to all German physicians, and we thought, okay, now everyone should know about this. It took us 3 years to go through endless revisions, but to say the least, the resonance was very modest. So we got about 3 phone calls and about 3 patients from that. So regarding nerve transfers, you have advantages if you're early and if you have a young patient with a limb that is not too heavy, but you also have some risk factors because sometimes the donor nerve is difficult to examine, and you have histological evidence for additional compression. And there are patients, for example, the C4 patients who recovered to be a C5-6 pattern. They are very unreliable, and the results of nerve transfer for elbow extension are not very good. So the second situation is if you need really stability, for example, in the thumb or in the wrist, when the wrist is deviating and you lose a lot of force by radial deviation, and you cannot really correct this with a nerve transfer. You need tendon procedures such as the ECU tenodesis or stabilizing tendon transfers around the thumb. The third situation is if the patient really needs powerful finger flexion for grasp. So if it needs to be a load-bearing grasp to firmly hold objects and not only a visible on a video clip, but it needs to be really strong flexion. For example, to grip the wheel of the wheelchair. And we have established tendon transfers that are very reliable. Unfortunately, the nerve transfers are not always that reliable. So I think tendon transfers are probably a better choice in many patients regarding this requirement. The same, in my opinion, goes for strong thumb flexion. When you need a forceful key or lateral pinch, so you need thumb flexion under load, and there you usually have the BR that you can transfer onto the FPL, which reproduces a strong thumb flexion strength. And in many patients where you do the nerve transfer, it's a more elegant motion, but it's not as strong as a tendon transfer. So this is an example of a patient that only had this transfer, and it was done more than 30 years ago, and still he can guide almost his entire life without additional help, because he has one good hand where he can manipulate many things in his daily life. So if we look at the literature, and that's the result of Natasha von Zyl, she did a lot of nerve transfers, and she produced good results functionally, but in general they had less power, less strength than the conventional tendon transfers when she used the AIN regarding both the finger flexion and thumb flexion. So if you do these nerve transfers, you don't burn any bridges, but if you do the tendon transfers, it's probably stronger. And you can also combine the two procedures. You can do one side a nerve procedure and the other side a tendon procedures, so you have the best of both methods for one patient, and he can do the requirements where he needs more force with the tendon transfer side, and give, for example, his more supple hand, a more elegant hand with a nerve transfer when he greets somebody. So the fifth situation is if you need an intrinsic reconstruction, or you want to correct clawing of the fingers. There's no nerve transfer for that. So you need a tendon transfer-based balancing procedure. One example is, for example, the FDS4 four-tailed procedure in a patient with tetraplegia due to Guillain-Barré syndrome. The sixth situation is an interesting one. It's if you have a patient that had already a nerve transfer, and the reinnervation was not entirely successful, so he probably got an M2 or M3 result where he needed an M4 result, and he has already waited for a long time, so you can give this patient a good pragmatic salvage procedure by using a tendon transfer that is, in most of the cases, still possible. Then, for example, if you do a spin procedure, so you reanimate all the radial innervated extensors of the fingers and thumb, you sometimes reinnervate muscles that you do not really need. For example, you have an additional extensor of the little finger, the EDM, and if the EDM reaches M3, then you can secondarily transfer it, for example, giving the patient an APB function and restore his palmar abduction so he can move his thumb on the index. It's a bit of a special situation, but that's my number 7. Then number 8, we are coming near the end. It's patients that have donor nerves where you have doubts about the quality, for example, incomplete spinal cord injuries, or in rare cases. So, for example, Guillain-Barré, transverse myelitis, recovered C4 patients, or, as I said, incomplete spinal cord injury. I think tendon transfer is more reliable because you do not have partial donor nerves, and you don't have to wait for a speculative regeneration. You can just use the simple method with good mechanics and create good results. So this is an example. So we have more and more infection-related spinal cord injury or spinal cord injury-like paralysis pattern. This is a group X, so exceptional, categorized young female with a transverse myelitis, pre-op. So as you see, she has very feeble grip strength. She can hold the pen, but not really write. This is me directly after the operation. So this is tenodesis effect. You see a lot of incisions. And that's the post-operative result, where she can grasp, pinch the pen and write, and also do things that normally you can only do yourself. For women, it's probably, how do you say in English, put on colors or lipstick, and yeah, she's also, so she can also manipulate these fine tuning activities. So the last is patients with an advanced age. Normally we always think that spinal cord injury patients are quite young, but there's a growing group of these patients, and they have probably slower axonal regeneration regarding nerve transfers, but tendon transfers still are quite safe and successful, and lead to a return of function within a finite rehabilitation horizon, because these patients are not really willing to wait 2 years until the nerve transfer kicks in. And this is an example from when I worked in Notteville. This was a 66-year-old patient, 47 years after spinal cord injury. We did a BR on ECRB and then a passive key pinch. And this is the first alphabet procedure that I ever assisted when Jan Friedin came to Germany and operated on this almost 70-year-old patient who wanted a manly grip and got a grasp of 9 kilogram. And this is a patient that I operated 4 weeks ago in Salzburg, also with an alphabet procedure. So the last group is when you really need a reliable function within short period. And this is the commandment that in a way summarizes the philosophy of the entire talk. So biomechanics often delivers independence earlier and more reliable than biology can. So you can directly compare the two approaches regarding the prerequisite biology, the time to get a useful function, the force generation, the alignment and posture, and the failure mode. And there are best case indications for both methods, and also strategic role. So in conclusion, the Tendon commandments define clinical scenarios where, in my opinion, tendon transfers are still probably better than nerve transfers, and tendon transfers remain indispensable, in my opinion, particularly when reliability, force generation, and time to function are critical. I want to come back to the picture of David against Goliath. So, as a motto of this Congress is innovation, is integration. We have to say that in tetrahand surgery, David should not fight against Goliath, but together they should go for the patient's goals. So thank you to my mentors and my inspirators, including Justin, who challenged me to give this talk. And thank you very much for your kind attention. And I want to invite you not only to Basel, to the FESH Congress in June, but most of all to the next Stoke Mandeville World Tetrahand meeting, which will be in September 26. Thank you very much.
So you're saying there's still a role, huh? I'm just teasing you. Yeah, so I think integration of both these, and Dr. Lim, come on up, is always necessary. We get the foundation with the nerve transfers, and then we fine tune that with the intrinsic correction, the IP joint extension, using the brachioradialis to get whatever's missing at the end there. But I think integrating them both is critical. Well, Dr. Lim, I came across one of your papers because I get these automatic emails in the morning, something you might be interested in. And this one came across. I said, that's a fascinating concept. And then we happened to meet in Spain recently. And so thank you for coming out.
Thank you very much, Justin, for this opportunity. And yeah, so this presentation will sit between David and Goliath and combine them. I think it's mostly an anatomic paper. And as far as the options available, it covers all forms of nerve injury that we have, spasticity and trauma, and not just tetraplegia. Just as a note to the neurosurgeons out there, I wanted to become a neurosurgeon. And one night I was operating with the head of the national unit. It was a depressed skull fracture, and I dropped a piece of the skull on the floor. And after that, I realized, and he made me understand that neurosurgery was not an option. So I became an orthopedic surgeon. Okay, so let's start with the clinical case. And this is a 49-year-old electrician. He had amputation through the distal humerus. We managed to replant the arm and save the joint, but he had lost his biceps and his brachialis. Now, what you see here is triceps muscle that's been treated by Sealer's technique. And here you can see the long head of the triceps, and with a nerve to the long head of the triceps coming in here. So essentially supplying one of the heads of the triceps and one compartment. And so in this case, we separated out the long head of the triceps. You can see that's a pretty good contraction. And we transferred it into the biceps tendon. And so here, this is the important slide. So it shows here that the elbow was able to flex at 6 months operatively. And we did EMG studies. When the triceps, the long head of triceps flexed, that's the new biceps, the lateral head of the triceps was flat. And when the elbow was extended, the lateral head of the triceps fired, but the long head was flat. So proving that you can get independent function from one muscle. And this was based on the concept that muscles are modular, and that's why split tendon and nerve muscles, nerve transfers work. So the surgical implications are that multi-compartment muscle can be split without sacrificing the whole. Each compartment retains independent contractile function after transfer. One donor muscle can give you independent motor reconstructions. And when you have scarce donors, you have expanded armamentarium. So here you see biceps muscle, also treated by Sealer's technique. And you can see very nicely one branch coming in here and one branch coming in here, supplying both heads of the biceps, giving the opportunity to use one head for different functions, like, for example, pronation of the forearm. The basis for this is anatomic and was based on this paper, which is more than 20 years old already, the intramuscular innervation of upper limb skeletal muscles, where 150 muscles from 10 cadavers were treated by the Sealer's technique, which essentially makes the muscle translucent and stains the nerve within dark blue. And this is what we found from this study, is that we're able to classify muscle morphology. So the first class is trapezoidal-shaped muscles. The second class is by basically unipennate spindle-shaped muscles. Class 2B is bipennate spindle-shaped muscles. Class 2A is, again, a combination of spindle-shaped muscles. The module generally is the spindle. And here you have multiple heads, single tendon, like for the triceps or the biceps. And the last class, 3B, is multiple compartments and multiple tendons. So muscles with multiple compartments, which have multiple nerve branches, are good and potential donors for nerve transfer or tendon transfer. So here, these are examples of the trapezoidal muscles, so the zanconeus, supinator, and pronator quadratus. And here, this is a class 2B muscle, 2 compartments, or bipennate, and this is the FCU. And the FCU is actually a very good muscle for splitting. There are 2 heads. This is the humeral head, and this is the ulnar head. And you can see that there's a long central tendon. This is the insertion into the pisiform that extends very proximally into the muscle. And on either side, you can see the innervation of each compartment on either side of the muscle. Here's the triceps, which we mentioned, 3-compartment muscle. And everyone knows how we can use the nerve to the long head or even the lateral or medial heads for transfer, either the nerve or the whole muscle. And here you have multi-compartment, multi-tendon muscles like the FDBS and FDP, and even these nerves can be used for transfer. Single compartment muscles from another study usually have about 1 primary branch coming off the main nerve trunk. Sometimes it can be 2, sometimes, so that's single compartment muscles. 2 compartment muscles usually have between 1 or 2 primary nerve branches coming off the trunk, and here you can see it's 2 coming off separately from the ulnar nerve. Multi-compartment muscles have multiple primary nerve branches coming off the nerve trunks. It just makes the dissection and the separation easier. What's the anatomic basis for independent neurovascular territories? One is that the nerve entry point is proximal and is determined by the position and orientation of the muscle relative to the passage of the nerve, which makes sense. The intramuscular course, the course of the intramuscular nerve is not affected by the direction of the muscle fibers. And 3, the musculotendinous junction determines the nerve branching. So muscles with proximal tendon junctions, branches course on either side of the tendon, giving rise to separate compartments. And these are the best candidates for division. And this is a study that shows how the nerve supply to muscles is clustered along the forearm. And also you can see the numbers here. These are nerve counts that we did in another study on the same cadaveric base. So let's look at the flexor carpi ulnaris. And here we combine both a split tendon transfer and a split nerve transfer. So this was a shipyard worker. He had a near amputation from a rope. And he lost all his extensors. He lost his FCR, his FDP, ring and little fingers, and so he lost some of his forearm compartment muscles and all the extensors. So we decided to do a free split FCU transfer from the contralateral arm. So this shows the muscle. Everyone can see that this is the FCU. Here's the skin paddle. This is the thinner, less voluminous humeral head, and this is the more voluminous ulnar head. So we use this free transfer to restore thumb and finger flexion for this patient. And here you can see that, that we've harvested, this is a single nerve that came off the ulnar nerve trunk, and it is divided into 2. And the recipients on the volar side of the forearm were 2 branches from the ulnar nerve going to the FDP, which we had debrided previously. So that was it. So here we placed the muscle fixated to the medial epicondyle. Ulnar artery and vena commitantes were anastomosed, and the 2 recipient nerves were the 2 nerves from the debrided FDP. The tendons were transferred dorsally, and the larger humeral head transferred to the EDC tendon, and the smaller humeral head to the EPL tendon. And here we can see that after 3 months, we got independent function. And so here, finger extension with flexion of the thumb. Here you can see the humeral, one head fires and the other one doesn't. And conversely, with thumb extension, with flexion of the fingers, you get firing of the EPL transfer and the ulnar head is flat. So here's, so this basically is proof of concept. And when people worry about the donor side, he was still able to hammer. Finally, this is a split nerve transfer. This patient was a Wing Chun master, and he had a malignant peripheral nerve sheath tumor. So basically, we excised it, and he had a high ulnar, a median nerve palsy. So we did sensory nerve transfers, and what we did was we transferred one branch of the FCU to his pronator teres. And we completed the reconstruction with tendon transfers, so brachioradialis to FPL, and the FDPs, we connected them. And if you see here, he's only able to pronate his forearm by abducting his shoulder. And this is 9 months later, he's able to I'm just waiting for the pronation. So he's able to pronate more naturally without abducting his shoulder. So how about nerve transfers in spinal cord injuries? I don't have that much experience in spinal cord injuries, and I think many of the transfers are excellent and have been described. Is there potential for split nerve transfers? There is, but first I wanted to show the posterior axillary nerve transfer. You can see this is the deltoid, this is the anterior branch, and you can see the posterior branch coming out here. And this is another deltoid, anterior branch, and posterior branch. So actually, when you're doing the transfer of the nerve, you're denervating about 1/3 to 1/4 of the muscle. One potential is the brachialis, and we see that's transferred for the AIN. You can see from this diagram that the brachialis has quite a large number of axons, being a large muscle which is in the proximal, which is in the arm. And this is the lateral cutaneous nerve of the forearm. This is the musculocutaneous nerve. And you can see good sized branches. And here you can see about 2 or 3 going into the substance of the brachialis. So here it's possible to take one of the nerves to the brachialis to use as a nerve transfer. That's a possibility. And here you can see the biceps, and you can see that there are 2 substantial branches. The biceps also has a relatively large number of axons, so that's another possibility. Here, ECRL and ECRB. You can see 2 branches here going to ECRB, ECRL not so well visualized, but you can see that there are a number of branches coming out and going into these 2 muscles, which can be used as nerve transfers. And finally, the pronator teres, which already many people are using as a split transfer. You can see one branch going into the larger head and one branch going into the smaller head. Both can be used. So with that anatomic study, I hope that it's opened up some possibilities, and I'd like to thank you again for this opportunity.
Sorry, can I ask a question?
Yes.
So with the innervation of the biceps seems like multi-compartment, multiple nerves in the biceps muscle, correct?
Biceps is 2 compartments.
2 compartment. Now, do we talk short head, long head, or independent? So we have short head of the biceps, we have long head of the biceps. Is this independent of the short head, long head, or when you do 2 compartment, it means, you know what I mean? I mean, like, if we want to split the transfer of the biceps for extension, and you don't take the whole muscle, you take part of the muscle, would you try to aim short head, long head, and try to split it in order for the brain to be able to do it? Or what will be the best way to use your anatomy to optimize outcome of such a split?
Okay, first is when you want to do the split transfer, biceps have only done 1 split. Yeah. Thanks. For the biceps, I've only done 1 split transfer. And I took 1 head and I I inserted it onto the radius for pronation. But it got stuck and it didn't work. So, I would say first, I haven't used it for extension, but yes, definitely that's a possibility. And first, you need anatomic separation of the muscle, And that's way. And then second is how do you work the functional separation if it's a tendon transfer? And for that, many patients are able to adapt. For example, for the long head of the triceps, actually, when you are extending your elbow and abducting your arm, your long head of triceps is actually quite relaxed.
But when you're talking about anatomic separation or dissection, is this like we're talking about the short head and long head of the biceps, or independent? Like what do you mean exactly by anatomic dissection of the muscle?
When you want to transfer for a split transfer, you need to divide the muscle anatomically as much as you can, while preserving the blood supply.
Thank you.
I'm fascinated by what you presented, and I'm so sorry that I'm very lacking in knowledge of this, but I was just wondering, and because I mentioned this to Dr. Bhatia and actually Dr. Wang before, who have done the lower trunk, the direct coaptation for total plexus palsy. And one of the things that Dr. Bhatia mentioned before was that you would take part of the FCU, which is giving you wrist flexion, but there's no opposition. And he mentioned that he could take part of that FCU and transfer it to do opposition. I've never done it before, obviously, but and Dr. Wayne has done it. So I was wondering, does this your proof of concept of having two motor units, or not two motor units, but two muscle that you can actually separate the individual functions where the patient may be able to do this wrist flexion and the opposition separately? This is the proof that FCU is an ideal muscle to do that?
Yes.
Okay, and also I've had cases also where the radial nerve transfers, the median to radial, and it didn't work. The FCR didn't give that EDC, and then you're stuck with that FCU, which you don't know if you can take that FCU as a donor anymore. Again, I'm interested in, does this proof of concept, or have you had experiences where you take that FCU and you can split it and then to do the independent motions of that extension as a tendon transfer, as a donor for, just you know what I mean, right? Yeah. Is that also?
Yes, FCU and FCR.
FCR also has
a long intramuscular tendon, and usually, there are two branches on each side. You can take one branch of the FCR to do a nerve transfer, and you still keep the FCR, with the other branch in the FCR, you still keep wrist flexion.
So for your tendon transfers using the FCR or FCU, would you usually take in the entire tendon, or you actually do split?
I will always go conventional first.
Okay.
And I will do split when I have no other options.
Okay. Thank you so much. Sorry.
Thank you. And I guess it's the same thing for supinators. If you don't take all the motor branches, they can still do supination itself while they do.
I would suggest always take it all, because biceps does a wonderful job all by itself. And when you take half, you sometimes don't get excellent finger extension. But we're privileged to have Dr. John Wengdell with us, because we need to know how to rehabilitate these patients. We can only do so well on our own. And when they get out of our hands and they're not getting the therapy they need, the results are compromised. And so to get your input is a privilege. Thank you for coming.
Thank you. So I hope you have some energy left before we get to lunch. I will try to talk about what I've been doing during the last 20 years in terms of clinic and research. So the rehab after nerve and tendon transfers, and obviously I have more experience in tendon transfers since it's been around for a long time. So most of my examples will be of tendon transfers, but the basic principles are the same. So I will talk about what we are doing in Gothenburg. So we are doing tendon transfers, tendon lengthenings, and nerve transfers. And I will talk more about that this afternoon. So the guiding principles. I have 4 guiding principles that we integrate in our rehab. So we have the wound healing that we need to take in account as therapists. We have the motor learning, we have the optimizing of the motor functions, and we also, of course, need to integrate this in daily use. And I will briefly go through these components, and then I will show you how we do it in real life. So it's nothing fancy. We do work a lot with our hands and not much of a robotic training. Wound healing, you know all about this as surgeons. I don't need to elaborate on that, but as a therapist, I must be aware of fibrosis development and adhesions, especially for tendons then. Motor learning, I don't know how much you know, but we start with the cognitive phase, realizing what's happening. What used to be my supinator is now my finger extensors. How do I activate this? It's a lot of brain capacity training. Then we have the associative stage, where you put this movement into a movement pattern or skills training. And in the end, we have the autonomous stage, where we integrate it in daily activities. And then we have, for the nerve transfers, the DARPA protocol has been presented, and it's similar to the motor learning, but in different words. So you have the early phase with the education, you have the middle phase with recipient muscle activation, and you have the late phase with integration in daily life. Optimizing muscle function, this is basic rehabilitation. We work with muscle strengthening, muscle endurance, the movement patterns, and the motor control. We just add on the tendon sliding for the tendon transfers. But for the SCI patients, it's not only about that, because they have a big thing called SCI. And so we have to be aware of that they have their spasticity, they have their possible pain, they have less sensation, which have impact on the activity, on their gripability, on their ability to use compensatory movements. And they also have more impact from the environment. If the table is too high or the seating position is wrong, they might not be able to use their hands. So we as therapists need to be aware of the broader context of the hand therapy, because we have the reintegration in the middle. We were interested in how do the patients actually integrate this regain function in their daily life. So we made a study, and we found this stepwise development. So they found their movement, and then there's a process itself to integrate that in daily life. And for those who's interested, I can talk about this forever. So we won't do that now, because we want lunch. We also, many years ago, described our early active rehabilitation concept, which have two phases, or two legs. The early mobilization of the restored function and the general active daily life during rehabilitation. Because we want to minimize the restrictions and optimize the independence and the outcome. And we also tested it, and it's safe. And I will go through this, and we have also changed this because it's developed for tendon transfers, but we have modified it for tendon lengthenings and nerve transfers as well. So what do we do? Early phase. So with tendon transfers and tendon lengthenings, we start the training within 24 hours after surgery. We do the first training session. So we do that before the swelling occurs, before with a good brain-muscle communication. We do a minimal wrapping so we can easily maintain the movement. And we manufacture the splints to position the hand, to prevent edema, and also to facilitate active daily life. It might sound a bit aggressive to do the training within 24 hours, but we know that it's safe. It has been tested, and I'm sure that my surgeon is doing a great job. So my job is to convince the patient that this is safe. There's no way that you will activate your finger flexors with more than 20 kilos. It's safe. You can do your training. So the initial training, why do we do it? Well, for tendons, we want the tendon sliding. We want to maintain the brain-muscle communication. And we want to avoid the muscle weakness that will occur if we mobilize the hand. And we do that independently of nerve or tendons through donor muscle function, so resistance against the donor motor. And we also initiate the cognitive phase for motor learning. And with that, I mean to concentrate on finding the movement, but also to understand what's actually been happening here. And we were thinking about what's actually happening in the brain. So we took 6 patients, 1 to 10 years after their brachyradialis to thumb flexor reconstruction. And we had healthy controls, and we put them in the MRI. And we asked them to flex their elbows, and that is in red. And as you can see, it doesn't matter, it doesn't change much between the groups. But when we asked them to flex their thumb, the patients didn't change, the motor the pattern in the brain didn't change between the elbow flexors and the thumb flexors. And when we were discussing this last night, it kind of makes sense because of that sensory feedback from the brachyradialis muscle is still the same. So I learned something yesterday. So how do we do this? We do it with patient education. They get their own training program with their own hand on, and with also an explanation on what actually been doing, the surgeon's been doing during surgery. They train 4 times a day, and they need to be in control of that training. And that is to maintain the system sliding, but also for the brain relearning. So I told you that the early active rehabilitation protocol was about early activation of the restored function, but it's also about being active. And why is that so important? Well, it's important to maintain the general fitness that the patient has been working so hard to get. It's to prevent the edema by moving, using the muscle pump. But it's very much to minimize the extra independence and care, and because that is so psychologically important. We have patients who decline surgery because they can't see themselves being dependent. I had a patient who said, I won't do the surgery unless I can pee by myself. So then we solve that problem. We find solutions so they can be as independent as possible during the restriction time. Second stage. In tendon surgeries, it's 3 weeks. In nerves, it's obviously further along in time. Then we can start to work with the associative stage and the anomalous stage, which is fun as a therapist. The motor training, diverse force, diverse speed, different positions, motor control. There's a lot of fun things going on. And we start the translation into daily activities really early. And why is that so important? Well, the patients are a bit afraid in the beginning, especially 3 weeks after surgery. Is it really safe? How do I do this? I don't know. I'm very insecure. But it's also very much about using the grip actively. Not stop doing the passive tenodesis grasp, the whatever. and also to relearn the movement patterns. Stop doing compensatory movements. And also very much because this is the goal of the surgery in the end. And through this process, we are guided by this model. So we work a lot with the belief and the confidence. We make sure that the patients are going in those steps. And by doing that, we encourage them and give them positive feedbacks. So this is an examples. We do skills training related to the goals that the patient sets before surgery. And this guy is 3 weeks after his tendon transfers, and his goal is to pour his colleagues coffee at work. And it's very much the confidence in his ability, and the movement pattern and the movement control. Finally, we also look at the movement pattern and sustainable ergonomics. If you look at him, he has grip on one hand. Oh, wrong. Can he go again? Move? No. He doesn't want to propel. We look at this guy then. So he has a grip here on this side, but he doesn't have a grip on this side. So on this side, he has to push his arm against the push rim. While when he have a grip, he can have a better position. And this is something that they need to relearn after. And we also looked at this more objectively and looked at the shoulder abduction, which we know is bad for the shoulders. And after the tendon transfers, they have less of an abducted position, more like the healthy control, the control that is a paraplegic patient. So in summary, independent of if it's tendon transfers or nerve transfers, they're same basic principles. The only thing is that the timelines are different. And this is also something that we have to consider when we said if we're going to have both David and Goliath. So if we do a nerve transfer early, and then after 6 months we do a tendon transfer, then we have the double process going on at the same time. Maybe that's good, maybe that's bad, but that's something that we need to be aware of when we do the decision making. As I said, we have been publishing a bit around this over the years, and I just want to highlight my colleague Therese Ramström as well, who did her whole PhD on rehabilitation after tendon lengthening in SCI. And with that, I say thank you.
All right. Do we have any questions? I actually have one. What is the biggest limitation you run into in this process where things don't go well from the rehabilitation standpoint?
Say that again.
What do you find are some of the biggest limitations that went into or problems you run into in the rehabilitation process where things don't go well?
I think when things don't go as well as we hoped was when patients weren't mentally there, when we hadn't done our pre-assessment well enough, and then we need to compensate for that later on, and it will take more therapy hours to make the patient on board with what's happening.
Okay.
Are you using electrical stimulation or functional? Are you using electrical stimulation or functional electrical stimulation in this process at all?
In Sweden, in general, we work more with using the brain to actually find the muscles, and sometimes, very rarely, we use electrical stimulation just to get that feedback, but not on a regular basis. But if you would ask in Notville, they would do it always. So I think it's also about traditions. Yeah?
I
where they can actually see the surface EMG on, and you can still tap and do all your other methods, and it gives the patient extra feedback. And what I like is you can actually quantify it, because in the very beginning stages, the patient may be getting really frustrated, they don't see anything. And the second they see just one little tiny action potential, now they're hooked, now they're going to start working. And sometimes you can actually tap, and they'll see it, and then they'll try and do it, and you just go back and forth and back and forth. And it's cheap, it's like $90. You can, I think, pretty much get it on Amazon or on eBay, and I think it's a great thing to do. So I can talk about it with you later if you want.
I would like that as well. But as you could see when we evaluated our concept, all patients could do their movements day after surgery. No one, it was 100%. They could do the movement. And after 3 weeks, they all could integrate it in basic daily activities, and 74% were doing kitchen and crafting and things.
The tendon's going to be a lot different. The tendon's obviously going to be a lot different than the nerve. So there's a tendency to just do everything you can.
And the process is way longer.
Yeah, I mean, I think what it comes down to, if you have a method that's working, you stay with it. If it's working really well, then you can always advance and do other things. But for strictly tendon, you don't really need the EMG if you already have your system up in place. But I think if you're new to the game, and I haven't done a lot of these, by the way, at all, but I've done a lot of nerve rehab, and for me, EMG is fantastic. I love it. So.
And I also think for nerve transfers, it's way more complicated to maintain the motivation for the patients. And then it has to be fun because the process is slower. And then you have to have more interesting training to maintain that.
This is AJ. He is a physical therapist himself, an amazing one if I do say so myself. But he is now kind of just the lead of the marketing and sales here in South Florida. We have over 37 locations just in this little area right here. I'm sure if y'all just walk outside, you'll see one. But we're here just to talk about more of the neuro focus of what we do. Of course, we do see a variety and a very big array of orthopedic injuries, conditions, but he's going to hit a little bit more on just the neuro aspect of it all. This is AJ.
Hi, everyone. AJ Sanchez, been physical therapist for many years. Have treated several conditions, ortho, neurological. But we want to talk about Cora and what we can offer to you guys. So we spend all the time implementing new techniques in the clinics and training our clinicians. We have our own Cora University where we train our own therapists on cutting-edge techniques like dry needling, concussion management, vestibular rehabilitation, and other techniques. So how we can help you guys? We offer several different programs in the orthopedic field, post-surgical cases, but also we do neurological. We treat your post-neurological cases after surgery. We do some patients with after CVAs and after some nerve repairs and other neurological conditions like paralysis and et cetera, et cetera. I want to talk about a couple of specific programs that we do in some of our clinics. One of them is, some of you guys probably are familiar with the LSVT BIG program. The LSVT program, as you guys know, started with a program for speech therapy. Then it was implemented into physical and occupational therapy, mainly to treat Parkinson's patients, right? So the main idea is to implement large movements for patients with Parkinson's to improve their the length of the the gait or the steps, and also improve functional movements like getting up from a chair, transferring from in and out of bed, but also works on some fine motor things like buttoning or simple techniques. So we offer this in selected clinics because it requires a certification. So we have certified clinicians in some clinics, not all of them. But we can offer that program. The program is an hour session for 4 weeks. And the patients also have some home exercises that they had to carry, and we monitor them. So not only what we do at the clinics, but they had to be compliant with the home exercises in order to be successful. When we get the referrals, they have to be a specific referral that says LSVT program. Balance. Also, all our clinics can treat balance. We do balance assessments at the clinics. We use different standardized testings like the Bear Balance and 1080s for gait and balance. We compare that with the standards, and we use actually whatever they don't do right on the testing, we use it for actual treatment, right? So if they have issues like with single leg stands, then we work a lot of single leg stands. If they have problems with the eyes closed, then we spend a lot of time with eyes closed. If they have problems standing or moving on anesthetic surfaces, then we work with that. Use the foam, we use the Bosu balls, or we use those different things to work on that. The other part is the prevention. Our organization has been big on preventing falls. We not only can offer in all our clinics a free screening, so any patient, anybody can call a clinic and say, hey, I want a free screening. And our therapist can take 10 minutes to do a screening and say, hey, tell your doctor to order a script. No, it's fine, maybe something else. Maybe we cannot help you with that because it could be something else. Or we give them some exercises to do at home. Maybe it's something simple. You know what? You don't have much problems with your balance. Your score is almost perfect. Just work a little bit on this, and we give them home exercises. The other thing we do is offer fall prevention at communities. So we go to communities like Central Village. I don't know, over here, whoever is from South Florida, know there's Central Village. There's communities for 55 plus people. But we also do the same thing at large medical centers for the members. So we connect with the medical center and say, hey, we want to offer this talk. Try to get as many members as you can, and we offer a fall prevention talk, which includes sometimes screening, depending on their time. Because sometimes they don't have time, they go quick. Sometimes they go for the freebies that we give. But we offer that, and we try to do it all year round, but it's most frequent during September. It's actually the fall prevention month, so we do it. So all of our centers, we do vestibular rehabilitation. In the vestibular rehabilitation, we assess oculomotor function. We've assessed the possibility of a benign paroxysmal vertigo or other causes of balance issues due to inner ear or vestibular system. And then we do, depending on that assessment and depending on the physician's, testing they do, when they do anisomography, so we get that and we can assess that on our treatment. We do gaze recession, oculomotor training, or we do the Epley maneuver to correct the benign paroxysmal positional vertigo. And all training that we do. It's like failing a little bit. Concussion. We do concussion management, physical therapy in selected clinics because also requires a certification. We normally get the patients after 7-10 days of the trauma if the symptoms persist. And obviously we assess for headaches, we assess for balance issues, for a possible vertigo or neck pain, and then we treat it accordingly. Neck pain, we do soft tissue, we do some light exercises. If it's balance, we work on balance activities. And if it's vestibular, then we obviously work the same thing, the same techniques of vestibular rehabilitation. And that's mostly what we work on concussion. And we also work on other kinds of symptomatology. Okay, let me see. Oh, this is better. Maybe the body is right now. All right, so depending on what is in the assessment and the symptomatology, then we work accordingly with that. Like I said, we have some specialized clinicians in certain clinics, not all of them. And we work on certification for our clinicians in that. Again, this is overall what we offer. We not only offer physical therapy and occupational therapy, but we also offer speech therapy in clinic, only in 2 clinics in South Florida. But we offer speech therapy via telehealth for anyone in South Florida or anyone in the States. Surprisingly, a lot of people is opting to go telehealth. The main reason for it is because speech therapy, trying to find speech therapy services is hard, it's difficult. There's not many places offer it. So a lot of people have to actually go to a hospital system, and if they don't accept the insurance, then a good option is telehealth. As you can see in there, I don't have to repeat it, the other services that we do, but mostly those that I was referring to are the ones related to neuro. Right? Brooke?
I'm back, y'all. All right. Well, I am a sales rep, obviously. But these are all the locations that our clinics are in. I am in Raleigh, North Carolina, personally, but it is fun with my job being able to travel and meet all of y'all. I know you're from all around the world. For the ones that are in any of these states, chances are we have a clinic right next to you, and so feel free to stop in, meet our PTs. We love when all the surgeons stop by, so we do appreciate it. But yeah, if you have any questions, you can come up to us at any time today and answer them. But yeah, if you're in any of these states, please just keep Cora in mind.
Thank you very much, and thank you to all the industry partners for supporting this incredible educational event. We now have 5 more of the free paper research presentations. Just to remind you all that we have a panel of judges, and there will be prizes awarded at the end of the day for the top 3 presentations, I'm assured. So the first presentation is recovery of elbow extension with the axillary to radial nerve transfer, technique and outcomes. And this is a presentation from Margaret Stein.
Hello, everyone. My name is Margaret Sten, and I'm a current 4th-year MD-PhD student at Georgetown. I will be presenting today on our project, the axillary to triceps nerve transfer. I unfortunately do not have disclosures yet. However, I do want to share that the content in this presentation comes from 2 team publications that were a product of a group of people that are here today. So overall, we'll start with the anatomy relevant for this, and then we'll go through the technique and both other people's outcomes as well as our outcomes. So first, the posterior view is really helpful for understanding and reviewing the anatomy. So we have the relevant muscles and the nerves that will be involved. But why are we doing this transfer? So the axillary nerve receives higher level innervation than the radial nerve. And so if we have a spinal cord injury at a lower level, we lose radial nerve function, but we can compensate by transferring the axillary nerve. So what does this actually look like? If we zoom in, you can see the transfer here, and between before and after reinnervation, you can see the muscle restoring function and being reinnervated. Now, while the posterior view is extremely helpful for a review of the anatomy, the anterior view is what will actually be seen intraoperatively. So again, we have the relevant muscles and the nerves and branches that will be used in this transfer. Now, the actual technique itself starts with anesthesia, no muscle paralytics, because we want response to stimulation, and the patient should be in the supine position with the shoulder abducted. Then we're going to come in with the anterior approach. Our incision will circumvent the glandular axillary tissue and then extend into the sulcus dividing the biceps and triceps. We'll dissect down to the latissimus tendon, which will serve as a key landmark, and then we will move proximally to find the axillary nerve, which looks like this intraoperatively, and then we will go superficial to the latissimus tendon to find the radial nerve. Once we've found these, we want to really parse down to the branches that we'll be using. So this will follow a general protocol of find the main nerve that you want to use, stimulate, dissect the branches that you'll be using, and then stimulate to confirm that you do have the branches that you are hoping to have. Once we have found the branches that we're going to be using, we can transect those nerves and bring them together through no tension and 3-layer coaptations. So first, we will directly connect the axillary nerve to the long head of triceps. Then we'll add the collagen tube for structural support and fibrin glue on top of the lot. Post-operative care, the main thing is to ensure that movement is restricted for about 3 weeks post-operatively. But then the next question is, who do we offer this to, and should we be offering it at all? So for that, we can turn to general literature, and to understand the literature that is current with this, we must go over MRC scores, which I think everyone here is probably familiar with, but just in brief review, we have the low-level MRCs 0 and 1, which is this really no functional movement, and these are all for elbow extension with these transfers. And then MRC scores 3 and up are generally considered successful transfers, and this includes good anti-gravity movement. Now, in the middle, we have these MRC scores of 2, which are pretty consistently determined to not be a successful transfer. However, patients report really positive functional improvement within the horizontal plane that they appreciate. So there are 4 main studies in reviewing the literature, and 3 of these are outcome studies. The Bertelli group only included C6 level injury patients, which I will come back to reconcile with our results as well. So we wanted to contribute our own data from the Paralysis Center, and so we started an outcome study with 4 main inclusion criteria, and we ended up with a total of 22 arms. They were mostly male, but we did have a good handful of females, and our primary outcome metric were the final MRC scores on their last follow-up. So we ended up having 22% of the limbs have a not successful transfer with an MRC score of 1, and what that looks like is this. But then 60% of our patients had an MRC score of 3 and above. And it's important to note, which I think Dr. Bazarek mentioned in his presentation as well, 50% of these outcomes were actually MRC scores of 4 or higher, which was a really strong outcome. And then we have that MRC score of 2, which is technically not considered a success to us. However, these patients did have very favorable views of their outcomes. So this held up fairly well to the literature, but there was sort of a question about why does the Bertelli outcomes group have such great outcomes here? And so one of the things we looked at were the ICSHT scores, which indicate level of injury. So the ICSHT scores of 4 correspond with a C7 level injury, while 1 through 3 are C6 levels. And so the Bertelli group outcome study only included C6 level injury patients, and you can see just perhaps they had more ICSHT score of 3 in there, in which case that would reconcile perfectly with our outcomes as well. So then we wanted to look at 2 other factors. We looked at patient age, hypothesizing that older patients might have worse recovery. We were happy to find that that was not the case. And then we looked at patient sex, and we found no functional differences between their final outcomes either. So in conclusion, we report the axillary to triceps nerve transfer as an excellent method for recovery of elbow extension, and we found none of the patients had shoulder deficits, and so we report that this could be an excellent transfer to offer to people regardless of age and sex. However, the evidence is strongest to be provided to patients with ICSHT scores of 3 or higher. References, and thank you very much.
Thank you very much. There are no questions from the panel, so we'll move on to the next presentation, which is time course of elbow flexion recovery following brachial plexus injury and peripheral nerve reconstruction, and that's a presentation from Sam Upton.
All right, good afternoon, everybody. My name is Samuel Upton, and I'm a medical student working with Dr. Brown in the Paralysis Center. We have no disclosures with this talk. So brachial plexus injuries are one of the most devastating injuries affecting the upper extremity and daily life as a whole. And despite our best imaging and surgical tools, we still lack clear and early predictors of who will recover and when. Our goal for this research study was simple. Is to figure out when we can reliably predict who will regain meaningful function and when recovery is unlikely, so clinicians can better counsel patients and time their interventions. So for this, we included 54 patients with brachial plexus injuries and specifically elbow flexion deficits. So 72%, 39 patients underwent surgical reconstruction, and 28% of our patients, 15 of them, were managed with just observation alone. And you can see that. You can see that here. For this study, we focused on the elbow flexion recovery because it's widely recognized as the primary functional goal in brachial plexus injury management. And for each patient, we set time 0 as either the date of injury, so the observation group, or the date of surgery for the elbow flexion recovery group. And among the reconstructions that you can see at the bottom, the Oberlin was the most popular. In order to assess their longitudinal recovery, we evaluated their physical strength via MRC grade and their nerve regeneration from EMG motor unit analysis of the biceps. And motor score is on the Y here, and time from surgery to injury is on the X for both the MRC on the left and the EMG data on the right. Each thin line that you see is one patient's elbow flexion score at the point in time. And from this raw data, you can see two distinct groups emerging. One is steadily inclining towards functional recovery, and some of them are plateauing. For this, we define two recovery thresholds for MRC and EMG. Functional recovery being an MRC value greater than or equal to 3, and you can see 38 of our patients met that by the end. And then for EMG, greater than or equal to 3 motor units in their biceps, and 35 of our patients made it there. To better visualize the recovery trajectory, we color-coded patients that did reach a final recovery, functional recovery as red, and you can see that in the line, and those that didn't as blue, and plotted them further. And looking at the slope, you can see a clear trend telling us that patients who did end up recovering, so in the red, did so at a much faster rate. Now, to make this more clinically useful, we wanted to find when we could reliably divide patients into those who will recover meaningful function and those who don't. To do this, we created a binary classifier model using both the patient's current MRC scores and their rate of MRC improvement over time. And we tested this model at multiple time points, feeding it only the patient's MRC data obtained from 0 to 30 months after injury and surgery, and checking to see how well it could predict eventual recovery. So this is just the MRC data, not any EMG data. And this graph here is the area under the curve of that model run. Shows the patients that did make a functional recovery, just in the red. And as you can see, early in the recovery window, so before this black line here, the model performs quite poorly, showing us that it's just too soon to tell when they're recovering. However, we found that the model performance improved over time, and you can see with this increase in the trajectory, showing us that the patients that do recover and those who don't begin to diverge over time. So we set the performance threshold at 0.7 for the area under the curve, and the first time point that the classifier reached this threshold of 0.7 was at about 5.1 months. So that's where this black line is, and the patients at that time had an MRC greater than or equal to 1. And this modeling approach suggests that at this threshold of 5.1 months, some a little before, some a little after, could be a clinically significant benchmark to evaluate for recovery, functional recovery for the patients. And as it shows, that benchmark being greater than or equal to 1. Then going over from the MRCs into the EMG data, narrowing in on that, and trending it against MRC values, we saw that it gives us an early heads up. So motor unit recovery greater than or equal to 3 motor units in the elbow flexion muscle was seen at a median of 3.6 months prior to functional recovery. And then that's shown further in the t-test on the right there with a p-value 0.003. So quick note on limitations for the study. It's a retrospective study, and there's some heterogeneity with injury type, intervention. So as you saw a few slides back, there's a lot of different transfers that were performed in the intervention group, and then follow-up of our 54 patients. In summary, patients who functionally recover, we found do so at a faster rate and was visible by about 5 months. This takes into account the different donors for the intervention group, with some being a little bit before 5.1, some being a little bit after, and then we found that EMG recovery precedes the functional recovery by about 3.5 months. So these two easy-to-obtain metrics could, with further studies, help clinicians to counsel patients, decide on more accurate timescales for them, and figure out when better to move from an observational approach to directly a surgical approach. Thank you for your time.
Thank you, Sam. Just one question from me. Given the variability within this population with brachial plexus injuries, did you do any sub-analysis for patients that had shoulder dysfunction to see whether that was a contributory factor to the quality of the recovery of elbow flexion?
Good question. I don't think we fully analyzed exactly like how, since it was retrospective, we were looking at pretty specific metrics for just their MRC and EMG recovery of the nerve and the functions associated just for elbow flexion. But but that's awesome, and I think we should definitely continue that as we progress with the studies.
Thank you very much.
It was taken in isolation.
Hey?
It was taken in isolation.
Yeah.
So yes, we didn't show up with that.
Thank you very much. No other questions.
Thank you.
The next presentation we've got is Mayor Brinster. I think this is a second presentation, so 2 chances at the win. Extended exposure for intercostal nerve transfer, an operation I always find very frustrating, so I get the fellows to do it.
Hi, I'm Maya Brinster. I'm an intern for Dr. Brown, so I'm going to be presenting his intercostal nerve transfer technique with a few variations from other operative papers that have been published in the past. So this procedure is performed when there are no intraplexal donors, so in a panbrachial plexus injury, for example, and the intercostals are an attractive donor because they're located very close to the axilla, and you can get a lot of length and a good number of intercostals without compromising breathing function. And I'm going to be focusing on the intercostal to musculocutaneous transfer because elbow flexion, as Sam said, is the main priority in patients who don't have any arm function. And Dr. Brown also performs a long intercostal to long thoracic procedure, which helps improve scapular stability because scapular instability is often experienced by these patients when the long thoracic nerve is damaged. And restoring this helps dramatically with elbow abduction, extension, and helps improve patients' overall outcomes. So first, the incision begins in the proximal medial arm, and then it deviates anteriorly to avoid extra skin folds and glandular tissues. And then it approaches the axilla and then follows the 7th rib towards the midline. And this is a very long incision because we harvest around 5 to 6 nerves, which is a good number of nerves. And this differs from a lot of other surgeons who report doing a curvilinear inframammary incision. And this is because this can often give the appearance of extra fat around the breast for males. And then in female patients, we spare the first 4 intercostal nerves because the 4th is primarily responsible for breast sensation. So for females, we do the incision that follows the 8th rib instead of the 7th. So to begin the chest wall exposure, this is done using a Thompson retractor with elastic hook retractors that are placed in the skin edges, and this allows for the fat to be lifted off of the abdominal wall and fully expose the serratus anterior like this. And then next, the recipients are harvested in the axilla. So this is the musculocutaneous harvesting, and this is located underneath the proximal biceps and adjacent to the humerus. And this is followed to the branch point from the lateral cord and dissected as far proximally as possible to get the best amount of length. Then after this is the long thoracic nerve harvest in the case when it is used. And this is identified with, through its neurovascular bundle. And this is also, again, followed as far proximally as possible. And then after moving to the serratus anterior complete mobilization. So this is very important because it allows for maximal rib exposure, and this allows for access beyond the mid-axillary line, which allows for more length on the intercostal nerves, and the complete mobilization also allows for a more direct corridor for the axilla to make it easier for the intercostals to reach the recipients. And then sutures are also placed throughout the serratus for later reapproximation to make sure that it can align properly. And then this is just an image of the completely mobilized serratus anterior. So you can actually lift this up and move it around because it's completely immobilized. And then next is the rib skeletonization. So these are skeletonized to, again, at least the mid-axillary line, and this is just using a Bovie electrocautery tool. And then after they're skeletonized, the periosteum is freed and retracted to expose the nerves underneath this. Next is the intercostal nerve dissection. So this is a distal to proximal dissection, and because the serratus was mobilized and the ribs were fully skeletonized, we don't have to transect or remove any portion of the rib, which is also often reported in other intercostal procedures. And these are mobilized along the entire length, and throughout this, Dr. Brown stimulates each nerve branch to confirm that it's motor versus sensory, because we want to take only the motor branches and to make sure that they're all functioning properly. So this is just an image of them when they're all looped. And then just to emphasize how important it is for very careful dissection, you see that the artery and vein are located above the nerve, so it's important to only transect the nerve. So you want to do very detailed dissection. And then next, just cutting all of the nerves. You again cut to at least the mid-axillary line, and this is also further for the lower intercostal nerves, because the lower intercostals compared to the higher intercostals have a greater percentage of motor axons, so it's important to get as far proximally as possible, especially with those. And then these are just images of the completely cut intercostal nerves. And then after this, the serratus is perforated just directly through it, and a tube is placed through it so that the intercostals can be suctioned through that, so that they can be placed in the axilla for the final repairs. And then again, because the serratus is completely mobilized, this is relatively easier. So that's the first case where both of the donor nerves can be in the, or both the recipient nerves can be in the axilla, but sometimes the long thoracic or the last intercostal is too short to actually reach the axilla. So in this case, one of the nerves, the long thoracic nerve, can be pulled retrogradedly through the serratus and then attached to the last short intercostal on the serratus anterior undersurface. And this is just, again, through the tube, just like how the intercostals were pulled into the axilla. And then all the intercostals are glued together as a single bundle, so it basically acts as one bigger nerve. And then after that, it's just the final microsuture repairs. So in this video, this nerve is a musculocutaneous, that's the long thoracic, and both of them are hooked up to that one intercostal nerve bundle. And then they're cut using this tool for a cleaner repair. Both ends are cut and then sutured with 9/0 epidural nylon sutures. And then these sutures are placed all around the nerve. And the nerve tube is placed around that to protect them, and this is also sutured to the epidural. And then sealant is placed over that to hold everything in place. And then just to recap, this is the first case I explained when both recipients are in the axilla and all the intercostals are pulled through. The purple is the musculocutaneous and the green is the long thoracic. And then this is case 2 when the 8th intercostal cannot reach the axilla. So you see that the long thoracic is pulled through the serratus and then sutured on its undersurface. And then the rest of the intercostals are still grouped to the musculocutaneous. And then after those microsuture repairs, the serratus can just be repaired directly. And it's also important to place a drain to prevent a subcutaneous seroma, and this would avoid pleural effusion, which can compromise respiration. So this is an example of one of Dr. Brown's outcomes. This patient had a complete left pan plexus injury. So he has full flexion on his right side, and then this is him trying to move or flex his left side. He has no movement. And then this is his outcome. So he has a really good outcome, and he's able to flex it really well. So there are a couple contraindications that some surgeons are cautious about. The primary ones are rib fractures and phrenic nerve injuries. Dr. Brown hasn't encountered complications because of these, so he uses intraoperative stimulation in the case of rib fractures to confirm that the intercostals are still good donors and that they're not also injured. And then with phrenic nerve injuries, he closely monitors patients with sniff tests to monitor their respiration. So to summarize, just going over the key variations, Dr. Brown does an incision from the medial arm all the way to either the 7th or 8th rib, and he does not do the curvilinear inframammary incision. Then for female patients or when breast sensation is prioritized, he begins harvest at rib 5. And then he also uses 5 to 6 intercostal nerves. Most surgeons report 2 to 4 intercostals, but in his case, he has found good outcomes with 5 to 6, and this also increases the number of motor axons that can reach the recipients and also does not compromise respiration either. He completely mobilizes the serratus anterior, which allows for more extensive rib exposure and more proximal dissection of the intercostal nerves. And he also mobilizes the intercostals over the entire length to at least the mid-axillary line. And then he also does the long thoracic procedure for improved abduction, flexion, and external rotation, which comes with the scapular stability after that. Thank you.
Thank you. There are no questions from the panelists, and for the sake of time, I think we'll move on for the next presentation, which is psychological coping and motor recovery after upper limb nerve transfer surgery in cervical spinal cord injury. And this is Chelsea Harstead.
I don't know what it's upset about.
Okay, because we could quit.
Okay.
You're presenting?
Yeah.
Do you have a clicker? Somebody took the clickers right here.
I can just hit this slide, so it's fine. All right. So I am Chelsea, and I am a PhD student with Dr. Brown. I'm going to transition us here a little bit. We've been talking about the structural and anatomy side of nerve transfers today, but now I'm going to take us into the psychological side, hopefully to do Dr. Brown proud here. So one of the things we're looking at in particular is how coping by itself can impact the motor recovery. So what we've seen today is the marvels that nerve transfers can do, but what we've also seen is there is some unexplained variability in these transfer outcomes. So what we know is that nerve transfer surgery does restore the upper limb function, and it can help with the independence of this SCI population. But the problem is some of this functional recovery can vary. And the clinical factors alone, as we've seen with the other presentations, can't always explain all of this variability. So what we're looking at with this data set is how other factors like coping strategies can influence how the recovery of these patients after surgery. So one of the things, again, we're looking at is these psychological factors may help explain at least a portion of this variability that we're seeing in these surgical outcomes. So some of the key mechanisms driving this functional outcome, as we've seen in other presentations, one way to think about it is the nerve and the muscle are the hardware. And that gives you that anatomical potential for their surgical outcomes. And then you add in the neuroplasticity with the rehab, but there's still this other portion that we're trying to tap into. And we can think of it almost as the software update by implementing these coping strategies to influence their motivation for therapy engagement, persistence, and being able to reach that potential. So by having that surgical reinnervation, we have them working with neuroplasticity for rehab, and then by adding the psychological component, we're looking to see if we can kind of fill that gap and get those functional outcomes that we're looking for. And why this is important is it's been studied in this population and in TBI as well, and this study by Francois and Chung examined the psychological outcomes and identified that acceptance in particular is a key coping strategy that has been used by brachial plexus injury patients in the past. And following research found that associations between coping strategies, particularly acceptance, had a positive adjustment when they were seeing it in spinal cord injury patients. And finally, Kennedy et al. Found that there was an inverse relationship. So if you had a higher level of depression, they had lower level, again, of that coping strategy, more towards the acceptance. And these are all things that can impact a patient and impact their recovery. So we thought it was important to kind of look into these things. And I've been mentoring COPE a lot. So how do you measure COPE? So in '97, Carver looked at it and found that this measurement of a coping scale, more importantly the brief COPE, is a way to measure coping strategies. And it has been applied, as you've seen, to the spinal cord population in previous research. So what is the brief COPE? So this is a scale that can be administered to a patient. It has 28 questions, and it's 14 areas are broken down into two main constructs. What you're looking at is the adaptive side and the maladaptive side. Seeing another way to think about it is the positive and kind of the negative sides of coping. And we really kind of honed in on this area of acceptance. And I just wanted to give you kind of a brief introduction to what the scale is looking at. So these are two of the questions that are asked, and they ask these questions, and then the patient is able to score them based on how much they've been doing this during the time to kind of cope with this injury that they're experiencing. So for the current study, this was a prospective study of 16 adults with cervical SCI who underwent preoperative coping assessment through the brief COPE, and they were followed up to 24 months, and the cohort consisted of an average age of 38, age at A and B, C5 through 7 injuries, and they all underwent a SOUP to PIN transfer, and their average time from injury to surgery was around 38 months. And the outcomes that we measured for this surgery, we looked at the MRCs of greater than or equal to 3 as being a functional good recovery, and we also measured extension both for the first web space and then through the second MCP or third MCP, depending on movement. So this is a take, these are some of the results that we've seen so far. Again, this is preliminary work, but this is a take on a conventional heat map. And what we're looking at here is the correlations between an MRC, so that functional motor outcome, and their coping strategies that we're taking pre-op. So this is the kind of how they were doing psychologically before surgery, how they're doing physically after surgery. And what we're looking at is the acceptance at a positive 0.62. So this is a strong correlation between having a better functional outcome and having better acceptance at the beginning. And you can see if they had higher levels of denial or self-distraction at the beginning, their MRC outcome were negatively impacted. So what is this telling us, this preliminary data? Is that, one, coping is measurable. This is something that can easily be done through the brief COPE.
And what it can do is it can identify these patients preoperatively that are at risk. So before surgery is even taken place, we can find these people. And it shows that you can target the psychosocial intervention to enhance the recovery of these patients that are undergoing nerve transfers. And I think the biggest takeaway here is to look at the rehabilitation of the mind and the nerve concurrently. And if you've kind of tuned out the rest of my presentation, this is the slide to really pay attention to. And it's this parallel reconstruction. Again, the mind and the nerve together. So currently, right now, we're really just focused on this anatomical pathway, which is the surgical evaluation, the nerve transfer, PT. But what we're proposing is to add on this cognitive pathway. So that patient is coming into your office to get that initial evaluation. They also get a brief cope or a psychometric at the same time. You're identifying these patients, and as they're recovering from surgery, they're also getting that targeted psychosocial support to increase those adaptive coping measures, and then you're going to be able to see more sustained therapeutic engagement, better outcomes for those patients. And that's it. Thank you very much.
Thank you very much. There are no questions. We've got one final presentation for the free paper session, which is time course of neurosurgical and functional recovery following nerve transfers in spinal cord injury. And this is Andrew Brooks.
Appreciate it. All right, good afternoon, everybody. Today I'm going to be presenting on the time course of functional recovery following nerve transfers for spinal cord injury using longitudinal videos and data. So the patient that we'll be discussing today was a 41-year-old male who presented in June of 2022 to the emergency department after a diving accident. And he was diagnosed with a C5, C6 AJA spinal cord injury. And in April of 2023, he underwent the left side supinator and ECRB to his posterior interosseous nerve transfer surgery. And then he also had both sides, his brachialis branches hooked up to graft. And then following that in August, he had both of those brachialis grafts hooked up to his AINs, and then his right side supinator and ECRB to PIN. So for this presentation, we're going to be following his left arm, and because those surgeries on the left side were completed at different times, right? The AIN was, the stage 2 of the AIN surgery was completed later. I've kind of taken videos from just to make sure that we're looking at the transfer at the same time after surgery, not at the same point in chronological time. So here's before surgery. As you can see, there is no active range of motion, flexion or extension. And now we're 6 months after. And you can see kind of flickers of movement starting to come in the extension there. Here's the flexion. Flickers of movement there. Going out to 9 months after surgery, we start to see some meaningful improvement. There's a clear strength jump here. Both flexion and extension are noticeably stronger. So I'm going to show you guys this one. And so the patient can actually start to move with some purpose here and start to do some functional tasks, as we'll discuss in a little bit. So much better extension there. And at 12 months, we're able to see 3 nascent motor units in his extensors. And this is what that looks like. So a little more extension coming in. And on the flexion side, he's got a pretty strong looking grasp coming in there. And you can see the FPL. He's able to get pretty good range on there. 15 months out, continued improvement in the grasp strength. And we're kind of seeing some plateau in the extensors at this point. But I will show you guys in a second some graphs of that. So now I'm going to show an attempt at a functional task, which is pouring a bottle of water. And so this is 12 months after the AAN transfer and 15 months from the PAN transfer. You can see he can open his hand to get it around the water bottle, but he doesn't quite have the strength to pick it up yet. So he's trying there, but not quite enough. But now we're a year after that, and his force has continued to improve, and you can see him actually able to complete this task now. And then I'm going to show you guys this video, which is showing some more functional tasks that you might do around the house, just passing things between your hands or using your phone, just showing that these transfers are leading to meaningful improvement in his day-to-day. And so now I'm going to talk data. These dash lines are his MRC scores, and the solid lines are his motor unit counts. The motor unit count, a lot of the motor unit count data is still being analyzed, but from what we have, we can see here that the MRCs and the motor units are pretty closely correlated. We see a pretty strong jump around 11 to 12 months, and then kind of plateaus after that. But when we look at the forces as measured by a dynamometer, we can see those meaningfully improve throughout the second year. And that, as you saw in the videos, correlates with the functional scores. So these are the scores from those functional tasks, like pouring the water bottle or putting keys in a lock, that kind of thing. So those look to be more closely correlated with those forces improving throughout the second year. Thank you everyone for having me. Thank you to Dr. Brown.
Thank you very much for a nice presentation. I know you've only looked at this one case, but do you think trying to reconstruct flexion and extension at the same time may influence the gradient of the recovery?
Yeah, I think that's why we like to get the occupational therapists involved, because they have to relearn how to use their transfers, right? And so we can sometimes see co-contraction, and that leads to confusion in the relearning process. But generally, I think we like to have them, we want them to be as functional as possible for as much time as possible. So if we do the surgeries at the same time, then we're minimizing the amount of time that they're in recovery, if that makes sense.
Sure. Yeah. Thank you very much.
Yeah.
I'd like to say a huge thank you to all of the presenters and also to those who were judging as well. We'll tot up the scores, and then I'm sure we'll probably present the prizes later in the afternoon when we've had a chance. My maths isn't very good, so, but I'll draw this session to a close. Thank you.
Right, I think we're going to go straight on to the next session. Is that correct? So this is the spasticity section. And the first talk is by Bradley Marcus.
Are we ready to roll? I thought we were taking 5.
Yeah, I think so.
Is it 1:30? Oh my gosh, it's 1:38. Hey, so we're going to start the next session about spasticity management. We have Brad Marcus, who he and I worked closely in San Diego. He ran his own rehabilitation center there, and he's going to give us the overview before we dive into surgical spasticity management to really have an understanding of what are the basics, what do we need to know, who's the right candidate for us, and who should we leave in the hands of the physiatrists. We're going to turn that over to you, Brad.
Can't see him.
Hello,
hello? Okay, we're good. All right, so let's talk about spasticity. Justin may not be happy with me with this talk. We'll find out afterwards. I think spasticity in many ways is a very good thing. I don't think it's a bad thing at all. It's kind of like when you have a car accident and you see a bunch of ambulances and you're going to blame the ambulance. So we can actually use spasticity to help train people how to move. And we know this because we have examples here today of patients who know how to tap certain things and actually get strength to help with transfers and everything else. So first I want to talk, what exactly is spasticity? And we all know the definition. We have an increase of tone when we move. Basically, as we increase velocity or with velocity, we get a caught. We have a reflex there. And that's important because when we actually look at movement, movement is more than just elbow flexion and extension. It's about accelerating and decelerating. That's why we throw a baseball. That's why when we walk, we have that momentum. And we have to be able to decelerate as well as accelerate. If we're always accelerating, we're going to fall on our face. So it's really important that we focus on that. And when we're moving, we're not just moving at the same speed. I can have patients not have issues with spasticity by just moving really slow. I also don't have to work them out full range of motion. That's kind of a myth that we all have to work out the full range of motion. No, I need functional range of motion. And when we talk about function, we talk about things that actually work in the real world, not moving a block into a square or whatnot. We have to make it fun, we have to make it engaging. But really what it comes down to is we want patients moving. So when we look at spasticity, it's not just spasticity itself, it's upper motor neuron syndrome. We have positive and we have negative signs. I'm just as concerned with the negative signs as the positive signs. So if I can figure this out up here, we'll go over it, but I think I'm just going to wing it for now. So when we look at negative signs, what are we talking about? We're talking about weakness. We're talking about, I'm drawing a blank right now. We're talking about weakness. We're talking about losing control. We're talking about fatigue. And fatigue is a really big one that we ignore. And it's really important when we're doing E-STEM that we consider fatigue or we're looking at strength. The two are not separate. They go hand in hand. So we have to kind of figure out what kind of function we want for the patient. Is this something that's going to be more strength-wise? Is it going to be more fatigue-wise? What kind of work are we expecting them to do? And that, I think, kind of has to come into the planning. So I'm not into the neurosurgical world. But I think when we do assessments, we need to be thinking movement first. And what we have to realize is that when we look at upper motor neuron syndrome, the positive and the negative, they're not occurring separately. They're both being modulated at the same time. If we remove too much, you're basically going to destroy my ability to do rehab. If we have a patient that has too much spasticity and a neurosurgeon comes in and says, okay, I can I can do this tendon lengthening here, and I can do this procedure here, and this procedure here. I have nothing left to work with. I'm left with basically a jello. And then I have a patient who's really mad because the surgeon promised everything. Likewise, as a PM&R doc on the outpatient side, it's my job to condition the patient before they ever see you. And that includes everything. That includes nutrition, psychological aspects, helping them out spiritually, emotionally, helping them out with family issues. You have to have an all-encompassing way to get them moving and getting happy. The biggest thing that Karen's going to go over, and one of the most important topics, is the number one reason why everything fails is depression. How do we beat depression? Well, we can beat it spiritually, obviously. We can beat it emotionally. You're not going to beat it through medications alone. We have to give patients options. And we cannot assume that they can't afford something. We can't assume that they're not going to follow through. We have to give them all the options. We have to make the patient the hero. And that's what's lacking right now. Patients are not the hero. We have to have them tell a story, and they have to be an example to other patients so that they can see what's going on, so that they can document the story, so they can get out the work that you do. In terms of neurosurgeons, it's too much to put on you guys. I saw your slides. It all looks like crab cake and tomato sauce. I can't figure it out, and I've probably done first assist in over 100 surgeries. That's why I'm not a neurosurgeon, by the way, thank God. But it's too much on you to be able to do everything. It can't happen. And I wouldn't want you doing that. What's really needed is you to have a team that can all work together, and we've kind of talked about that. And everybody has to understand what the other side is doing, and we can all coordinate. But I want to get back to spasticity, because this is going to be the second part of my talk. So when we talk about spasticity, we're talking about what? Force is equal to mass times acceleration. I know we have at least one engineer here. So what are we talking about with that? It's crazy, right? Like, well, it all kind of makes sense. If I'm going too fast, it's okay for me to protect the joint. I can't just keep throwing something and all of a sudden decelerate and my whole arm's gonna fly out. Everything has to be timed. And so when we look at upper motor neuron syndrome, the patterns that we typically get, the stronger muscles kind of win, right? And we kind of coil up. We end up like this. This isn't functional for anybody. I have no grip. This isn't a grip. No flexion, no extension. Everything is. But when we actually look at how we throw and do things, we push, we unwind. So when we have increase in tone, because spasticity is just one example of what kind of tone brings on. It's really we're treating the underlying tone is what we need to do. We don't want to have too much tone taken away. We don't want to have too little. But when we talk about tone, let's realize that we can get rid of a lot of this with volitional control. So I'm really excited with a lot of the things you guys are doing, because the second someone starts to understand how to move, or they have a new connection to move, or a new nerve to move, that spasticity is going to start going away. And I think it's really exciting from that standpoint. Now, we can do medications. We can talk about medications all day long. People that love medications, I will tell you the number one thing I see that is being missed, especially in spinal cord injury patients, is you take a guy who's 200 pounds, and now he weighs 150 pounds, he lost a ton of muscle, and everybody's saying, hey, look, his kidneys are fine, his creatinine's 0.8. Okay, his EGFR looks like it's fantastic, his BUN isn't even that high. Yeah, he probably still has kidney issues going on. We have to check his cystatin C. Don't worry, most people don't know what that is. I had to find out from personal reasons. Cystatin C is a little molecule. It's released. All your cells kind of release it. Your kidneys filter it out. It actually gives you a more accurate EGFR. So it's a really nice thing to be able to use, because if you have patients on baclofen and you want to make sure they're just healing well, really nice to know if there's underlying kidney issues going on before we damage them with medications. The other thing that's really great to know is if they are having kidney issues, they're going to be getting muscle spasms. You're going to have magnesium issues. You can't just check regular magnesium. It's not going to work. There's specialized magnesium tests that we need to have. These patients are often chronically dehydrated because they don't want to be catheterizing themselves every 4 hours, so they drink less. They manipulate a lot of their nutrition and stuff around their bowel patterns and their bladder patterns. So there's going to be a lot of dehydration issues, and it's not just a matter of drinking water. It's okay, put some sea salt in there, put some lemon in there. This is stuff grandma's been telling you to do forever, and it works. I know personally, I've had neuropathy issues. A lot of cramping brought on. Even though I'm drinking plenty of water, you got to bring it up. It's very important to supplement with the right things. Very important emotionally also to deal with pain. And pain is the major issue that is being missed. And it's how we frame it. And this is where kind of surgeons come in big time. So let's talk about pain so we're all on the same page of what exactly pain is. Pain is an emotional response to the threat of real or you actually had real bodily injury. If someone thinks that something is painful, it is painful. If you have a toothache and I tell you, you know what, I'm a dentist, you have a toothache, you have diabetes, it could be an abscess going to your brain, don't worry, I'll see you on Monday. Worst pain of your life. You will physically have the worst pain. Same patient, I say, you know what, you got a minor toothache, nothing to worry about, put a little Ambisol on it, numb it up, chew some gum, I'll take care of it on Monday. They're fine, they're doing great. We give somebody an injection and we say, we're gonna give you an injection now, you're gonna feel a hard prick. Oh my God, sounds awful. We can frame things differently. You're gonna feel a little bit of pressure. You'll feel a slight burn. The burn means the pain medication's working. Which brings us to another thing that we can talk about, because I'm kind of going on tangents. Diagnostic nerve blocks, I don't know if anybody was talking about it. Love using them in practice. It's very simple. I can't understand all the stuff Dr. Sheehan does out in San Diego with the EMGs and stuff. And I'm a physiatrist, and I've done hundreds of, it's beyond my scope. But you know what I can do? I can easily take a lidocaine injection, put it right into the muscle of interest, take a look at it. Surface EMG. Do the antagonistic and the protagonistic muscles. Surface EMG, have them walk, videotape it. Doesn't have to be 240 plus frames per second. Have it focused at the feet. He can now see how the foot is landing. We can now look, are these muscles firing appropriately? Is it giving a spastic pattern? But more importantly, if I do before and after, I can see how much, or I can at least give some advice of, hey, Dr. Brown, I think we need to do more of an injection. More of a selective peripheral neurotomy. So from that, I want to kind of open it up the field a little bit to anybody's questions, because I can go off on tangents a million different ways. I will say this, it's really important that we have fun with things. It's really important that we focus on breathing. I know we talked about that previously. So there's somebody here that loves Kung Fu, so I thought I'd bring it all together. I don't know if she's here or not. I don't see her. But when you're breathing, it's really important that you time it with what you're doing. Breathing is more than just breath. It's affecting your vagal tone. It's affecting everything. You're stronger when you know how to manipulate your breath. In spinal cord injury patients in particular, their diaphragm is weak, their intercostals are weak. You can put a binder on and help that. But more importantly, in terms of getting them in the right frame of mind, breathing is the best supply. You should be thankful every breath in and out. I'm sorry, question?
How do you prevent contractures, those patients?
So we can only do so much as therapists. So what we have to do is educate them on number one, on spasticity, but number two, we have to develop a program where they can work out throughout the day. We can't just work out in 30, 45 minutes a day or stretching once or twice a day. Physical therapy has to be just like a prescription like I would write for medications. I want you on a standing frame, 45 minutes, once or twice a day, every week. It's been shown to work. That's what we need to do in terms of contractures, active movement. A lot of patients have movement that we don't see. And why? We're not eliminating gravity. Some places have pools. Fantastic, you can do it. You know what else you can use? Bungees. Really easy. Carabiner clips. You can have your left arm work your right arm. You have stroke patients. You you want to do a cross crawl pattern. We talked about this when we talked about cats being able to walk when you mutilate them and things like that. We want to stimulate the spinal cord, but we want to do it in such a way where we don't bore the spinal cord, and that comes down to attenuation. So we can talk about pain. So when we talk about a pain attenuation and spasticity, they're all kind of related. So when you bang your elbow, what do? You rub your elbow really quick. You're overloading the nerve fibers. You overload the nerve fibers, you're not having as much pain. There's only so many cars that can fit through the tunnel, and this isn't a noxious pain, you're not in as much pain. Same concept with snow blindness. If everything's white, all of a sudden your retina turns off. You can't see anything. Same thing with your spinal cord. I put you on a bike, and it's just doing this. That's a 1-to-1 ratio. Your spinal cord is bored. Spinal cord wants to be stimulated. Turns off. I can put somebody in a cross-crawl pattern. Very stimulating. That's how babies crawl. But babies don't crawl on a 1-to-1 pattern. They're a little bit off. So if we're going to develop a system to stimulate the spinal cord, we want to have a ratio the brain can't easily, and the spinal cord can't easily figure out. Our body wants to be efficient. So if I'm going to have somebody on a cycle, and I know their bicep is tight, am I going to have them row this way or this way? Am I going to fight this spasticity, or can I work with it? Well, you know what? I say, we can work with it a little bit. We can do small circles. We can go out and make it out. We can go forward. We can go back and forth. We can rock it if we're worried about contractures. The main thing with contractures is to get them before they happen. And the beautiful thing is, the most ignored organ in our entire body is the myofascial layer. It runs through everything. It runs through your brain, runs through your kidneys, through your heart. It's the only organ where if I took all the other organs away, I'd still recognize you. And it talks to each other. How do I know it talks to each other? Every cell in your body talks to each other. We're all electrobiochemical beings. We're all full of energy. That's why acupuncture works. That's why a lot of the electrical stimulations things that we do work. It's not just working the muscle, it's working the areas around it. It's improving blood flow. So in terms of contractures directly, how would I treat it? Where are we talking? Are we talking in the legs? Are we talking in the arms? Are we talking in the hands? Because they're very different. So like, which one would you want me to do? Upper limbs are tough. Hands are not my specialty on that. But what I would say is this. Not all contractures in the hand are necessarily bad. Yeah, if it's a Dupuytren's, we can go ahead and do surgical on it. If it's a wrist and it happens to be contracted in the right position, I'm happy with it. Right? Some things are going to require surgery no matter what we do. If we have a frozen shoulder, that's easy to fix. Just do little micro movements. If I have to, I'll put some Marcaine, some lidocaine in it and work it around. I never worry about shoulders. But if I'm going to rehab anything in the upper extremity, I need to think about stabilizing the joints. My number one goal is think of your upper body as a crane, right? I have one of those machines and I'm trying to pick things up. Every part going up has to work. And that's common sense. I'm not telling you anything you don't know. But here's the thing. A lot of spinal cord injury, for example, has also brain injury. And what we have to realize is if the patient isn't aware that there's a problem, they're going to develop contractures, and it's going to start at the neck. If they're ignoring their right side, they're going to get torticollis to the left. I don't care how good a surgeon you're doing on that side. If they're not looking at it, it's not a problem. So the first thing you have to do when you're talking about patients is awareness. They have to be aware that there's an issue. And I can actually force somebody, if I put the right optics on, to walk to the left, even if they don't want to. So if I'm having a patient and I want them to walk better, or I want them to use their hand more, I can actually put optics on. I can put optics on them and make them walk left. And even though I tell you what I'm doing, and you're trying to walk right, you'll still walk left. Visual system's extremely important. It's extremely ignored. And we have to be able to visualize things too. There's a lot of different meditation things that we can do that get us in that zone. I used to tell patients that did get spontaneous recovery, when you're waking up early in the morning, right before you open your eyes, visualize your thumb moving. Visualize your hand opening. And that's normally when they would get that spontaneous recovery is in the wee hours of the morning right before they woke up because they saw themselves doing it. So, any other questions? I'm completely off tangent, but.
Jeff Scott.
Oh, just a quick thing. Even what you're talking about with the slowness of the movement and the like, it's not, even though it's not strictly classical spasticity in that regard, which is a passive thing.
Right. So what you're talking about is passive movement, but what I'm saying is I don't really care about that.
Right, and that's my point, is that this I call spastic dystonia because it's a co-contraction,
right,
which limits the movement, and that is.
And that's one of the upper motor neuron syndromes thing, as well. It's one of the positive symptoms, and I agree with you completely that that is a problem, and that's not as easily trainable when you have somebody who's.
Well, that was my question because you're very engaging and informative presentation of the real world sort of down-to-earth stuff, and the working with what is sort of turning it into a positive, you know.
Right. So we're talking more of the spastic dystonia. You know, you're kind of going in the realms of, you know, I've seen more of that in more pediatric disorders and more with like I imagine like Parkinson's and more not classic spinal cord injury. I just don't see that.
No, well, it's called spastic dystonia to separate it from the standard movement disorder, basal ganglia sort of rooted dystonia.
So I typically think.
But it acts the same, and I was wondering if any of your activities which seem to want to entrain.
So that's an excellent point. So when we're looking at spasticity, it's really important to focus on, not necessarily focus on, but to know what disease is the underlying cause, because we're going to treat MS much different than we're going to treat a patient with Parkinson's who doesn't really have true spasticity. They have more cogwheel rigidity. So we have to kind of, like, for example, in an MS patient, you're going to have both. Those lesions can be anywhere. They can be central, they can be peripheral, which brings us back to fatigue, when we were talking about fatigue, which is, I know that something that I'm sorry.
Get him set up.
Okay, so one of the other things I just want to briefly talk about that people ignore is fatigue. Fatigue is a real thing, and you're going to see it. And there's many different causes for it, very common brain injury. But there's different types of fatigue. There's also neurofatigue. Sometimes the nerves just can't handle it. And you'll hear about this with bodybuilders. The main reason why they rest so much isn't so much for the muscle recovery. It's because neurologically, they're kind of spent. They just can't do it. That's one of the reasons why I like, if you want to increase somebody's strength, you want to have them doing more things. You kind of want to open up what I call the neuro spigot. So if someone has a weak right hand, if they squeeze their left hand, the right hand will actually get stronger. If you're squeezing both hands, your strength is actually stronger, which is kind of cool. So you'll see it in Parkinson's patients. If they sing, they can move better. And that's the other thing I want to talk about. When we talk about movement, got to make it fun. And one of my favorite things is music. You got everything involved. You got timing, hand positioning, rhythm, and they enjoy it. It's a lot of fun. And you can modify it depending on how their hand structure is. It can be modified piano, modified drums. There's a lot of different ways people can make music. You only have to learn 4 chords. You can play 90% of songs out there. I wish I was any good at piano, but I'm not. But the point being is, it's got to be fun. It's got to be engaging. It can't just be moving a circle. It can't just be using a surface EMG and flexing your arm and watching a bar go up and down. We can connect that to video games. We can do a lot of really cool things. The technology's there, and it just requires creativity. And just one more thing I want to cover is fear. People are afraid to move. You have to remove the fear. You can do that physically, you can do that emotionally, you can do that spiritually. People are afraid of fear, and they're afraid of falling down. First thing I do, I push a patient down and I go, it didn't hurt that bad, did it? They're afraid of it. Now, likewise, if I put them in a harness and it's a walking track, or I have their arm up on a sling and I want them to move it and they're afraid of hurting their shoulder, I have to show them they can't. I'm not going to let you hurt that shoulder. And just one more thing, Justin, I know I'm kind of running over. I want to talk about the last thing about movement that is very kind of counterintuitive, but it's a great way to protect the joints. So I want everybody to kind of think about this. I don't have to move your joint to put acceleration and deceleration forces in that joint. If you're a spinal cord injury and you're standing up and I throw a ball at you and you catch it, you're going to have all those spinal reflexes. You're going to have all that stuff going into your joint, into your back, into your core. They're going to have micro contractions whether they realize it or not. So we can do things on the floor. We can do things on the mat. We can stabilize joints on the floor, on the mat. Not everything requires a super expensive machine. And I will say this, a lot of machines out there can be repurposed for a lot of different reasons. People will tell you the Locomat doesn't work well for spasticity. It doesn't? I've probably had 100 patients on it. It works great. Is it a permanent fix? No, it's not. But anytime when we talk about contractures, anytime I can control your hip flexion, your knee extension, your ankle strike, how fast you go, the amount of hip swing, and I can combine that with augmented feedback. They can see exactly what's going on and I can adjust it in real time. I'm going to avoid contracture because I'm going to be able to do micro, real-time dynamic change. And one of the things that we're able to do now, unfortunately it's really expensive, but it can still be done, is real-time biofeedback using EMG and walking and upper extremity things. I can have patients look and coordinate upper body cross-crawling techniques and actually see how smooth they are, and they can actually see their spasticity go down. You don't have the money to do it, you can get one of those 1970s Schwinn Airdynes. Let the momentum do your job. If you're getting spasticity going forward, move it backward. Whatever you are given that is being seen as a weakness, you have to make it a strength. If somebody can only move forward and they're complaining about they can't move back, I'm going to take that back and I'm going to figure out a way to cycle it forward. If they can't do either, well, you know what? I'm just going to rock you back and forth, because I do have patients with issues like this. Rock them back and forth on a hand cycle, on a bike, until it starts to loosen up. And eventually it will loosen up. Because they've done studies, I wish I had it on a slide, of how fast the myofascial layer can change. And it changes so quick you wouldn't believe it. And we can change it with acupuncture, we can change it with lidocaine, we can change it with heat, we can change it with ultrasound, we can change it with photobiomodulation. There are a million different things we can do for the myofascial layer. We're doing none of it. And then for the neurosurgeons here and for the therapists, my second talk, I want to go over how we prep patients before and after, like nutrition-wise, and how we can talk with them, and how we explain things that will make it so that we have a success. Because right now they're kind of set up for failure. So.
Thanks.
Any other questions?
Okay, right, we can move on to the next talk. So this is Petros Mikalev, and he's from the country of England, in Birmingham.
Yeah. How do we do this? Can you help me with this? It's just this one here, I think.
No. Oh, you're just using that? Which is you want to use the clicker?
No, I'm good. I just need. Can you see me? Can we put it sort of here?
Yes.
Hi, can you hear me? Yes. Thank you. So, thanks very much for the lovely talks. Justin, it's an amazing honor to be here. I love it. I never thought I would learn so many things in a specialty that I'm so far off. Not that far, but I am. I'm an orthopedic surgeon by trade. I was born in Johannesburg. I grew up in Greece, and I ended up in England. I work in Birmingham, Birmingham is a little place here. Apparently there is a Birmingham, Alabama as well. I'm not from that one. I'm at Birmingham, UK. Yeah, once I booked tickets to that. Yeah. Yeah. So, yes, didn't buy them, but anyway, yeah. So, yeah, I work in the Royal Orthopaedic Hospital, Sirius and Lau. I'm supposed to be the first stamped appointed spasticity surgeon in the UK because we have do a lot of spasticity work here, or mainly this is the Royal Orthopaedic Hospital today. It's got a few extensions, it's not just that though, yeah. And this is how it was about 100 years ago, where it was called Children's Crippled Hospital. This is the main team I'm working with. I've got amazing colleagues. We've got 3 surgeons, as you can see, in a very high tower over there, where we went through this journey together, the journey for spasticity, starting with the upper limb. That's why our upper limb is a little bit more than anything. We recently had Emily. Emily is a neurophysio she's great. She's a great adjunct. And of course, we always have Mr. Power around us for his sins. Where is Mr. Power? Who is always here and I'm making his life always miserable. I have a declaration. Whatever I'm going to show is not just mine. It's a team. We are working as a team, all the videos and everything. I was really, really impressed. One of the things I always like is the fact that there are too many definitions about spasticity. And the only definition I really liked was the one from the American Academy of Neurological Surgeons. Spasticity is not a complex one, it's a common condition which muscles stiffen or tighten, preventing normal fluid movement. The muscles remain contracted and resist being stretched. And this affects movement, speech, and gait. It's not that the arm is not just a leg, and there is a whole thing around it. I'll try to take you through this as quickly as possible, and I'll try to be nice. Is the one component of the upper motor neuron syndrome. And to take this into a perspective, this is a bicep, this is a spasticity of the elbow flexors, and this is how we sort of examine that, which is the so-called catch. Patient has got full range of movement. Lovely patients. I'm sorry, I have very good relationship with my patients. We all need to know, and we all know there is something wrong in the central nervous system. And after a while, what happens is that there is supposed to be, if you don't have this lesion, there is supposed to be some kind of balance between flexors and extensors. And because of what's happened, the balance is gone. The spastic, or more strong or more firing side, is usually overworking, and this creates usually the postures that we see. The reality is that this is the most common posture, but there are quite a few of them that you can see in various. The spasticity is not just one thing. Okay? And the posture is shoulder abduction and internal rotation, elbow flexion, forearm pronation, wrist flexion, finger flexion, and with the thumb, clenched fist and thumb impaled deformity. And there are too many procedures that we can do in a number of cases. The main thing I want you to take out from here, if there is something, is that is not the incision, is the decision. Okay? We need to make sure that we have, this is written by Caroline Leclerc. I did a lot of training close to her, and she's one of my favorite mentors. You have to put a lot of things together and assess everything: sensory assessment, functional assessment, general assessment, a number of other things. We have to do a number of assessments, and we have to look into the bigger picture. There are carers, patients have got also behavioral problems, cognitive issues that we need to make sure that we get into them, okay? And there is a diversity of presentations. Sometimes the goals differ. The outcomes, we are not really sure what the patients want to do, okay? And when we have a patient, let's say a teenager, in quite a few occasions, the mom wants different things than the child, and this is something that we have to assess. We need a MDT, this is the main thing, and we need to individualize the treatment, and we need to get everybody on board, okay? This is though in an ideal world. Where I work, unfortunately, is the three of us, and we've got a lot of red tape. Okay, we struggled a lot to get a physio, we struggled a lot to get the therapy that we want to. In order to operate, it's a real struggle. So, especially the assessment, we were going all those things which are the scales, which are very good in discussing between us and communicating what is what. This is an amazing tool, but it won't help me decide what I'm going to do for this patient. I need something simple. If you go there, you can see a lot of paperwork, a lot of this, a lot of that, but in the end, we have to sit down with patients who have been around the houses for a long time, seeing this functional around functional, non-functional, what would they expect, make sure that we address the pain. The pain is a big thing for those patients, and of course, a lot of those, unfortunately, come to the surgeon, and because they think we've got a magic stick and we're going to do magic to them. We need to make sure that we do things properly. We assess them with simple things. We don't have the luxury of doing complex things. The patient needs to understand that here we are to do something which is irreversible, and we need to make sure that what we do is on the right direction. And we need to assess and make things the way we want them. What we have developed as a team is what we call the bottle test. It's a very simple way of assessing things. You just give the patient a bottle and you ask them to open. It works a lot better for the hemiplegic. So, can you hear me? So, what I realized at some point, wow, this is loud. What I realized at some point was that if you started assessing the patients exactly how they had been assessed in the past, which was, let's do the catch, let's do this, a lot of my patients started disengaging and were telling me, okay, doctor, do your own thing. I've been through this a lot of times. So what we are doing, which is a simple thing, we give them a bottle and we ask them to open it and to do it how they're supposed to be doing it. And in simple terms, we realize that this patient is able to hold the bottle and undo the lid. Okay? He just does that. So he has good control, or control that he can have to stabilize the arm, the hand in the desired position, the shoulder, the elbow, the forearm, the wrist, and the hand are able to coordinate. In this patient here, which is not the best example, but we still don't have too many, there is something wrong. They cannot keep the wrist in the best position. They cannot keep it in a position. Or sometimes, which is sometimes more common, I just couldn't find the video, I'm sorry, the patient has the arm, which is actually whenever they try to do something, it ulnarly deviates. And they tell you, I'm clumsy. That's why I'm not using the arm, which is quite good. Then you go to the other ones, which is the common one. What do? They just put it in between the shoulders. So there is no hand function. They don't have the ability to use their hand. So once you have somebody who does this and they come in and they ask you, I want this, I want that, you tell me, sorry, why are you not using the hand? They have the connection between your brain and your hand is not very good. You don't have very good control over it. For some reason, most of them, although they've been through physiotherapy and this, nobody has actually pointed that. They made them always feel guilty that they are not doing it. I'm sorry, but we had a lot of it. And of course, we've got the next one, which is this, which is the patient who has no control. And they do other stuff also. I was in Czech Republic, and he was putting it next to his whatever to try and do it. This was a surgeon. The main thing you need to understand is you need to make sure to tell them, how do you normally do it? This is a patient who is sitting with the mom, and the mom is telling him, yes, you are able to do it. So apparently this is how he usually does it. He's not going to play the piano. For us, this is quite important. We do, I'm not going to sit for too long for that. Preoperative evaluation is a big thing. We check sensation, we check to see what's happening with them, if there are contractures, if there are deformities, but sometimes in the clinical environment where we are supposed to have a nice, calm and whatever, you're going to read it in every paper, that's not what happens at the Royal Orthopedic. It's panic over there. So what we usually do, yeah, that's what it is. The transport doesn't work, patients are screaming, it's not very good. So what we realized is that we can bring the patients in for local anesthetic blocks. The local anesthetic blocks, we see them in turns. So we start from distally and we go proximally, and we try to figure out what is the range of movement of the patient and what the antagonists do. Since we started doing the local anesthetic block, we hardly ever do a tendon transfer for finger extension. A lot of them have got pseudo-paralysis. They are not paralyzed. A lot of patients are like this, especially when they have been in that position for a very long time, okay? And also, it's botulinum toxin injections, which it's a very good tool, but unfortunately, most of our patients had a lot of it, and they're disappointed. Okay? So this is, we try to see, we assess them, we reassess them, and then we make a plan. And now I'm going to talk to you briefly about some surgery, because I've been talking for too long. Hyperselective neurectomy, you can do neurectomies. As Caroline Leclerc says, it's indicated when one wants to reduce the spasticity. Has no effect on muscle and joint contractures, so you need to deal with the muscle contractures differently. The joint contractures with arthrolysis, paralysis, if they are truly paralyzed, you need to move a tendon around, and you need to make sure that the patient has got good control over the tendon you're going to use. It would be an insult if we don't talk about Stoffel. Okay, it's been here, I think Andreas spoke about him. He was a very big pioneer. This is a nerve stimulator that he actually managed to invent, and he was doing his surgeries. I just put a few things here to take you through the history, how these Stoffel procedures were abandoned because it was before the era of antibiotics, and they had a lot of infections. The problem with these kind of things is that we have series, we have expert opinions, but unfortunately, we don't have randomized controlled trials, we don't have high-level evidence. And the reason for that is it's very difficult to find patients who are exactly the same or identical. And sometimes we do a lot more than one procedure for those patients, so you don't compare the same things. Okay? Sitting once with Dominic, who is sitting just back there, we were sitting in the pub and we realized that there is no consensus about the terminology, and we sat down and we wrote this in a piece of paper, and then we published it, and apparently it's what it says here, which is, this is the levels, if the muscle is on this side here, this is the levels where you do the neurectomy. Here is the hyperselective, it's the intramuscular, selective neurectomy, on this level, partial, or just to cut or full neurectomy, and then the total motor neurectomy. Sorry, I think I skipped one. Yeah. The beauty of the neurectomy, if you do neurectomies, is what has Caroline Leclerc done. It's that whatever happens, the spasticity goes away, but the muscle strength remains. Okay, it's 5 out of 5 or 4 out of 4. They recover the strength. And going, which is the good thing, the technical basis, you need to make sure that because you're going to be stimulating, they don't have muscle relaxants. We need to be able to do mapping if you are doing mapping. Okay, for the neurosurgeons here, I suspect this is a very easy thing to do. For me, I'm an orthopedic surgeon by trade, so touching the nerves to begin with was a terrible thing. Yeah. Yes, I have to bring Dominic to help me, okay? In a few places, yes, if you're an orthopedic surgeon, you learn to go away from the neurovascular bundles, and I had to go in and start poking with them. I mean, that's terrible. But you learn everything in life. So this is the nerve, as it goes out to the neuromuscular junction. You need to cut at least 3/4 of it. The thing is that sometimes people say, what are we going to cut, how long, how far? I was in a panel where they do a lot of neurectomies, and nobody has gone to the point where they cut that much that the muscle was paralyzed. Okay? And in quite a few occasions, you cannot even stimulate the little nerve that you leave behind, and in the end, patients do extremely well. Okay? This is one of the, what happens, the similar thing. This is a drawing by Mr. Power. This is here what you do if you do a trunk. You do all those things in the trunk where you go in, you do your mapping. You have to cut whatever you need to cut, or cut a little piece of it, or just dissect it. Okay? For neurectomy, we could do neurectomy when the shoulder has got full range of movement. I hardly ever get those patients. We could just go to the pectoral nerve and do it. It's a beautiful procedure. We hardly ever get those patients, unfortunately. If we go to the musculocutaneous nerve, the reason why I've put this photo here is because this patient was initially planned for a musculocutaneous neurectomy, where we would go to this place here. But once we gave her anesthetic, she was we did the blocks before COVID, and we saw the patient far after COVID, and she had already developed contractures, and this is why we decided to go at the front and just do the tendon lengthenings. This is how we usually do it. The incision is in that level here in the middle, and we go in, we find the nerve, and we make sure that we stimulate. The branching can be strains in the musculocutaneous nerve. We avoid the lateral cutaneous nerve, and we try to make sure that we do it properly. Regarding the median nerve, we usually discuss about pronation. This is what we try to do, and we've done a few of them. Our colleagues from France, the neurosurgeon, Professor Mertin, just goes proximally, stimulates, and does his neurectomies. We don't do that. Okay? It's just, I don't know, maybe he's a lot more familiar. We do selective neurectomy of the pronator teres when we have to do that. Then the FCR, we don't always do. The FCU, we've done it a few times. The ulnar nerve is quite good, and the FCU has got 2 branches, and it's very easy to find it. With regards to a few things that we are doing at the lower limb, we've started we've started trying to have a lower limb MDT as well for our spasticity patients. My contribution to that is to try and do some neurectomies. We've got a few patients for obturator nerve, but still there is not enough evidence what we are supposed to do. Things are a little bit tricky. You make sure that you do it properly. We've always a nerve block before. It's more in the pediatric population, and they also do adductor release. Can you hear me? Oh, okay. In the femoral nerve, I would just do it when the patient has got this extension deformity where the rectus femoris is overreacting. The best procedure for me, if you do neurectomies, is the tibial nerve. The tibial nerve is an amazing nerve. It's just there. The anatomy is easy. You can just go in, do what you're supposed to do, and the stretches are very easy because the patient just stands and walks, as long as they don't have leg length discrepancy. If they have, they're going to buy Aquinas in the end, and they're going to start moaning, but generally. So, going further, this is a patient it's a disgrace of our Western civilization. This patient was screaming and fighting. He was all around with all those, rehabilitation people who were leaving them in that position, and he was fighting, and he had a bit of a cognitive issue, and he was screaming of pain. When we managed to anesthetize him, we realized that that's what was happening under his axilla. That was with his hand, and if you look, this here, in the finger, it's just epidermis, and that's his pulley. So this patient nobody could clean him, and he was swearing to everybody who was around it. For those patients, neurectomy is not an option, I think. It's been found, though, that contractures, patients do not have arm function, it's very likely to get contractures. And there was an observational study which I found recently, which is very good half of the adults who present to the hospital with stroke develop at least one contracture within 6 months. There is something happening. So apparently there is a physiology. There is something which is going wrong. There is something where the muscle goes. There is the physiology changes and the muscle stiffness, and has to do with the theory in 2000, this paper from 2025 with hyaluronan. I'm sorry, my English is not very good with things. I'm Greek. So, going further, what we're going to be doing for those patients, what we usually do, we do for the shoulder, we do a release. If you see where this is the arm, we try to get as close to the humerus as possible. We go in, whatever you can palpate over there, you have to release it. I usually, this is not me operating, this is a colleague of mine. I usually go a little bit further because over there it usually bleeds a lot. And one of the things that you have to do is make sure that the fascia of the axilla is released. Otherwise, they are very short, and otherwise the patient will look as if you've left something behind. Okay? There are other procedures that they do. Usually in my cohort, if you just release, we can release other muscles as well, but if you release the pectoralis, usually things are very good for the patient. There is a bicep suspension procedure. This is when the patient has got pain. This patient has got pain here because if you see the X-ray, the brachial plexus is stretched. In quite a few occasions, if you put them in a sling, they are reasonably well, okay? But you can do those procedures, and our shoulder surgeon also do them arthroscopically, and they do a number of things with tunnels. Regarding the elbow, I just show, for whoever doesn't know, a few things which it's an AI creation of how the step lengthening works. Okay, so we go in, we do the step, we lengthen, and then we put some sutures. This is the patient that I told you before. We came in, we marked. After that, for the elbow flexors, this is the biceps tendon. We did this, and after that, you can see that this is lengthened. Then we go under there, we take the brachialis, we release as much of the fascia over the brachialis as we can, which is quite rewarding, and then you stitch the muscle as close as you can suture it. Regarding elbow release, sometimes the patients are so bent, so flexed, you have to go do a lateral approach. You cannot go from the front. The lateral approach is, the anatomy is quite distorted. Sorry. So you go from this side, and then once you get there, we were feeling that this is the biceps, but apparently this was part of the brachialis. We went in, we did what we needed to do, and then we started elevating the brachioradialis. We started elevating everything from the humerus, and the tendon was on the medial side, the biceps tendon, which is what it shows there. As you can see, this is pure bone, and the angle of the elbow has changed. You need to do a full release. Patients don't overstretch it, but patients are in a better position, and the skin at the front is a lot better. Regarding pronation, if you look at the video, this is an open. We did a number of things, and one was to release the pronator, and that's what you do. The pronator goes around the radius, so you need to make sure that you release the whole of it, and it retracts. We usually do it if it's in isolation. We do it with an incision here, and you make sure that you go and you see it retracting. The procedure that is very common, very easily done in the pediatric population is the rerouting of the pronator teres. You make the pronator a supinator. I don't understand how it works, and we don't do it in our sort of, I'm not the only one if you go around. Regarding the finger flexors, the procedure that I usually like doing is the fusion. If you fuse the wrist, you stabilize the wrist, and once you stabilize the wrist, the patient uses the finger better. The patients do not have this ability to do two things. One, to stabilize the wrist in the position that they want and then move the fingers. So if you do tendon transfers, quite a few of those patients just sit in positions like this. The reason is that there is only they have limited control. Get rid of the option of trying to stabilize the wrist and just allow them to move their fingers. This is an amazing procedure. If you see this, because I'm going to talk about in the next slide, this is a patient who, before coming to us, had FCU to ECRB done before skeletal maturity in both sides, and one ended up hyperflexed and the other one hyperextended. Okay, that's why here I never do this procedure, although the pediatric surgeons are very happy with that and they're trying to do it all the time. Regarding the FCU, if you release the FCU muscle, you need to make sure that you release it, and you do not just cut the tendon, you make sure that you release the muscle fibers, otherwise the wrist is going to be ulnarly deviated. As you can see, there are muscle fibers until very distally. This is the distal part, okay? Regarding the fingers, you have to make sure the procedure that we usually do is that we make sure that we find the FDSs. Once we find the FDSs, and we put them on the side, and we try to find the FDPs. The procedure that we do is called fractional lengthening. We do a cut in that position over there, and then we fraction it, we just pull it in the musculotendinous junction. You will see we do it first of the FDPs, which are deeper, and then we do it on the FDSs. And the reason is if you do it first of the FDSs and they pull them, then the whole gap becomes a lot bigger, and the patient has a lot more weakness. This is the FDPs, this is the FDSs. I will just run through those. I'm sorry, it's a big presentation because there are a lot of things to say. Have I run out of time? Okay. And then you can do a step lengthening, as it says here. We do a step lengthening of the FPL. Okay, this is one of the common procedures. The commonest procedure that we do is superficialis to profundus tendon transfers for the patients with the clenched fist deformity. You open up, you cut the FDSs distally, the FDPs proximally, and you suture them back. This is it's a procedure that's been done for a long time. This is the procedure that we should be doing for this patient here, but we've got a better one. One of the things that we could do is just take the FPL and stitch it over here, okay? And we are now doing it if the patient has got just volitional control. We are doing it also independently. I have no evidence, it just works a little bit for the patient and it gives them a bit of movement, and they are a lot happier with that. This is an FCR to EDC tendon transfer, the most common that we do to have some extension of the fingers. Okay, here is the FCR. We cut it distally. When it's here, we try to mobilize it and then pass it through, okay, and then stitch it to the EDC. I'm not going to say a lot more about those procedures because there are too many. What I'm trying to say is that this is an area where there is a lot of things to do further. There are C7 neurotomy that you can do, which a lot of people are doing it. Unfortunately, everything has got small series. I recently went about 1.5 years ago to see it in Shanghai. They do the C7 transfer, and I went there just to make sure that these guys are to see the results. The results are improving. There is also a systematic review and meta-analysis of what they're doing. Okay, here is where we went there, and the procedure as it is. I'm not going to say. The good thing is that they have found we are rewiring the brain in a strange position. This is what Dr. Penn said yesterday. It's amazing. You can also, we are not really sure what's happening to the brain, but things are improving. We don't have the knowledge to understand every single thing, okay? And if we go to here, we can do peripheral neurotomy, where we go to the ulnar nerve. What's really impressive is from the team in Singapore. They're doing neurotomy and immediate repair for the musculocutaneous nerve, which I think it's very good. I asked them, they are really amazing in what they are doing, and they told us a lot of little tricks, and we have started doing this in patients who have got spasticity of the FCR before starting to do the tendon transfer. We are waiting for those results. And of course, peripheral nerve transfers. This is a colleague of mine who works in northern Sweden, Isabella. This is a patient that she did spin transfer, pre and post-op. The patient has got less fatigue. It's extremely happy. The patient is extremely happy. Don't ask me exactly what it works there. It sort of burns my brain, but I think that we don't know how the future is going to work. We don't know what was there before, and we don't know what's going to be there. This is a patient who has got brain injury. We have to understand that. There is something in the brain not working, so we're not sure how everything works. Okay? Just a take-home message, we have to understand what the patient with spasticity is. We have to do a careful preoperative assessment. This surgery for spasticity is a highly evolving field. There are new procedures. We have to make sure that their indications are right, especially now that we're dealing with the central nervous system, with peripheral nervous system, sorry. Unfortunately, we don't have hard evidence, and there is query indication for different procedures. We don't really know. We try to create our numbers. Thank you very much.
All right, Petros, 2 questions. Sorry.
Any you wish. Oh, now it works.
2 questions. Is the neurotomy, that was loud, wasn't it? Is the neurotomy a newer procedure? And then you also, selective dorsal rhizotomy, will you speak to that?
Say again, sorry.
Yeah. Selective dorsal rhizotomy.
Yeah.
It's really loud. Will you just speak to that? And then also I was asking if neurotomy is a newer procedure, and you just said it was. I hadn't heard of that before.
It's more popular now, but as he presented earlier, it's been going on since, what, the late 1800s? But it really has taken off in recent years. And then she talked about the place of selective dorsal rhizotomy.
The selective dorsal rhizotomy, this is why I would prefer that Professor Mertin was here.
Yeah.
Because he's doing it, and I don't have any, I'm not a neurosurgeon, and I don't have anybody around us in Birmingham who is doing it. Apparently, there are too many things that we really don't know the indications, and why do this and why do that. We don't know why to do those things. We just say, I do it right, it works for me, and we carry on. And in a nice way, unfortunately, we have grateful patients. And the reason I'm saying unfortunately is that whatever you do and you release them and you make it better, they are happy. And then you realize, maybe if I did something different, it would be better for the patient. You don't have complaining patients in spasticity surgery, and which is, it's good, but it's not good.
So selective dorsal rhizotomy has found its place in select cerebral palsy children, has not translated very well to adults, although I think there's some experience.
There is some evidence about adults. It's very scarce. I had presented in Greece at some point about it. There are limited series, and there are not too many centers that they are doing it.
Yeah.
It's just, I think, one center that they are doing it, or 2 in the world. So, I don't know, I cannot tell you. There are other modalities that people do, which is the baclofen pumps. So once you have the baclofen pump, I go in and do the rest of it, which is crazy.
Petros, a question, like you mentioned about transferring potentially the FCR to finger extension. Does it really work? These are spastic muscle. Every time I tried it, they don't have control over it. I agree with you with the wrist fusion, because wrist fusion, we try tendon transfer sometime. I think neurectomy has a lot of merit. Wrist fusion, hold them in place. They try to push against the fusion. Now they have flexion, but the problem is extension. Sometimes you transfer tendon in the setting of fusion, but because it's a spastic muscle, because the FCR is spastic as well, they do not have as good control. So in your hand, do they really work?
Thanks for the question. If it worked, we wouldn't do the last thing that we started. If it worked that well, we wouldn't try what we last tried, which was do a cut and repair of the FCR, because it was quite spastic, and turn it around. And now we are waiting to see what the patient is doing. It doesn't always work. The good thing, though, with the hand function, first of all, they're not going to play the piano, which is a good thing. They just need, if they grip something, to have some power to slightly release. And I think if you give them that, it's a lot more than having just a hand which is over there. It doesn't, the function in spasticity is something it's different. They just need something to just open the hand, just open the fingers. Because if you have something and you put it and you grip, then and you need your other hand, you're never going to use it. So if it works, it just gives a jog of movement, but I was never very happy. I'm not really happy with all those, especially in the stroke patients. The stroke patients are patients who are a little bit older. A lot of things are stiff. I don't have any evidence for what I'm saying. I'm just trying. Please. Yeah.
The spastic hand. And so we can use tendons, we can do neurotomies in the hand, which should be normal approximately for a global effect on the hand.
Is it okay if we just one more question and we're finished? Yeah. We're not using any of that. Thank you. Yeah.
Again, Therese Romström did her own PhD on rehab after spasticity surgery. So maybe even if it's tendon lengthening, you have a lot of information there.
And for the figure flexion, it's very difficult for the spasticity. So, not work?
I did it.
So for the wrist and the figure flexion, and the figure flexion is more difficult than the shoulder and than the elbow flexion. So, so a lot of procedures for the spasticity decrease. The SPR for the lower limb and HSN recently lot of report for the shoulder, for the elbow. But for the hand, there's some C7 and C8 new rectum, but also rebounding and recurrence for the figure spasticity. So about 20 years ago, I tried to use the contralateral C7 to the lower track to see whether there is some recovery for the figure flexion. So there is 4 keys. One case is the T1 new rectum. I use the contralateral C7 transfer to the T1. Another also uses the T1 new rectum, but I use the pharyngeal nerve transfer to the T1. Another is the C8 new rectum, and I use the contralateral C7. After 1 year's follow-up, I find there is no recovery. I give up. And about 10 years ago, 1 case I only do the T1 new rectum. 4 cases. There's 3 cases to the T1. Only 1 case to the C8 new rectum. But about 6 years ago, I followed up all the 4 cases. The C8 new rectum with the CC7 transfer is recurrence. And the T1 with the contralateral C7 or with the pharyngeal nerve transfer, the spasticity is obviously decreased. And another one, only T1 new rectum, the spasticity of the finger is also decreased obviously. So about 7 years ago, I re-began the research of the T1 new rectum only for the finger flexion spasticity. So the T1 new rectum is from the cervical incision. So we can find that sometimes, mostly, the T1 is very deep and very short. So we find the upper trunk, middle trunk, and here is the seat. And we dissection the T1 to the distal. And because the T1 is very short. And generally, we ligament the T1 at the proximal. And then we trace-section the T1 node root. The proximal, we ligament, not seriously, only a half. So this is a series about 90 cases of T1 new rectum. In this series, total T1 new rectum, about 40 cases, partial of T1 is 3 cases. And one case use the contralateral C7 transfer, and one case use the phrenic nerve transfer. So there is 19 cases. And the preoperative of the finger spasticity scale of the modified MAS generally is grade 3. And this is the finger and the thumb. And the motor power mostly is M3 or M4 for finger flexor. And yes, we are divided the 90 cases into 2 groups. Group A is no finger activation, complete paralysis. Group B is preserved partial or good finger activation. So there's some difference in the result. And the functional evaluation is modified modified HFC. And level 4 and level 3, level 4 is poor assist hand. So this is the evaluation standard. So this is the result after about 24 months follow-up. The spasticity of the finger flexion is degraded in all the group, in all the cases, and obviously from the M4, from the 4 to 2, and degraded obviously. The hand function in group B is improved seriously, obviously. That means if the patients have the finger activation preoperative, and the result is good. And in group A, also improved, but in group B, improved obviously. And this is the result after the T1 new rectum. There's no obvious decrease of the finger flexion. And also, there's no obvious sensory deficient on the forearm. Only when you touch the forearm medial side, there is numbers, only a little. So we can see this case is CP, 4 years old, and please video, we can see the preoperative and the figure. He cannot open the hand, and see the moderate spasticity of the finger. This is after the T1, about 4 years later. We can see the spasticity of the finger is very, very little. And we can the function and the grasp is also very, very good. And another problem is adduction of the thumb still exists. And the little numbers on the middle side of the forearm. So And we can see the hand function. Please video. Grasp, and it's also good. And you can see but the adduction of the thumb exists. We do the HSN of the adductor of thumb. This is 1 month. This is 1 month after the HSN of the thumb adduction, and improved the thumb abduction. This is adduction, the adduction obviously of the thumb. So for 4 years, we do the HSN of adduction of the thumb. So the improvement is also obviously. If the adduction from the flexion of the thumb may be useful. If the adduction from the intravenous muscle, it needs another procedure. So we can this one. This case is also a spasticity of the CP, of the finger flexor. So this is preoperative. He rarely uses the hand. So this is after the operation, about 2 years after the T1. This case, we also do the FCU to the ECRL, transfer the FCU for the wrist extension. But this is the hand function, about 2 years. We can see the spasticity of the finger flexor is obviously decreased. So another case. So this case is traumatic of brain injury. 1 year after the traumatic, you can see the finger flexor is very seriously. He cannot use the hand. This is after the T1 neurectum, 42 months later. He can use the hand to do some things. This case is performed in the Louisville by Dr. Zhou. And this case is after the stroke. The first is 4 years after the stroke. His hand, the left hand, the finger flexor is seriously. And the spasticity is also seriously. He cannot open the hand. So this is 1 month after the T1 neurectum. And this is the 4 months after the T1 neurectum. This is a picture sent by Dr. Zhou to me. And this is 4 months after the T1 neurectum. He do the rehabilitation. But we can see the thumb is adduction, still exists. And this is the hand function. So before the T1 neurectum, we sometimes do the T1 block. T1 block is very difficult. Not easy, because the T1 is very deep. So we use the ultrasound guide. We can see the needle to the foramen of the T1. And if the T1 is successful, the Horner's cell obviously. So we do the ultrasound for the posterior approach. This case is a T1. Before the T1 block, we can see some flexor of the thumb and finger. He cannot grasp some things. So this is during the T1 block. We can see after the T1 block, this is after the T1 block, we see the hand function. It is moves quickly, and the cooperation of the finger flexion is also good. So we prepare to the T1 new rectum. So another question is whether the T1 block is completely block the T1. So this case is a T1 hand is traumatic, not the spasticity. So we block the T1 and all the function lost. That means the T1 block can completely block the hand function. So before the operation, sometimes mostly we can decide it, we can cut the T1, but sometimes the finger flexion is very, very big. So the conclusion, if the finger spasticity with partial finger activation, the T1 is very, very useful. The other problem is if no finger activation, only flexion, only spasticity, what shall we do? And if you do the T1 new rectum, maybe 2 years later, the spasticity will be recurrence. So what shall we do? We can see this case is there is no finger activation, only spasticity of the finger flexion. What shall we do after the T1? So how can we reconstruct the finger activation? For finger activation, the tendon transfer is rarely useful. This is my experience. I rarely do the tendon transfer for the finger activation. For wrist activation, maybe okay. So what shall we do? This case is very interesting. We see a case. This case is after the traumatic of the brain. So first, maybe about 7 years ago, I have no some experience. Which we hope to recover the finger activation. But the spasticity is seriously. So 5 years after the nerve transfer, we can see a little finger activation. But with the patient's grasp, and he cannot open the hand. So what shall we do? We do the HSC about 50% of the medial bridge via the muscle. So after the operation, it is the finger flexor spasticity is decreased obviously. But 3 years later, this is 1 year after the HSC of medials. We cannot give the hand. So what shall we do? This is about really, this is after the value rector. The spasticity of the finger flexor is decreased, but the patient is no active finger activation. No active. So we began to the glycemic. We do the glycemic. We use the intercostal nerve as a donor nerve, and we also there is some contracture of the finger. We do the detachment of the finger flexor from the elbow. We do the detachment and we do the receding for the finger activation. And so this is about 20 months after the receding for the finger activation. We can see the function of the muscle, but the finger activation is not of the finger. And we do the release of the the children from the injury to the about we do this operation about 20 years is about 6 years long. So there is some contracture of figure flexion. So we also do the detachment. And we also do the release. This is 2 months after the release. We can see the active figure. And we can see this as the figure muscle. There is active figure activation already. We can use the hand. We can open the hand. This is 2 months after the release. And this is about 8 months after the release. May be useful for younger people for the figure activity. For the hand reconstruction, with the spasticity is also very, very difficult.
Excellent talk. Thank you, everyone. Please don't fall asleep. Yeah, thank you. So, I'm not doing neurosurgery anymore. Like Justin Brown is doing the neurosurgery now. We work together on the shoulder reconstruction. The tricky part about the shoulder is honestly the biomechanics. Like respectfully, the majority of hand surgeon and neurosurgeon, they focus on each muscle, but the mechanics of the shoulder and how it works, especially when we talk about shoulder fusion, is extremely, extremely important. So this is why, yeah, thank you. And so this is why I always talk about biomechanics and I always talk about animation, because what's different about the shoulder compared to any other joint other than the wrist, other than the elbow, other than the hip, it is 3 joint, 1 articulation. And many times when we see patients with brachial plexus, the majority of them, they don't have fracture, they don't have stuff like this. We start to focus on muscle nerve reconstruction. However, even if you have rib deformity, the function will change. If the AC joint is dislocated, it will change. If the SC joint is different, it's changed. So there are a lot of things around the shoulder girdle that will make it like very unique. And this is what we have been doing for, not for the patient, to understand more. Right now, we're doing 4D CT scan motion analysis inside the CT for the mobility to understand some of the pattern of how the shoulder move. And it's 3-dimensional. We always simplify it. You can move abduction, external rotation. Is much more than that. If you see, because of the shape of the chest wall, the scapula slide on the chest wall, the AC joint has to move, SC joint has to move in order to have everything working very well. And if any of these have major pathology, the shoulder will not work. If we do anything and the shoulder is stiff, you cannot do much. So this is very, very important. And this is like all of you here, you know all of this, but essentially there are 14 muscles working around the shoulder girdle. 8 work specifically on the glenohumeral joint and 6 on the scapulothoracic articulation. The purpose is not to try to talk about anatomy, but it will be very relevant to when we talk about shoulder fusion, because I really think certain even surgeon, the concept of shoulder fusion and how it works, they may not even get it, because you can fuse the scapula on the chest if it's in the right position and you have all the rotator cuff and deltoid and you can have a great motion. But also the mobility of the scapula is extremely important when you have nothing around the glenohumeral joint that work very well. So you have like 8 muscles work on the glenohumeral joint, the rotator cuff deltoid, then you have the teres major, latissimus pectoralis, and you have 6 muscles that work on the scapulothoracic articulation, and this is going to be very important in our talk. The 2 most important, serratus, trapezius. In my opinion, if the serratus and trapezius are working very well, the smaller muscle, levator and rhomboid, will be less relevant. But they are also important. You have the pec minor in the front. Now, everything I tell you about is based on things we worked on it ourselves. So some people think that the levator can lift the scapula up. It can lift the medial scapula, by the way, but it cannot lift the lateral scapula. So the only muscle that originates from the base of the neck and attached to the shoulder to lift it up is the trapezius. Levator goes more medial and deep. So this is, because we do a lot of open surgery, now we use of the checkpoint, we'll be able to stimulate a lot of these muscles. So other than you say, yeah, you can do cadaveric study, this is in vivo. You cannot have better than this. So look what happened when you stimulate the levator, the shoulder, the scapula retract, but the outer scapula doesn't go up. Now, rhomboid minor, rhomboid major originate from the thoracic spine. They just move the medial scapula border. This is it. They just stabilize it medially. Now, this is a contraction intraopen. You can see this is the tip of the scapula. Bring the scapula close to the spine. Pec minor, very annoying muscle, by the way, because it causes a lot of trouble, and I think it's connected to our brain. Sometimes it misbehaves, but it protracts the scapula. It will become relevant later when I show you the exam, because when you have someone with no paralysis, how you can examine the serratus with the scapular protraction. Because notice what the pec minor can do. It can bring the whole scapula forward. So it can protract, but with an anterior tilt. It's very important. This is a patient we've done pedicle pec. We'll elevate all the pec major. This is a pec minor deep to it. But when you stimulate the pec minor, the whole scapula moves forward. And this will become more relevant later for the exam. Serratus anterior, and this was going to comment about the presentation from Justin about how they elevate the serratus to protect the long thoracic nerve. Just hope, like the distal part of the serratus is extremely important. It does do the stabilization and protraction of the chest wall. So I'm just hoping when you elevate all this muscle, it does scar in a certain way because you cannot fix it to the rib, and we still have the good function that it has. Now, why the scapula, why the shoulder does not move very well when the serratus does not function? Sometimes it was hard for me when I was resident, even junior surgeon. But what happened when the scapula move in an anterior tilt, when the scapula, the serratus is paralyzed, the acromion block the shoulder and you cannot move anymore. This is why you have so much limitation. So during shoulder flexion, the most important part of the serratus is the distal part. Because what it does, it protract, it keep it on the chest wall, protract, give the acromial space open for you able to move. And again, intra-op, this is a distal serratus. When we stimulate it, you can see how it hold the distal scapula and protract it on the chest wall. You need that mobility in order for the shoulder to move very well. That's correct. But also when you do your exposure for these are the one I was going to comment about because you're elevating the serratus. If it did not heal very well, it will not protract very well, by the way. So that's only a comment. The trapezius is a fascinating muscle, by the way, because it does help with the neck motion and is the only muscle, look, base of the neck, the skull, to the lateral scapula. So if the only muscle that can lift the scapula up, the levator scapula cannot do it. Otherwise, the shoulder will drop down. So this is like, you can see how complex it is when we're adding all these layers one by one. Now, this is the issue with the trapezius again and again. Everyone thinks the trapezius, someone will droop only. It does not only droop, it droops with an anterior tilt. Because the trapezius attached to the clavicle and acromion, it lifts the scapula up and retraction. So during shoulder motion, it keeps the scapula open so that it will not push against your rotator cuff during mobility. Very important. All of these are very important. This is why when you do spinal accessory nerve transfer, if you lose half of the trapezius, you may not be able to do fusion. Now the shoulder is not as stable. Sometimes, no, we do it. You have the majority of it. I'm sorry, and it's not correct. Many times you have only a very, very small portion and become hard to use the scapula. So again, this is intra-op. This is a lower trap, like the distal one. The lower trap mostly retract, but the upper trap hold the acromion and pull the scapula up. Very important for stability and mobility of the scapula. And all of this. Now, how can we use this information and take advantage of the great mobility of the scapulothoracic articulation when we do shoulder fusion in patient traumatic brain injury? To start with, and this is, I have been working with Justin for the past like 5 years. I was working at Mayo with the Mayo Group for also 13 years. The majority of our work that we're trying to use on traumatic brain injury and spasticity came from patient with brachial plexus injury. But of course, at the functional level, there is a huge difference between traumatic brain injury and between brachial plexus injury. Like to start with, surgically, when you open a traumatic brain injury, every muscle contract. The patient with brachial plexus injury, they're all atrophic. And the spasticity with co-contraction could be really a problem. So this patient has a brachial plexus injury for 9 years, cannot flex the shoulder, but he can control his elbow. He does not have spasticity. This patient, 15 years, brachial plexus injury, he has an elbow, he does not have shoulder. This patient, traumatic brain injury, different pattern. When I ask him to flex, he abduct. This is always like really, really like I do not understand. The patient, at least I see. Every patient, flex your shoulder, they do this. Can you try to move it this way? You bring them here, they go out. And this is really like, this is so much electricity going on. With it, not always, but some of them, they cannot flex the elbow. And they're able to move it, the elbow extend, they cannot flex. So there is so much co-contraction and confusion that become very, very hard to combine them. Of course, not everyone this way. Some of them are extreme, some of them are not. Now, we've done large number of shoulder fusion for different patients, for different indications. We learned a lot. And the big question, what can we do to optimize the outcome of shoulder fusion? Very basic. Number one, detailed exam of the shoulder. Remember, this patient cannot flex. Like I have a very, I'm happy to share it with you, very detailed exam if you want to examine trapezius and serratus, if you can flex the shoulder. But remember, this patient cannot flex. So essentially, we have to examine only the scapula to make sure trapezius and serratus are working. And second, no-brainer, the technique should be correct. How you position the shoulder is correct in order to get shoulder, like, good outcome. So for the physical exam, basic, very easy. Trapezius, shrugging and retraction, very easy, because I cannot flex. I show you what I do else for patients who can move their arm, but this patient cannot move their arm. So this is just to show like retraction and shrugging, just to make sure like this muscle is working. And you can see in majority of the patients, except they are very fluffy, you cannot see them, but you can see the three parts of the trapezius. Now when the trapezius is paralyzed, this is what you see. I mentioned it before, the levator scapulae cannot give you the contour of the neck, only the trapezius. So you can see the difference between right and left. Levator, even though it tries to lift, the scapula still droop down. The trapezius lift the whole scapula up, and you can see the big difference between right and left. This is another patient. This is very evident. There is nothing, and you can see, this is the only time you can see the rhomboid major and minor, because there is no trapezius to cover them if you have paralysis. Now, the serratus also very tricky because like the standard testing, push-up test, flexion test, you cannot do them. So there's only one test you can do. So the protraction against resistance, which means you ask the patient to push against your hand and look at the scapula. This protraction is initiated by pec minor and by the serratus. You have to be careful if the patient are doing this. You always show them versus this. And it has to be along the chest wall against resistance. This is another patient. You can see push. He's protracting fully. That's all serratus. Now, what happened? The serratus is paralyzed. This is what happened. They push. The medial scapula wing out completely. Okay? Now, can they protract? You can see the next one. He's protracting, but he's using pec minor. Now, I push against my hand. He cannot. The scapula wing out. So what's happening, the scapula is coming forward with an anterior tilt. And this is very important because if we do the mistake and we do fusion on someone with serratus paralysis, is a big, big problem. So now patient with the spasticity, again, the pattern could be so variable. The one I have inherited, of course, when I get them from Justin Brown, it means he tried everything on them and they need something to be done. And this is why they end up in my hand. So most of them, shoulder, but many of them also shoulder and elbow. You do Botox, everything they keep on doing, either this, or they cannot get their hand on their face. Like this is another patient, like usually their pattern could be really variable. There are so many variation of them. For me, the one I've seen, the majority, they cannot flex their shoulder. They just can't. Anytime as a deflection, they go into abduction and they do this and they cannot get their hand on their face. Now, this is the question. Is the fusion a good option for patient with dysfunctional shoulder? The answer is yes, but with some hesitation. And this is what we learned about from patient with brachial plexus injury. So this is an example. Brachial plexus injury, they're going to have very good function. Why? Because they have no contraction of the fingers, of the elbow. It's just the shoulder. You position the fusion in good position. They're solely using the scapula to move their arm, and they have very good function. Now, we were not able to make all these patients happy. So honestly, I remember someone from Kuwait, I did fusion on him. He was quite unhappy. So what shall we do? Like it's hard, why is it unhappy? Because if you tell the patient, I fuse your shoulder to get you better, they don't understand. Sometimes you tell the surgeon, like you fuse them, they get better. What do you mean? Like how my shoulder is gonna move when you glue it in together? So it's hard for them to understand. And remember, this is not a temporary, this is a permanent option. So once you do it, you cannot undo it. So what shall we do to confirm that fusion is the right option for the patient? Anyone has any idea? Well, we came up with this, and like Idris Garbawi, like a long time ago, me and him, Narakas, talk about it. Now, almost routinely, we do this, percutaneous spinning as temporary measure. So this is a 5-10 minutes procedure. You position the patient in the fusion position. You wake them up from surgery. You either do it, if they're awake enough, you let them test it. If they're happy, great. If not, give them 24 hours, bring them back the next day. Now they know what fusion is. Otherwise, it's very hard for them to know. It's hit and miss. So, and this is what we do. So, this is a patient. He had I'm going to show you brachial plexus spasticity. He had an abduction. He can put his hand on his face. And this is one of your patients, Justin, by the way. And then I said, like, yeah, I saw him. This is outside the clinic. I thought, this is quite good. So are you happy? No, I'm not happy. I don't like it. So now imagine I fused him. Now we are very unhappy patient for a long period of time. Okay, that's another patient, spasticity as well. This is stroke, by the way, patient. I did it for him. He had no function. Are you happy? He was super happy. And he's super happy. You take the pin out, you do the fusion later. Now, this patient, brachial plexus, this is different. He has no motion whatsoever. Pin him. This is him in the OR. He was waking up in the OR. He looked at his hand. He could not believe it. For the first time since, I don't know, 4 years, he was able to move his arm. He started to scream in the OR. So he was quite happy, and we did the fusion for him. So this patient, brachial plexus for a long period of time, pinned him. This is his function in the recovery room. Of course, brachial plexuses are different. So he was quite happy. Then we fuse, essentially, this is an example. We fuse his shoulder. This is him, virtual visit with him. He's quite happy with his shoulder. Okay? So this is a patient with spasticity. This is also one of Justin Brown's patients. And he has a combined brachial plexus and spasticity at the same time. This is pre-op. This is in the recovery room after pinning. Again, you can see, like, they want to get to their face, but they still, after, they can flex now. They usually cannot, and it's difficult for him to reach. He was quite happy with this one, but he told me, like, let's wait. Maybe there's something come up over time. If not, I'm going to do it, but he was quite happy. So we did publish about this one. This is called two-stage for fusion, which means you pin the patient first. You let them see if they like it or not. If they like it, we do fusion. If not, and believe it or not, 30% of the patient did not want to proceed with the fusion after pinning, which means if we don't do this procedure, there is a likelihood, other than complication, 30% they may not like it. So now I routinely pin every single patient before surgery. So in summary, what's our approach? Detailed exam, very important. It's very important. If you don't get it right, do it again. Examine the periscapular muscles very, very well. And we offer the temporary pinning for the patient. If they are happy with the pinning, we do the fusion aiming for the patient to get their hand on their face. Inpatient also, we did the fusion, but they're still not able to flex their elbow, and they tried everything else, so I do for them triceps to biceps. This is a 45-year-old female patient, just as an example. Spasticity, inability to flex, neither the shoulder nor the elbow, so I did for her fusion. She still has difficulty even to get her arm up. Then we did for her triceps to biceps transfer. And this is her cane. She's quite happy with it. Now she's able to control her ability to get. Before, honestly, I do not know why, but this is also the advantage of the fusion because these patient tendon transfer would not work. So I will say she was very happy, and you never fail until we stop trying, but we're gonna keep on trying to make our patient better. Thank you very much.
Proximally.
Professor Wong, do you have any role now for a C7 neurectomy and spasticity? Any role? C7 neurectomy. Is there a patient for this or no patient?
C7 is not control the finger flexion.
Right, right. But if
So-
they have tricep or chest. Yeah.
The elbow maybe elevation is good because the adduction, the spasticity is decreased.
Yeah.
So after the cut off the C7,
Yeah.
and another, if the tricep spasticity is very strong, after you cut off the C7, the elbow flexion.
It's going to be better. Yeah.
And the FCR is innovated than the C7. So you cut off the C7, the wrist, the tissue may be okay.
Yeah.
So for the finger flexion is a tissue, little, very little. When you cut everything, sometimes also the stick, or the finger also
Yeah.
that's like you cut off the upper,
Yeah.
the upper limb nerve, the lower.
Yeah. Now, we talked in Spain about the weak finger extension, and C7 has some contribution of finger extension, that it could get worse with the C7 neurectomy. That the,
This is very important.
yeah,
Before the operation, the finger tissue is very weak.
yeah,
You cut the C7, and also
even, yeah,
whatever it is, C7, you can cut off partial of C7.
yeah.
If only the paper, you can cut off the anterior of C7.
There you go. Okay.
For the finger tissue, and for the elbow tissue, or shoulder abduction is also. This is very important. So we need to the research to the block C7.
Yeah.
Every case and the result.
I think that makes sense. And we always have another,
Every case
yeah,
to the block C7.
yeah,
And then we select
and see what happens, huh?
contralateral C7 to C7, also the same.
Yeah. Just like neurectomy.
All the same.
Yeah.
So in the paper, in the New England, improved is shown or
When we did a fusion together, Bassam and I, we had a patient who had minimal elbow flexion. spastic patient. She had a brain injury. We did a fusion, and she came out of that with a beautiful elbow flexion, which we never would have anticipated. Would she have that when you pinned her? No.
Not the same. The brachial plexus, yes, because of the inferior subluxation.
Right. And I understand that one. The stroke spasticity one, I did not understand where that came from.
And you have to understand, like when we expose the shoulder in stroke patient, the muscles are there.
Yeah.
So I'm not sure also there's anything about when you're detaching this muscle to do fusion, it triggers some kind of circuit here to shut down and activate. They're different than brachial plexus completely.
Yeah.
I have a question. When you finish the shoulder,
Yes.
about the lateral or regional rotation, you like which field, which position?
Well, there is. So in surgery, this is the part I'm like when the fellow's with me, I'm holding the arm, and depend on the patient. But in general, no angles. I don't measure any angle. You bring the arm, keep the scapula down. You bring the arm in flexion, not abduction. In flexion, in a way that you'll be able to. You put your hand this way, like but not the top, not like all the way up. Like you see here, you put this way. You'll be able to get your face on top of your head. So I put it here. And I hold it this way.
Like this?
Exactly.
Okay.
So like, oh my God, what have I done?
Yes.
How about this?
But with this one, they get it. This way, I don't get it very high. So when you do it this way, they can get it here, they can get here. Yes. Yeah. The key is not to do too much abduction, because abduction, they cannot get as much. If you do more flexion, it's better for them, and you can use the scapula for protraction, retraction, and get a better mobility. The main problem is what the patient wants. I have a patient for Dr. Brown. He did for him surgery. He did good job, but the patient, every time he moves, he got flexion supraspinatus, but every time he goes in. I fused him. He came he's super happy. I'm sorry, but this guy, he wants external rotation. So I intentionally put him in external rotation. There is one patient, I pinned him twice. He's from Saudi Arabia. They like to pray, so like their prayer, the hand is here. So I positioned him the usual way. He woke up from anesthesia. He loved it. 20 years he could not flex his shoulder. He has no triceps, so he slapped himself. He woke up. He said, "Who slapped me?" I don't know, nobody slapped you, but because these patients, when they don't move, they don't know they need the triceps. So now his arm is up. He did it twice. Like, stop slapping me. I was like, nobody's slapping you. But anyway, he used it 24 hours. I said, I love it. My family love it, but I cannot do my prayer. Can you change it? So we put him again under anesthesia, put him under internal rotation. He loved it. Then we fused him. So we put him more in internal rotation.
Will you use the weight or use the screw?
Both.
Fix the issue.
Pin for the screws. These are guide wires. I put 4 of them. 1, 2, 3, 4, and then put the screws.
Use the pin.
Position, pin, screws, plate, and bone graft.
And for the upper extremity,
As a general rule, this is not what I'm going to say. There is no evidence about it, but this is how we usually practice. Okay, there is no evidence about it, but that's how we usually practice. So when the patient, the joint that you're in has full range of movement, you can do neurectomy. If it doesn't have full range of movement, as a general rule, it's better if you do some kind of tendon procedure. But for the fingers, for the finger flexors, Caroline Leclerc proved in a paper that if you need to do hyperselective neurectomy, you need to detach so much that in the end you're doing a slide. And you create a lot of scarring in there. So you're not really sure what's really working. If the patient has got function, I haven't seen, especially doing just selective neurectomy, which branches. I'm a little bit afraid that I'll end up with a patient that has got some fingers moving and some fingers not moving if I just go to the branches. I think that the fractional lengthenings are a lot more predictable. At least I know what I'm doing and why I'm doing it. This is how it is. Generally, for neurectomies, we prefer isolated. If the patient has got full passive supination, I prefer to do neurectomy to the pronator. The thing is that unfortunately, and this is why I discussed about the contractures, I hardly ever get the patients in a position where they've got all those things. They come to us, they are referred to us when they have established contractures. So we are firefighting. We are not doing, having so many options. I wish we had.
And last one for Dr. Wong. Many times when the wrist and the hand comes together, the only movement they have is you peel it open and they come back like this. The FDS is the strongest, most spastic muscle. So I've been taking that and putting into the wrist extension, ECRB, so that when they close the hand, the wrist comes up. I'm hesitant to do your T1 neurectomy because I am worried that I'm going to decrease that strength and I'm not going to bring the wrist up. Would you do both T1 neurectomy and FDS tendon transfer? No. Only to the FCU. Yeah.
I hope to do some tendon transfer, but several is failure. I'm afraid I'm not used because after the T1, the tension is quickly degraded. Maybe we can use the FCR or FCU transfer for this. But I'm afraid after the operation is degraded quickly, very near normal. At this period, you can use the FCU transfer for this, not to the Gracili. Gracili is difficult. For fingers? Yeah, for finger. Maybe because if the tension is very strong, you do the tendon transfer, maybe no useful. After the T1, new rectum, it is degraded, near normal. So you can together do, you can try. So.
And one more for you before you're done. You use intercostals in hemiplegia. You use on the same side.
So the problem is the intercostal, no spasticity.
The whole leg, the arm is spastic. I would assume it has to be spastic. Yeah, yeah. Okay. You're not worried. You're not worried. Okay. I just assume if the arm's bad and the leg's bad, everything in between must be bad as well. So I've been doing grafts from the contralateral C7. Do you use contralateral C7 for the gracilis?
Can I make a comment?
For the gracilis, to open the fingers, a sural nerve off of the contralateral C7. Yeah. Yeah. So you trust your Tenels? I don't trust my Tenels. Yeah. Yeah. I don't know. That activation of lower trapezius is usually crummy. Well, we better wrap up because we have to move to the next session. So we'll take yes. Depends on the clinical presentation. If they present identically, we treat them pretty similarly. If they present differently, then we treat them differently. Yeah. Huh? Okay. And you're talking. All right. Let's take 5 minutes. For the next setup. We're going to bring some people up front. We have a panel, and so everybody take 5 minutes, and we'll get started then.
Hello?
Make sure that I don't look surprised, please, because if I look surprised, it's me.
Karen, do you want to advance with this and be down there with the crew while you talk?
No, I'm going to do the presentation and then I'm going to walk down just with the microphone. And yeah, so is it okay if Chris sits beside you, Macy? Yeah. Okay, let's sit here.
You guys are just me hanging out.
It's fine, whatever you want, but it's up to you guys. Invitation. Yep. Okay. So I'm going to give about 10 minutes. I'm going to talk about mental health, and then I'm going to introduce you guys, and then I'm going to ask you guys the questions. We've already kind of gone. It's not up on the screen. Should I do something else? Hello? Can you hear me? Hello?
There you go.
Hello? Oh, hi. Oh, that's it.
I should have enough for the, I should have enough.
Should be enough, because it's not in the red.
Yeah,
but
you know,
just
it's
in
only
case.
10 minutes. Is it going to last 10 minutes? Okay. I just, can I do this one? Yeah, okay. All right. Fine. It's only, I mean, he said, thinks about it. Let me just get started. You want to introduce me real quick? And then...
Just bug that. All right, we're gonna move on to, is this our final session? This is the final session of the day. You know, Bossum, you know how Alan Bellsberg likes to come to these and say, you know what patients really like? And he'll tell you what they really like. So he and I were arguing, and I called Chris here, and I said, Chris, what do you really like? And Chris, of course, disagreed with Alan. And Alan's like, hang up the phone, hang up the phone. He doesn't know what he's talking about. What he really likes is, so I thought that was hilarious. So anyhow, what we want to do today is, one, give the rest of the picture. We got the surgical picture, we got some rehab, we have therapy we've talked about, but what about everything else you got to deal with an injury like this? So Chelsea gave us a nice lead in, and the psychiatrist here, who I like a lot, my wife, is going to give us her take on it, and then we want to hear from the folks who've been through this themselves on what are the things that we need to know about when we're taking care of folks who've had injuries like this. Like, what are the things other than reconstruction? What's the rest of the picture? So with that, turn it over.
Okay. Hello. My name is Karen Brown, and I was asked to discuss the mental health support for paralyzed and injuries. I proposed, I'm so sorry, this is in my screen. One last question. Justin, I'm so sorry, but this is blocking me. Just a second. I don't know how to get rid of that this little box that's like in my screen. Do you know what that is?
I don't even have a cursor.
Yeah, me neither. Great.
Hope it doesn't pop up.
Me too.
Do this. Go up here. There's a cursor.
It's okay, I'll just use the screen.
No, it's on.
It's okay, I'll just use that.
All right. We hit use slideshow.
Okay. All right. I was asked to do mental health support for paralyzed and injuries. I had proposed that for the Paralysis Rehabilitation Center to be successful when providing surgical paralysis reversal and rehabilitation services to paralyzed patients, that mental health and spiritual support is a critical component. Close your eyes if you're willing, and imagine that you're now waking up. You cannot move your body. There's a machine that's breathing for you, and you hear a voice letting you know that you have broken your neck and that you are paralyzed. I want to give everyone a frame of reference for what we're talking about here today. Rehabilitation is to restore that condition of health, is to restore to a condition of health or useful and constructive activity. We've been talking for a day and a half or longer, looking at the most innovative, cutting-edge surgery for paralysis reversal. And we have talked about some of the frontline research projects that are being put forth now for this endeavor. My frame of reference is the Paralysis Center in Boston, and there's many other across this nation and across the world doing these same things. A lot of them also have ancillary services such as physical therapy, occupational therapy, orthotics, prosthetics, physiatry, and pain management. So what could possibly go wrong? These people have poured out their lives and their careers and their hearts to come up with strategies to make improvements for their patients' lives. I want to let you know that all-cause barriers to rehab treatment success are comorbid and secondary medical illnesses. Pain is a big one, and we're going to hear about that in a minute. Medication side effects, cognitive deficits, lack of support, lack of financial resources, lack of transportation, and lack of motivation. We talked about that with Chelsea's presentation. I want to highlight quickly comorbid and secondary psychiatric symptoms. It's beyond the scope of this presentation to talk about anything much more beyond spinal cord injury. I'm not going to go into each paralyzing injury in detail. I'm going to look at this as a whole. The known mental health risk factors in patients with spinal cord injury, the top 3 are depression, anxiety, and substance. If somebody has depression, all-cause depression, they are at increased risk for suicide, and I'm going to include PTSD symptoms along with the anxiety. Depression and spinal cord injury is connected to poor quality of life, unsatisfactory health behavior, and greater impact of secondary medical conditions. A recent meta-analysis suggests that 20 to 45% of people with spinal cord injury do experience depression. That is probably low because it's often undiagnosed. These patients have difficulty getting care for treatment, and they're at high risk for additional secondary psychiatric conditions. For example, if they have depression, a lot of times they will eventually end up having symptoms that meet criteria for anxiety disorders and substance. The risk factors for depression should not be a big surprise here. The highest time of depression and suicidal thoughts is immediately after the diagnosis, so in the acute rehab. Also, directly following discharge from any rehab into their home, where there's a realization that they're not functioning at the level that they were, and they have to make some adjustments. Being diagnosed with secondary medical conditions, chronic pain, infrequent meaningful activities, low self-esteem, and a negative appraisal of the circumstances of the disability. Also, they go get a surgery thinking that it's going to bring a certain improvement, and it doesn't work, a sense of disillusionment. These patients are at extremely high risk for suicide. Patients with spinal cord injury are at 4 to 5 times higher rates of suicide than other groups. Leading cause of death, it's the leading cause of death in spinal cord injury patients 55 and younger, and 75% are completed within the first 5 years. The primary psychological considerations for the suicide, the things that I want to try to alleviate or remedy right away, is feeling that they're a burden to their family, friends, and community, feeling they no longer have a purpose in life, pain, and lack of social support. The protective factors: positive self-esteem, feeling like, you know what, this is another challenge, it's a big one, but I can do it, I can get through this, an increased sense of coherence. So you're going to hear from Don, he is probably the very best example of this, but his house was corrected, he went back home and started working right away. It's a sense of coherence in his life, and that decreases the risk of depression. Increased socialization is huge, and we're going to talk about that. An accepting or fighting spirit, right, Macy? And hope and orientation, and as Chelsea was talking about, their style of coping. There's a duality of treatment and depression. If I treat the depression, they are more likely to engage in therapy and do follow-up from the surgery, rehabs, and they'll have better outcomes. On the other hand, if Justin does a surgery, it creates better independence and more abilities to function, then they are less likely to be depressed. Anxiety and spinal cord injury, 20% report symptoms meeting criteria for anxiety disorders. Number 1 is going to be generalized anxiety. Number 2, panic disorder. And number 3, symptoms of trauma or post-traumatic stress disorder directly related to the trauma of the accident. These anxiety symptoms compromise their participation not only in the acute rehab, but also in successful community reintegration upon discharge. This was mentioned earlier by Dr. Marcus, but the common anxiety sources are feelings of helplessness, dependency, and vulnerability, anxiety related to falls during transfers, and ventilator weaning. This anxiety contributes to sleep disorder, lower quality of life, lowered pain thresholds, and interference with treatment compliance. Substance use disorders, honestly, successful participation in rehab does involve cognitive and motivational challenges. Substance abuse can be a barrier. The concern is that a lot of times we're using substances like sedatives and pain medicines in the hospital when they didn't never use those before, and then they have problems, new problems with dependencies. The effects of the substance, as you can imagine, less participation in therapy, lower functional gains, longer lengths of stay, emotional symptoms, depression, anger, anxiety, low satisfaction with life, and increased psychosocial problems, higher mortalities. Just like, for example, a farmer can get the best seed from the best plant, and he can go plant it. And if he's planted it on rock or he's planted it in shallow soil, it's not going to do very well, no matter how great the seed is. He needs to develop the soil, add fertilizer, and make it a nice environment for the seed to grow. In that same way, we've been listening to all of these efforts. There's, diagnostic tools being used to try to figure out which nerve to transfer and how well that case is going to go and what are the outcomes and is this nerve more viable than that one and all that effort. But if that patient has a nerve transfer done and they develop a severe clinical depression or severe anxiety or they get lost to follow-up or they don't do their rehab, then it hasn't really done anything that we've tried to get it accomplished. That fertilizer is this treatment of depression and the other things that would alleviate depression, just global support for this person, the patient that we want to treat. We're trying to create a good environment so that there's good wound care, there's less stress, there's less cortisol, there's less infections. The nerve is going to have a chance to grow at the fastest rate that it can to its endpoint. The patient is going to be motivated to engage in physical therapy and other rehab recommendations. There's a peacefulness in them as they receive the therapies and relax into it. And just like Jack Penn was talking about neuroplasticity. So they've got to be able to focus their mind and shift some things around, even in their brain, a learning of combining new nerve. The nerve over here for breathing is now causing their arm to increase, and that takes energy and focus. And we need to create an environment so that they can do that the best. I'm going to briefly reiterate, Chelsea was talking about that there are outcomes and statistics showing that when these patients are coping well and they have this good environment within themselves, then their outcomes are improved. Jack was talking about neuroplasticity, talking about exercise and motivation and therapies, neuromodulation, nutrition, and treating depression. That's the medications like SSRIs. So my concerns were in the paralysis center, are the paralysis patients able and willing to maximize the benefits of the surgery they receive? Are they fully engaged in post-op care? And for the research, were the research outcomes, were they accurate? Was the patient, was the surgery inherently not working? Or was it not working because it would have worked, but the patient wasn't doing the rehabilitation needed? You've seen the pictures where the effort that they need to do to get a little bit of gain, a little bit more, that's pretty intense physical therapy to make those corrections. So what should we do? Very simple. Screen each patient. When they come into the surgical centers, collect the data, use it in the research outcomes reporting, and use it in patient algorithms to direct the high-risk patients into mental health care services. They're simple screening paper. You can give it in the new patient paperwork. It is not that hard. It's a Beck's depression inventory, a Beck's anxiety inventory, WHO substance screen, the COPE that Chelsea was talking about, and consider a pain scale for pain. If they screen positive for depression, anxiety, or substance abuse, they can see psych. If they screen positive for pain, they can be referred to pain management. The role of psychiatry is simply to either do some of these screens, to evaluate the patients that screen positive and to continue their care. Consider adding a psychologist for individual and group therapies and family therapies, and licensed clinical social works to advocate and address psychosocial. I'm going to briefly mention spiritual support. From a Christian perspective, it's a religion of suffering for the suffering, and it's a religion that a lot of people, when they have global or catastrophic events, a lot of patients will turn to faith, and they will realize that in this there's a God that is, familiar with suffering, and they can relate to that. They need to forgive themselves and the people maybe that were contributing to this injury, offering hope for healing. We're talking about a religion that, there was supernatural healing and resurrection from the dead, so we believe that miracles happen. Offering a reframing of purpose. They might not be able to do the exact job that they did, but Macy's a great example. She came out of her injury and is now advocating and trying to make laws and fundraising and things to change the course of treatment for spinal cord injury patients, and she wants to go help people because she knows what it was like, and now she has a purpose in her life that's different, but it's great. Sanctity of life, as you know, and just to offer the reframing for value. This scripture, Micah 4:6-7, is one that Justin and I think about all the time when he gets ready to go to work. And it's this: in that day, declares the Lord, I will gather the lame, I will assemble the exiles, and those I've brought to grief. I will make the lame my remnant, those driven away, a strong nation. The Lord will rule over them in Mount Zion from that day and forever. I want to leave you with two quick analogies, and then I really want to stop myself and everyone else from talking about these patients, and I want to talk directly to these patients, and I want them to talk to you because I want you to hear from them what got them through and what they need and what they're asking you to do. And so the two analogies that I have are one. I met a man who was doing regenerative farming, and he came up with this healing from these fruit leaves, and it was like all the trash, and they would be collecting it, and he's going around and he's like, I'm seeing gold, I'm seeing, the answer, and everyone's just throwing it away, and he's collecting it because it's the answer to everything. And I just want to say that when Justin and I see spinal cord injury patients, we see people worshiping God and people who can pray, and that's something that we value in our faith, and that's something that we see as valuable within patients. You don't have to do that. You don't have to have an intact body to be able to do that. And so we see gold. This is a picture. I'm going to leave you with a coral reef. As you know, it is a symbiotic relationship between algae and coral. The algae produce the food through photosynthesis, and the coral protect through their landscape. Basically, they create that environment to protect the algae, but to protect all the other animals living there. I want to suggest that we have, even right here in this room, a situation kind of like that. These patients need you and me, and they need us to go out and do our very best, just like what I've seen this last day and a half. And I want you to know I've talked to these patients, and it gives them hope, and it's a thrill. But we need these patients. We need Dawn, we need Chris, and we need Macy. They're out there now being patient advocates. They're praying for us. They are making part of advocating for laws to change. They're publishing and publicizing all of the research and all the things that you guys are doing, and you were working hard to do that, but we need each other, and this is kind of an example like that. So without further ado, I would like to introduce Chris and let him talk about, if you're willing, talk about your initial injury, and tell everyone here yours. Thank you, honey. Tell them your story. Tell them what happened and what that was like for you and the emotions that you felt at that time.
Hi, my name is Christopher Janney. First, I just want to say thanks for everything that you all do. I don't know if I would have been around, or would have stuck around unless I had top quality physicians trying to change my life and make it better. I know it's a challenging thing with traumatic injuries, the traumatic brachial plexus injuries, is that usually their lives are upside down for a couple of years. They don't know how to say thanks just yet. So if you don't get thanks from any of your patients, I'm giving it to you, because I get to talk to these guys 10 years, 15 years down the road, 5 years down the road, and their lives have come back around, which is great. It's a beautiful thing. I was injured in 2002, December 15th, riding a motorcycle back from a friend's house. He just bought a house on the beach in Manhattan Beach, and we spent the night there. And I was on the way to have a play rehearsal for a play I was in that night. I was in the theater and an actor. I think I ate too much. I had like a double breakfast, double cheeseburger and pancakes and the kind of thing I usually do because I was a big guy. But I had a little bit of a food coma, I think. Wrecked my motorcycle on the freeway, trying to get towards Hollywood area, and ended up waking up in the hospital. My sister there 3 days later. My shoulder was so swollen they couldn't put me in an MRI yet. And the biggest challenge at onset was just trying to figure out what's going on. This was 2002, so websites weren't really available for hospitals and brachial plexus injury and things like that. It was word of mouth. And all I wanted to know was, like, when can I get more diagnostics and find out what's going on? Fortunately, I've got a brother who's in biotech and successful. He actually reached out to Dr. Weiss Young at Rutgers University. At that time was Christopher Reeves, neurosurgeon, and a big proponent of stem cell generation, or trying to. He just told my brother, well, if it's this, if your nerves are avulsed, it's not like a broken bone. You're kind of screwed. There's not much you can do. I mean, it's very little you can do. You got to figure this out yourself. And my brother told me that when I came conscious, like day 3. I was still pretty high in morphine. And it put me in a driver's seat to some degree. I've always been sort of do it yourself and figure it out, but I still didn't know how bad the problem was. And because of that, the hospital I was at, USC, but also went to UCLA in Los Angeles, I couldn't get any real diagnostic on if one nerve is torn out, 2 nerves, 3 nerves, 4 nerves, and that was, I think, the physician I was dealing with at the time. But if it wasn't for United Brachial Plexus Network, nonprofit that I was president of for the last 5 years, and I've stepped down, but been involved with their forums where patients were sharing information, was where I learned how to get elsewhere. And because of that, I traveled all over the country, willing to leverage everything I own to do that, even to the UK, and getting surgery at the Mayo Clinic, which was phenomenal. And all the other surgeons I actually met and told them I was going to the Mayo said, go do that because of the options they can provide to you. I don't know how much to cover, but the point of it is that the journey is a tough one. From the patient perspective, community is one of the best things is to learn so you can get real word of mouth about what's going on, what to expect. False expectations, I think, are natural. People don't want to believe it's going to happen to them. When I was injured at first, there weren't any images of people with brachial plexus injury on the website, or any website, period, internet. And that was actually one of the first things I wanted to put on, like, UBPN's website was pictures of, like, me with my shirt off, so people can know what to expect. And that gives people a leverage of knowing what they have to work with. If you're left in the world of mystery, you're going to be stuck in misery. One of the best things a psychologist I went to see, because my sister was traveling with me all over the country. So that's better. Saw a psychologist because of the tensions with my sister. She was my champion, but frankly, I told her, I said, look, if this doesn't get better to where I need it to get, I'm not sure how long I'll hang around. And this, one of those components was the nerve pain I was in was just beyond my ability to understand. I used to have this little quote I'd say to myself to keep myself sane, that I knew pain because of my own previous history, pre-injury. I'd been stabbed multiple times, had to go to the hospital, drove myself to the hospital, had half my liver removed. When I woke up when I was 21, this is a gang in Los Angeles, I refused all pain meds because I just changed jobs and didn't have insurance. And I said, I don't want anything in me that I don't need to have in me. And they just opened me up from the ribs to my belly button, taking out half my liver. And I endured. And I figured, okay, I can do that. And I was in there for 10 days. Couldn't drink any fluids because the knife went through my stomach. So having cotton mouth was a new discovery. But the point of it is, so I'd say I've been stabbed multiple times. I'd been shot when I was 18. A friend of mine hunting had a pistol, accidentally pulled the trigger, didn't have it on safety, went straight to my foot. Okay. I grew up with hunters, and that you couldn't have more of a shame, being shot by a friend. I didn't ever go to the hospital. I just got drunk for 5 days. We were on spring break at his grandfather's house in South Carolina.
I'm hearing you say that the pain was the biggest issue for you.
Yeah, 100%. I mean, that's...
What would you say to the students here, and what would you ask of them?
There's research out there that you can treat the pain at injury onset, surgical onset. And I'd like you to investigate it. But recognize that your patients, if they're a little bit low or depressed or not giving you the feedback you'd like, it might very well be because they're depressed because they're in pain. And also just the changes that come with the injury itself.
Yeah. The pain is, it's blinding or it's obscuring everything else. It was distracting you beyond the ability to function. Okay. Dawn, can you tell? Yeah, I sure can. So I want you to tell first the audience what happened. Mm-hmm.
Sure. First of all, my name is Don Chester, and I live here in West Palm Beach. And I was a triathlete, and a pretty good one. And I was running across what was then the Southern Broad Bridge. Now it's been replaced by the Donald Trump Bridge. And I was hit by a car, taken to my trauma center at St. Mary's Medical Center. And even in the trauma room, I knew I was paralyzed. And then I spent 7 glorious weeks in ICU, where they took great care of me, and go back to them all the time and thank them. One of them even said, I bet you never thought I'd be giving you a bath, which they didn't. Fortunately for me, I have an incredible wife, Sally, who's right over there. Sally, wave your hand, who is a registered nurse and a master prepared nurse, and she took care of me. We had friends in the neighborhood who remodeled our house so I could get inside. Pretty much told the mayor, who was a friend, that we were not going to get permits and we were just going to do it. And a contractor friend did it. And then other people who I knew from the hospital came in and did things like tile work and raised the floor and everything. I had every possible benefit you could have, which is a lot different. I spent 6 weeks in inpatient rehabilitation, spent a lot of time rehabilitating at home, went back to work in just short of a year, and the hospital was fantastic. I could go back to my old job. I couldn't have the 7 or 8 different departments that reported to me. I only had a few, but that was great. And the other thing that was great is I had a service dog, a white shepherd who, Pollyanna, who was absolutely fantastic. And if you have a dog, people don't know what to do to approach you when you're in a wheelchair. But you have a dog, they want to talk to the dog. And it's wonderful. I had a dog, Iggy. Unfortunately, I do not have a dog now. Iggy got cancer. But I would go around, they would know him. They had no idea who the heck I was. But they would go him and they talked to Iggy, and it was a great icebreaker as I went around town and did everything. And we got a handicap van so I could go wherever I wanted. Not necessarily the best driver, but we got there. And that's just the way it is. I just hold my breath and say, we really need to turn here. That type of stuff. But I think I had all the benefits that you could possibly have for someone who was injured. There's really nothing, more than that. I go on. Now I work from home, thanks to computers. But however, after college, most of people want to work from home. They want to spend, 20 minutes or so driving or a half hour trying to find a place to park, meet for an hour, and then go back to their office. So we do most of our meetings over the phone. A lot of my meetings are out of town anyhow. Everybody else is on the phone. They're in Dallas, they're in Tallahassee, do a lot of government work. Quite frankly, it's pretty good not to have to be in Tallahassee these days. Or Washington for that matter. But I do work with those folks, and I do keep up with all the key legislation and have a different perspective than other people have, which I think is very helpful because I look at it as someone who is at home, who has a disability, quote, has a disability. I don't think of it that way. I just, have a different way of getting around. And that's about it, unless you have any questions. I'm so very honored to be here.
You've been listening in for a little bit, and you know that this is a conference where they're trying to advance medical and surgical things for paralyzed patients. There are a lot of upcoming doctors and medical students and things like that. What would you want to say to them?
Listen. Don't just fill out forms like you have to do now and everything, but listen to the patient. My father was a cardiologist. He would spend 20 minutes listening to his patients, and then he'd examine them a little bit. But he knew what was wrong with them. If you just listen to them. Unfortunately now, with all the government work and all the forms you have to fill out, you don't have time to listen, which is a shame. But if you can, as much as you can, listen to the patient, and they'll tell you a lot of things that will help you out. Listen to the nurses, too, because they know everything.
Okay, please.
Now, have you listened to some of these talks today? I look at your hands, and I'm like, I can hit a home run with both of these hands. Let me ask you, some folks decide not to get a fix. How did you come to the decision? I'm going to leave it alone.
I don't think as many options were available when I was injured. I think there are much more now. I think there was a doctor that did some hand surgery. He said, well, there's somebody in Italy who can do this, and Italy sounds nice, but I didn't really want to go there. Honestly, as I said, the minute they took the trach out, I wanted to start meeting with my direct appointments. So, getting something like that going away and getting things fixed, that wasn't an option. It was getting back in the office, which the hospital is fantastic in letting me do that and giving me the option to do that, and they still are now. They're just incredible.
I'll have to ask Macy the same question, but I do have a number of folks that say, I don't have time to have my hands fixed. And to me, I'm like, how could you not have time to be able to feed yourself and so forth? But it's common.
Yeah, and there are a lot of devices that we use, and they're very simple. And we showed them to people, like there's someone in the hospital right now in ICU who was injured. And I was talking to her family and I said, I need to bring in these devices. First time you just kind of talk to them and you listen to them. Then you bring in, this is what I use to eat. This is what I use. Sally, hold up the cup that I drink with, will you please? It's got a handle on it and a straw. You know, you get those from Tervis Tumbler. Forks, knives, I have things used for typing. I dictate into my computer. It makes it easier for you to live because you can do things and you can be normal. You know, if I'm on the phone.
All right, this one's going down.
Care where you. If you can, you know, answer someone's question, they really don't care where you are. They just want to, you know, meet with you, learn from you. I want to learn from them. Same type thing. We don't want to do.
All dead at this point. Yeah.
Can you tell your story?
Because they get the power from the wire.
None of us are safe. At any moment in your life, it can change. You're not impervious. I was literally in 6-inch Jimmy Choos running around all day at work. And that night, it took me out. So there I was thinking, I'm at the peak of my career. Things are going really, really well for me. And this is the moment that it's going to change, right? So I don't know what's going on with my children, but the RV had a decent component to it. And while I was unconscious, I was screaming very loudly, and no one could hear me because I needed someone to get the children out of the car. At the time, their father told me was in Houston, about 350 miles away, and it's in the middle of the night. Keep in mind, this happened around 9:30, and he didn't get that call until around 11. So, if any of you have children, you can imagine what he felt. And I will never be able to take that pain away from him. And I was blessed to never know it because I wasn't. So that night, I knew that my life was going to change. I didn't know how my children were. And I was, yeah, not that loud. I was surrounded by people with terrible bedside manner. Honestly, I look back on it and it kind of makes me want to send my daughter there to teach people how to act. I was in the hospital, in the ICU for about 3 weeks, where I developed a stage 5 pressure sore in my sacrum. And when I got to that point, I was asked by a nurse, well, why didn't you tell us to turn you? And I said, well, I've never been paralyzed before, I apologize. So couldn't possibly have known that. This is February 21st of 2020. Pay attention to that time. The hospital shuts down the next week. I can't see my children. I'm in the hospital till June 17th. So you've now taken my livelihood. You've taken my ability to see myself for who I am. You've taken my children. And you've asked me to fight to live. Does anybody in here want to fight at that point? Probably not. And I know I didn't. But when I got out, I did what I do best, and I started researching.
Macy, because you told me something I actually would want to highlight if you can.
Sure, anything.
You just said that there was a time in there where you were suicidal or you felt like you couldn't get out from that
I
pit.
wouldn't say I was anything but suicidal.
And then you had a moment, you said, where you were allowed to visit with your children
They
on the
snuck
roof.
them into the hospital on the 4th floor of the roof. Now, somebody squealed on us, so I didn't get to see them again. If I knew who that person was, I'd find them. But that was the point that it changed for me.
Yes.
Because I saw myself as a burden on society. I was a very independent person. I wouldn't even ask you to, like, grab something off the ground for me. I was just that kind of stubborn. So
And what did your children say to you?
they wanted me to come home. They wanted their mom. So my priest asked me a question. He said, what are your goals when you leave here? And I said, I just want to be able to hug my kids. It was very simple. So I'm going to skip to something that I think you guys probably just need to hear. I do a lot of advocacy. I sit on several boards. I travel around the country advocating for you. If you're in the United States, I'm fighting for you right now, just like this man right here. We are constantly trying to get spinal cord injury research funding for you. But what we need from you is to understand that you're not just touching us, you're touching every single person that touches us. When you change my life, you change their life, and every single person they come into contact with. And that's not me trying to talk about the God complex again, because I could do that all day with surgeons if you really want to. Attorneys are that way as well. So, you know, I will own that. But you have this unique opportunity in this amazing brain. You too. You have an amazing brain. I've watched you for the past 2 days. I like you. I don't know you yet, but I like you. But the work that you're doing, it's like, yes, you guys are talking about all the different ways you're doing it. Congratulations, you're already doing it. Now, where's the gap? Is us helping you get to market faster, letting people know that these technologies exist, because the truth is, I had to fight to know you were even alive. No
Chelsea,
one told me.
what coping score do you think that Macy would have on her? Yeah,
Oh,
so-
who's Chelsea?
Yeah, so.
Hi, Chelsea. Hi.
Would it be okay, you guys, if I invited anyone to ask you guys some questions? Would that be okay? Okay. Doesn't
Bradley had a question.
Okay, Mark.
When this happened to you, you look at it in the third person sense in terms of, I have a spinal cord injury, but it doesn't have me, like I'm going to have a spinal cord injury, or you're looking at it in terms of, wow, I have an injury, now I have to suffer with the injury, or you're looking at it in terms of, I'm going to make this work for me. Like, I'm curious, because three of you have very different stories. I think I connect with Macy on some of what she went through, except hers was a lot worse.
Sorry about that. Yes. Yes.
Chris. Chris?
Yeah, Chris, I have no idea. I mean, you're able to
You're a superstar.
I know you're not the case of the worst before.
Oh, yeah.
So I'm curious what yours is. But the one I'm really fascinated with is the man in the corner.
Let him answer. You asked him first. Let him answer.
So one thing I was saying right before we stopped was that when I went to the therapist with my sister, the best advice I got from the psychiatrist, who's a pain specialist at UCLA, she said, Chris, you're not going to be able to gauge how you are going to handle life or get over this depression you're experiencing until you know how much function you're going to get back. And I was at year 2 of 3 years of surgeries. So that was a great, gave me a window of time to reassess. But honestly, it wasn't until I got off all the pain meds that I was on for 5 years that I realized that my thinking wasn't me and my injury. It was the gabapentin and the methadone, mostly gabapentin.
Get off of that.
I could not pass a window, and this is no lie, for 2 years without having the impulse to jump through it. Every damn window, and I didn't. Because I have family, I made a promise. I promised myself that I would never do anything or fully, I would never really contemplate it fully until I knew my thoughts were mine, and I would do it at least a year after I'd gotten off all pain meds, knowing that they lived in my system for a while and I want to get back on my own feet. But literally 2 weeks after I got off Neurontin, 80% of my suicidal ideation just dropped away. And the rest took a month and a half. And it's like someone said to me this, you had your pilot light blown out and you're smothering in your own gas. And that's 100% accurate. When I got off that stuff, my fight and desire to live just came bounding back. And it was humiliating for me to live for those 4 or 5 years thinking it was all me that was doing it. I thought they were all my thoughts. Because it's natural, my life got fucked. I lost my career, I just signed on for a TV show, I lost my house, lost my girlfriend. This and that and that and this, but getting off the meds, I finally got to light up my day again and find ways to adapt and get curious.
So I just want to add to that real quick. So neuropathic pain is like the worst. Do you feel that those medications were a bridge and you were just kept on too long because physicians said, you know what, I'm making money, he's coming every 6 weeks to get his methadone? Or do you feel that it was managed appropriately? Because I've written for a lot of Neurontin and I'm going, oh my God. You know? But I know it helps a lot of patients at the same time.
I was kind of John Wayning it, I was thinking, I can take another drink. It's, I'm a big guy, I can handle anything. Because I thought that it was better than just dealing with the pain. But in retrospect, I wish I'd never got on. I knew how to handle pain. I just would have to bear it and figure it out.
So if you would have had a psychologist had explained to you
I did.
how you were having the pain.
I finally found one, and I was getting out with my brother, getting off of meds. He said, Chris, and he was a psychiatrist, he said, get off all the drugs. Wake up before the sunlight, go to sleep after sunset, get working again. Best advice I got from any doctor. Hands down.
I want to second that. Get off of all of that nonsense. They had me on 27 pills when they sent me home.
Right.
Seriously, 27 pills. Who does that? You have to understand, like, it messes with your psyche. And you're asking us to keep our nerves alive as long as possible, right? Because that helps you do your job. Why are we taking medications that make our nerves go to sleep? It's counterintuitive.
Well,
make it make sense.
There is that acute hump, though, where we worry about patients being suicidal because they're in so much pain.
Yeah.
So you need, but what I'm saying is I think if the proper phrasing was done, this is short term.
If a 6-month window is proposed, something like that, like even though I'm still having nerves regenerate and whatnot,
right.
Some kind of a window and framework.
Right.
I actually was put in the psych ward on my anniversary day of my injury because I was going to the pain doctor to get drugs and didn't want to be there. And I was with my sister and my mother. It was just a strange situation. My doctor saw my face, said, "Are you depressed?" I said, "Of course I'm depressed."
So let me ask you a question here. If I started, let's pretend you guys are my patients, and I say, you know what, you're in an awful amount of pain. I'm going to help you with it, but I can't take it away. And that pain is a signal to your brain that, you know what, you have healing that needs to take place.
Yeah.
Do you think that would have
Yeah,
changed the whole situation?
I did a course, a 1-month training course on dealing with pain, which was hugely beneficial.
Okay. So the answer to the question then is basically
training.
Yeah, if you were told it wouldn't eliminate your pain, it would take a steak knife and make it a butter knife. You're still going to feel it every now and then. It's still
Yeah.
going to cut you, but it's not going to kill you, and it's going to be limited. And,
If I want to live as a zombie and stab with a butter knife,
but there's still that
I'd
initial.
rather be
so
stabbed
from
with
a
a steak
physician
knife than be
standpoint,
alive.
we're handicapped.
Yeah, I know, yeah.
I don't know, I guess I agree, and then I see it differently.
Right.
I want to feel my body even when it's in pain. That's my body telling me something is wrong, and it gives me an opportunity to find a way to correct it properly, and instead of putting a Band-Aid on it, I'm creating a long-term solution.
Were you given the option?
Oh, 1,000%, still am. Every surgery
Okay.
I've ever had, I've been sent home with pain meds. I've never taken one.
Do you feel if you're given the option of pain, like knowing you have pain medications, I think it's easier not to take them for some people?
No, I think that some people have addictive personalities, and
Right.
that runs in my family.
Okay.
Compulsive gamblers, drug addiction, name it. I think we all have that in our family somewhere down the line. But I would suggest, that's why I said I suggest it differently. It's not to say it's not a necessity in the interim, but number one, let's be cautious about bare minimum standards. Like, we don't need to go ham on it and everybody's getting Klonopins, right? You know, let's talk about what's the bare minimum to get people sustained and stable. And then when they're sent home, let's give them capable therapies that can put their bodies in a better position to heal, because I need to be in my best physical self for you guys to do your job. And if I'm not well, it's gonna like leak into my psyche. I'm gonna start making terrible decisions for my body, and my long-term sustainable growth, nerve transfers or otherwise, that's moot. That it's not even worth talking about.
Right, so here's the killer question. Were you guys ever offered any alternative therapies in terms of TENS units, lidocaine patches, anything like that? Or they just went straight to heavy meds?
They tried to give me fentanyl patches.
But what I'm saying is, were you given options to escalate it? Or,
Yes, every single
So
time.
you were given the full range of stuff?
Yes, I had
Because it's a real
access.
dilemma from our end in terms of, I have a patient that, I mean, I know if I have a toothache, oh my God, it could be the end of the world if I don't have something. And I take pain, other types of pain perfectly well, so
But
it's
I
very
think
difficult.
that goes to what Karen does as a psychiatrist, right? Like, you have to weigh that in the balance.
I
when
hope
you're-
so.
No, you're weighing it in the balance with every patient that you see. Is this something that they need necessarily, or do they have a predisposition to abuse what I'm about to do? And so when you're trained properly, which I know that you are, you'll be able to make that judgment call, but we don't always know ourselves very well. And as Chris so elegantly stated, we are in the trenches in those moments, right? So we're not making the best decisions for ourselves. We're dealing with
It
big issues.
doesn't make a difference how well trained you are to a certain extent.
But you need to be
Because,
able
I
to use
mean-
that discretion. And sometimes that's just blind faith.
Right.
Like, we have a conscience, we all have something inside of us that tells us what's right and what's wrong, and then we make a judgment call based on that, right? So you're using discretion, and you have logic, and you can see, you have eyes. So you're gonna have to use all of your capabilities to come to that conclusion, and then your patients are gonna have to trust you. And by the way, Bradley, that's a mutual thing. Like,
Oh,
I
I
talked
agree.
to you about this. This is
Right.
team effort.
Right.
If your patients aren't being honest with you, then you can't give them the best care. So this is a two-way street. I'm not punting. I'm just suggesting that there are other avenues, and we need to consider them all for the purposes of the longevity of the growth of what we're trying to accomplish.
Would it be okay if we heard from Katie wanted to ask a question?
Yeah, no, just a quick question. I'm conscious of time, but thank you for sharing your stories. I'm a plastics resident from the UK. I would love to hear just from each of you, after this pivotal moment in your lives, how do you, this is probably a bit vulnerable, but how do you feel like your identity and your purpose in life has changed since your accidents? I'd love to hear from each of you.
Couldn't quite get your question, but let me tell you, just you said dealing with pain.
No, away
I'm
from
sorry,
pain,
excuse me.
your purpose of life. How do you feel your purpose in life has changed since your accident?
Yeah, to an extent. My wife and I try to help other people who have had similar differences, different problems. There's a patient right now in ICU who was injured, I can say this because it was in the newspaper, but she was injured in a triathlon on a bike ride. And I'm spending a lot of time with her family because I'm trying to say, I can't say. But anyhow, her family is trying to feel like, how am I going to deal with this? How are we going to help her? Where is she going to live? What does she need to adapt to? And I've given them things. And what I have to do next time on Wednesday when I have to come in for a meeting is bring some of the stuff that I use that makes it easier for me, that I can use to type, that I can use to write with, just simple little devices that somebody came up on their own. There's something that we use for putting on a button that somebody made out of a paper clip way back when, and you just, grab the button with a paper clip, and it's somebody's caregiver figured out a way to do it. And that's the great thing is people figure out, and you on your own, you figure out the way to do things. I figured out ways to open and close doors. I put a rope on them. You want to pull it closed, you pull a rope on it, or you push it closed. And we all do, in similar ways. You may have to do it a little bit differently than somebody else, but you figure out a way to do it. And that's what's really important, so that you can do it on your own and you don't need somebody's help.
So I'm going to want to pivot for a moment. Joanna Wangdell comes from a center that seems to be a bit more integrated than what most of our centers in the U.S. have. And she's going to share how they do it there. And then what I want to do is keep you guys around so that we can then talk about what can we do better here in the U.S., kind of follow up on these experiences you've shared. If you have anything else to close out before we pivot on, we can do that as well. Two of them.
Oh, wow. This is serious.
Hello.
I have two microphones. I think that's enough.
While she's setting that up, I just wanted to say thank you.
Okay. Feels a bit strange to talk about this now after you have shared about your journey. I come from Sweden. We have a different... could you please turn around so I can see you? It feels like I'm talking. We have a different healthcare system, which all, of course, influence our work. So if a person with an SAI is getting in rehabilitation for roughly 6 months, so they have time to develop all these things, the techniques, the mental health things. They get assistance to go through this process. And we meet them, as a surgery team, we meet them in their first initial rehabilitation. So we can do this together with the team, together with the patient, together with the relatives, in another way. Sahlgrenska University Hospital is a big hospital. And my center we do all the tendon nerve transfers for tetraplegia in the whole Sweden and in Iceland. And we also do spasticity surgery in our region, which we need to decrease because we can't take care of all our tetraplegic patients. We have 5 beds in a specialized ward, and we have our outpatient clinic there, and we do all the therapy in the same session. And we try to make it look less
as a hospital, because many of you are not that interested in coming back to hospital once you're released. So we try to make it slightly less hospital-ish. Our team is just me here today, but we are 3 surgeons, 2 physiotherapists, 4 occupational therapists, and we have administration support. And we all also involved in research. So 2 of us are associate professors. We have 2 additional PhDs. We have 2 PhD students, and we have a master student. So we really combine our clinical work with our scientific work. Since we are the only clinic, we need to collaborate internationally, and this is just examples. I would just want to highlight the international Tetrahand course that we are running together with Knotville, and we've been doing since 2011. We just decided that we will do one next year in October. So I would like to invite you all to go to that course, both the therapists and the surgeons. I think it's important to remember that we have a really long tradition to do this. Erik Moberg started when he retired in the 1970s. So we have had a long time to develop our relationships, our routines, and so on. And we also have had, through this period, a lot of scientific workers together with our clinical engaged team. We do a lot of team consultations. And as you can see, I will explain this about the satellites a bit later. You see that we do way more now, the last years, and this is when we have centralized even more our organization. The same thing with the number of surgeries. Nowadays we do about 80 surgeries a year on tetraplegic patients. And we also increased that when we have slimmed our organization a bit. What type of surgeries do we do then? When it says grip reconstructions, it's tendons. We do a lot of spasticity, triceps reconstructions. As you can see, we have done nerve transfers for about 10 years. And we do a lot of minor adjustments as well, which has increased. And I think that relates to the nerve transfers who need adjustments in terms of mostly stability after. So how do we do this? This is our overall process, and I will walk you through each step. The pre-assessment. As I said, in Sweden there are 4 units where all the SCI patients come after their injuries. And we go there, and we see them there. And as you said, it's not always that easy to make the wise decisions or even to explain where you are at that moment. So it's really nice to meet the team around and have that discussion together. So we go to different places many times a year, and we also go to Iceland. So we're traveling people. And we always go together as a team, and the patients see the therapist first, and we do a little bit of look at the motor functions, but we mostly look at where are you? How depressed are you? What's your social situation? What's your home situation? Because if we do nerve transfers like 6, 9, 10 months after injury, in Sweden that is when you come home. That's when you realize that the reality is just in your face. And then we come and do nerve transfers. And we have to be aware of where are the person so we can do the best of it. Or maybe say, we do it later. After, and quite often, so we see the patients like, depending on when we come, so sometimes we meet them like 2 weeks after injury. And we just say, hi, we're gonna meet you later on, but just so you know, if nothing else happens, there are things we can do. So we give that little of hope. And then we see the patient again. So after then, the decision that we were gonna do something, we're gonna do surgery, we have pre-digital meetings. So OTPT have a meeting with the patient and make sure that they have the care that they need. They're not in the middle of rebuilding their house. And they have the technical aids that they need. But also the preparation of how will I do my transfers after surgery? How will I catheterize myself? How will my eating? Are we going to immobilize your best hand? So we have solved all those problems before surgery. So after surgery, the patient can focus on the surgery and not being nervous about getting home.
I was saying, what's the furthest out from the injury that you guys will perform a surgery for a nerve transfer?
For nerve transfers, it depends on, again, if we stimulate them and it works, we have done surgery, nerve transfers 20 years after the injury. And tendon transfer, I think the record is 39 years after injury.
I don't know what the average is in the United States.
No, me neither. But I guess since we have met all the newly injured patients in Sweden for that many years, we have that uptake and people tend to do the surgeries early. The nurses also meet with the patients before they come to really make sure that we have all the preparation at the ward that they need. How do they manage the bowel? How do they manage the bladders? How do we make this smooth during the inward time? So then we go to surgery. It's always in our unit then. We don't travel to do surgery. Oh, well, from Iceland, we do some surgeries there. So for tendon transfers, the patients come on Monday, we do surgery on Tuesday, we do the training Wednesday, Thursday, and they go home on Friday. And as you know, we start the training early.
And the training is activation of the transfers, right?
Yes. So day after Wednesday we call it the crying day. Because we come in the morning, we take off the plaster and say, we're going to move your hand. And when the patients and the relatives, they see that they can move their hand, they cry, the nurses cry, we cry, everyone cries. Nerve transfers is slightly different since we don't need the training afterwards in that case. So they come on Wednesday, we do surgery on Thursday, they get some instructions on when to meet us afterwards and how they can start doing things, and then they discharge. Tendon lengthening is the same thing as tendon transfer. They come on Monday, they do surgery, and they do the training. And they start early. I already talked about the concept, so I will just skip that. The rehab later on then. For tendon transfers, grip reconstructions, they come back after 3 weeks for 5 days of intensive rehab. And with intensive rehab, I mean 4 sessions a day, 1 hour each. So that is kick-starting. For triceps, where we have restrictions for a longer period of time, they come after 7 weeks when we release all the restrictions. So we actually can do the transfer training and those things. And they come usually for 3 days. And then we send them back to the SCI units who can train them more. Nerve transfers, we do digital meetings with them 3, 6, and 12 months. And there we call them, we ask them to call us as soon as they see re-innovation, so we can guide them further at that point. And after re-innovation, we see them digitally, usually, since they're from all over Sweden, like 4 to 6, I would say 8 weeks, to just keep on motivation, adjust the training. But you also have to remember that we usually then also do tendon transfer with them later, so we see them due to the tendons as well. And for the tendon lengthenings, since spasticity is so diverse, we have, as I said before, Therese Ramström has developed this program that we have, that we use with the high-functioning patients who have a lot of voluntary function underneath, and they can use their hand in one-hand activities. They get more rehab. They get 5 days after 3 weeks. Again, 4 sessions a day. Then we have the low-functioning patients, that more of an assistant's hand. They don't have that much voluntary function. They get 2 days with intensive training after 3 weeks. And then we have the non-functioning patients, who is more of an hygiene thing. We see them just a team visit. So it depends on how much voluntary function they have. And then we do follow-ups 3, 6, and 12 months after all the tendon surgeries. And then again, we go out to the satellites. And this is really useful for us. It's way easier for us to travel than 15 tetraplegics from Stockholm coming to Gothenburg. It's easier for us to travel. And it's also education for the SCI unit. And building relationships. So if they have their newly injured patients, they can call us and we discuss what to do. And again, then we do a therapist session first, where we can guide the patients further, and we do some follow-up testing. And then we go into the surgeons and we make a team meeting afterwards. This is a busy slide. I just want to highlight that we meet our patients for a long time. So you see it's the months after injury. And then you see if we do, we say that this is a C6 complete, C7 complete injury, which hardly exists anymore. We do a nerve transfer, we do a nerve transfer really early, and we do the follow-ups according to that. But then for the left hand, we might do a tendon transfer for triceps at the same time. And then after 6 months, we do the triceps on the other hand. And then we do the grip here, and then we do the grip here. And then we do all the follow-ups. So basically, we see the patients all the time for like 3 years. So we get to know each other rather well. Predicting out, I just want to mention a little bit about predicting outcome, because that is so important for our patients when we discuss that. And we relatively recently published this, because we felt that even if we do this exactly the same tendon transfer, finger flexors, we get different outcomes. And it's difficult to tell the patients what to expect. So we looked at level of injury, or the ISHT scale, International Classification of Hand Function, and we looked at gender. And with this, and we collected data together with New Zealand. So nowadays, we can better tell our patients beforehand what to expect. And the same thing with the CUPM goals, the activity goals that the patient sets before surgery, that we follow up at 6 and 12 months. We have classified them into different activity groups, ICF groups. And what we can see is that we have improvements. You're not supposed to read this. but just to see the bars, that we have improvements in 6 and 12 months in various different activities. And this is so important to discuss with the patients beforehand, what to expect, what can we achieve. You will not play the piano, and so on. Yeah, we also looked at our prioritized activities over the long term and make sure that we actually get improvements in daily life for our patients. And with that, I would like to say thank you.
Don, I wanted to hear about St. Mary's. Does something a little like this? They have, obviously the American system can't just keep people forever like your system does, but forever. For a long time. I'm strongly encouraged to make everything outpatient. Okay. Yeah. But you all have the quantum.
Yeah.
The quantum house. How does that work?
And Quantum House is a hospitality house. It's like a McDonald house that they have that you hear, but this is like a McDonald house on steroids. They get their furniture, they just got their new set of furniture from the Breakers. Quote, lightly used, if you did. They have groups that come in every night and provide food for people, cook meals for them. They bring therapy dogs in. They bring kids in to visit. Last time we were there, they brought fire trucks. They brought the SWAT team one day. But things that just keep the kids busy because some of them are there for a long time.
Do the therapists come over and do this kind of post-op therapy at the Quantum House?
No, they don't. They want to bring them over, Fran can tell you better, but bring them over where the therapists are, you know.
But they can get back and forth.
Oh, yeah, absolutely.
It's actually walkable. So, yeah, we have a shuttle that takes them, but it's walkable over the hill if families want to. So, yeah.
We can try to approach you.
Oh, yeah, well, no, I mean, you know, you can do it. It took us, you know, it wasn't like we started over day and night. It's taken a long time to develop all these things, and like Quantum House went from 10 beds, which used to be working with families who had babies in neonatal intensive care, to therapies that come for a lot of Dr. Paley's patients, that they're there for a long time and they're having multiple surgeries, a lot of therapy. Takes a lot of time, but they do a great job.
John, I think that kind of care is critical for these patients, and I would love to be able to deliver that in a better way. Macy, closing thoughts on?
So Dr. Brown, when he performed my nerve transfers, I met him for the first time in September the same year that I was paralyzed. So what would that have been? February to September. I didn't go to law school for math, so y'all can, do that. And then we just really connected in a way that it was like, we're gonna do this. And how fast can you get back here? Because it's a time is of the essence, which is why I had asked you, what's your outset on that? Like, how far out will you go? And he came and he was like, no, Macy, you were one of those. And I knew because I could feel it. I didn't want to tell anyone in my family what I was feeling because I was afraid. I knew my body was failing. And that really messes with you. We need to be more open about the outcomes, which I think Dr. Brown does a fantastic job of. He's never made a promise that he couldn't keep, and he's always been extremely honest with me about what the uptake is in contrast to the loss. So I knew for all 5 surgeries what I was getting into, and I'm not quite sure that we're done. I don't think I'm ever done with him. I think there's always improvement, and so you might see me here again soon. But I want to be a little more clear with the doctors in the room, and I don't know who you are because everyone looks the same. You guys, I want to reiterate the teamwork because I kind of touched on it, but you have to find a way to connect with your patients in a way that they want to do all the things you're asking them to do. that they feel that you're as invested in the process as they are, and they're not just another number. I mean, I am the product of collaborative medicine. You know, I have nerve transfers, I have a tendon transfer, I have an epidural stimulator. I've traveled around the world, I've seen some things. I understand what everyone's trying to do here, but just like we're stronger in numbers when we're kicking and screaming at Congress, you're stronger in numbers when you guys are collaborating and sharing information like you're doing right now. Hoarding information is honestly just the worst thing for the future of what you're going to accomplish and what you've already accomplished. And the more that you guys are open about the work that you're doing, the more people like me don't have to sit there on the internet 24 hours a day for months trying to go, this can't be it. That's the worst, is someone telling you every day, this is all you're ever gonna be, right, Chris? This is all you're ever gonna be. So, you know, get your affairs in order, tell your family to contact that nursing home, and, you know, keep it moving. But we're better than that. So I resolve to you, like Chris did, like what Don's doing, we're gonna keep doing our job. We're gonna keep speaking up and making sure that people know about the interventions. We're gonna continue to help people in our community pro bono like we do. But in return, my ask, my very specific ask, and honestly, it's why I'm here, keep talking. Keep talking, keep being very loud about what you're doing. I'm not social media adept. I'm just not, like I try really, really hard, but I'm 43 and it just doesn't work. But I'm still out there saying things in a very uncomfortable way, because even if it makes me uncomfortable, I know that there's somebody right now in a hospital bed that's begging to know you exist. And you're gonna save their lives just by existing before you even touch them. So I'm gonna leave you with that. And I wanna thank Dr. Brown for everything he's done for me and my family.
Like was said before, is listen to your patients. Give them the opportunity to participate. And I know it's hard. I mean, you guys are probably getting inundated with so much, especially with the internet and people's ideas and things like that. But give them the ability, give them the respect to listen to them, and you can argue with them. You know, tell them, I'd like to see more data on that, or whatever it is that you need to hear. Because like my docs at the Mayo Clinic, they actually listened to me. I had to convince them, but they basically did a Oberlin to tricep, which at that time was never written about before. But I suggested right before they put me under, and then I kept on at it for 6 months until I finally did, because I said I was going to India to get it done. And so they did it, and they saved my tricep function. So for me, that was a big win. I felt like I was actually taking care of myself somehow. That kind of stuff makes a difference in someone's life. And that's what's got me here, actually, that kind of solve the problem, find a way, don't give in.
One thing real quick that you can do too that fire chief taught me. I have my phone set so that if it goes off, it doesn't interrupt you, it just flashes. So my pants are not on fire. But that, you know, little things that you can do, this anybody can do for that. Just so that, you know, in the middle of a meeting, you're not beeping all the time, which is kind of nice, especially if you're in visiting a patient and you want the patient to pay attention to you, not their phone.
Well, I think we're going to close it out with that, unless there's any more burning questions. But thank you all for your participation. I've enjoyed myself. I hope you have too. Thank you guys for participating too. Thank you, Mr. President.
Hello, everybody. I just wanted to say that I think this has been an absolutely splendid conference, and I think we all owe a great deal of thanks to wherever he's gone. Oh, over there, whatever his name is, I've forgotten right now. And I'm sure Karen had a lot to do with it as well.
You know who needs this? April. Where is April?
April?
Holy mackerel, April.
Hey. Yes,
Don't you dare give me April's credit.
The science was fantastic, but I think the biggest and best part was this afternoon meeting the patients and hearing from them directly. That's never happened before, which I need to talk to Justin about to find out why, and the mental health aspect as well. So thank you guys for coming along.
For anybody interested, tomorrow is the more spirituality and medicine day, and it's over in the business building, and anybody who's been here is welcome to come there, and it's going to be, what, it was 8 a.m. to... Oh, I'm sorry, the award. Where's Dom? Is Dom still here? Hey, Dominic, who gets the award? Thank you for that. What's that?
Right. I'd like to offer my thanks to Justin and the team for putting together such an incredible meeting. I'm going to announce the winners of the presentations. So there are 3 prizes. So in reverse order, third was psychological coping and motor recovery after upper limb nerve transfer surgery in the cervical spinal cord injury from Chelsea Harstad. So congratulations. Second place, recovery of elbow extension with the auxiliary to radial nerve transfer techniques and outcomes from Margaret Sten. And it was a very close run. In fact, there were only about 2 marks between 6 of the presentations. I won't tell you who they were. So, but first prize goes to Maya Brinster for CES improving functional reinnervation in a human primate model of radial nerve repair. So congratulations. And if I could just have 30 seconds of your time. I was passionate about nerve surgery and battled for many years to get anyone in the hospital, in the government, in the NHS in the UK to recognise that we were a developing specialty. And I spoke to industry friends and colleagues over the years about how important it was to educate and to teach people about nerve injuries and opportunities for reconstruction. And with the help of industry partners, initially with Axogen and Eric's backing, and later on with multiple commercial partners, we've established something called the Global Nerve Foundation, which is a truly international organisation for patients, all those healthcare professionals that are involved in nerve care, whether it's nerve pain, whether it's paralysis, brachial plexus, and so on. We're about 4 or 5 years into the journey. We're growing, run regular educational events, courses, and webinars. There are research grants available, and there's a huge amount of awareness activity going on. Anyone that wants to get involved, this is a QR code for free membership, and the GNF obviously is open for everybody. I just wanted to extend the invitation. Those patients affected and afflicted by nerve injury as well, we need everybody involved so we can continue to have this narrative about improving outcomes for patients with these often devastating injuries. But thanks very much.